स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं
A very good morning to all the delegates and faculties. It's my privilege to welcome you all on the fourth day of the Appec 22. Indeed, a very smart way of learning. I'm sure you all must have been enjoying and benefiting in the academic feast. So without delay, let's start today's first lecture, which will be chaired by Dr. S.K. Singhal. Dr. S.K. Singhal is a senior professor and head Department of Anesthesia and Critical Care in PGIMR, Chandigarh. And his area of special interest are difficult airway, ethics in medical practice, critical care, and communication skill. He has more than 120 publications in his achievement, and he's in charge of the state-of-art Dhanvantri Apex Trauma Center, which is 120 bedded, and he's been examiner and guide to various research projects. And he has more than 200 international national conferences, CMEs to his credit. I welcome you, sir.
Thank you.
Very good morning. Thank you for being with us. Over to you, sir.
Welcome. Good morning, friends. We are starting the today's session. First of all, I wish you all a very happy Shivratri. Today we have a Shivratri also. Welcome, Dr. Amit Dua. Sir, I introduce you the first talk of today. Dr. Amit Dua, we all know he is a known personality in Delhi and also in India. He is professor anesthesiology in the RR Hospital, New Delhi. And his achievements and interests are pain management and regional anesthesia. He is a dynamic person, and so he will be delivering his lecture and deliberation on blood the talk of. I think he can go ahead with the talk. It is blood transfusion and complication related to that. So we will enjoy his task. Dr. Dua, please.
Good morning, everybody. I'll be speaking on blood component therapy and complications of blood transfusion. I come from Army Hospital RRM, Delhi, Kent. So the blood components are separated from the whole blood by blood component fractionation, which is based on centrifugation and flash freezing technology. Whole blood is separated into red cells and platelet-rich plasma by slow centrifugation. Then a high-speed centrifugation is applied to PRP to yield 1 unit of RDPs and 1 unit of FFP. FFP yields cryoprecipitate via a slow thaw process to precipitate the plasma proteins, which are then separated by centrifugation. This is the diagram showing the same thing. Whole blood gets into packed cells by centrifugation. PRP is centrifuged again to release the platelets. Then the platelet-poor plasma becomes the FFP, which is thawed to release the cryoprecipitate. So the packed cells, 1 unit of packed red cells has got hematocrit of 55 to 75%, hemoglobin of around 20 gram per deciliter, volume of 150 to 200 ml, which is stored at 2 to 6 degrees. Average shelf life of a packed RBC is 21 to 42 days, and it should be transfused within 4 hours of rewarming to the room temperature. In a hospitalized patient, hemoglobin of less than 7 gram per deciliter, we need to transfuse the patient with a packed cell. While if the patient has comorbidities like coronary artery disease, chronic renal failure, and congestive heart failure, even a hemoglobin of more than 7 gram per deciliter, we can transfuse. During perioperative period, hemoglobin of less than 7 gram per deciliter, patient should be transfused. And for patients who have got organ ischemia, increased potential for ongoing blood loss, or volume status and risk factors for complications of inadequate oxygenation, we should transfuse these patients. And any symptomatic anemia with normal blood volume should also be transfused. Coming to FFPs, they contain stable clotting factors, immunoglobulins, and IgGs and albumin. Volume is around 200 to 300 ml per unit. They are frozen within 6 hours to minus 25 degrees Celsius to maintain the coagulation. Can be stored at minus 25 degrees Celsius for up to 1 year. They are thawed at 30 to 37 degrees Celsius before transfusing, and transfusion should be started within 6 hours of thawing. Indications of giving FFP is active bleeding with documented coagulopathy in form of INR beyond 2, PT beyond 1.5, and double the APTT. Liver disease with coagulopathy, emergent reversal of warfarin effect, DIC, dilutional coagulopathy due to infusion of large volume of transfusion, replacement of single factor deficiencies like factor 11 and factor 5, prophylaxis in patients undergoing surgery or invasive procedures with coagulopathy. The dose of FFP is 10 to 15 ml per kg, and we need to monitor the PT, PTTK, and INR while we are transfusing these patients. Platelets. The pooled platelet concentrate contains 240 into 10 raised to power 9 platelets, while the single donor plasmapheresis contains 55 into 10 raised to power 9 platelets. They are stored at 20 to 20 degrees Celsius, 24 degrees Celsius, with constant agitation for up to 5 days. They should be infused within 4 hours of collection to avoid any contamination because they are stored at almost room temperature, and total transfusion time should not exceed 30 minutes. Indications for platelet transfusion are active bleeding with platelet count less than 50,000, active bleeding with platelet function defect, surgical or invasive procedures with platelet count of less than 50,000 for procedures with minimal bleeding risk, and for CNS or ophthalmic surgery should be up to 1 lakhs. Massive transfusion, that is replacement of whole blood within 24 hours, requires platelet transfusion also, and post-cardiopulmonary bypass with uncontrolled bleeding. Coming to cryoprecipitate, they are rich in fibrinogen, factor 8, von Willebrand factor, and fibronectin. They are resuspended in 10 to 20 ml of plasma. They are supplied in pack of 6 or more. They can be stored at minus 25 degrees Celsius for up to 1 year, and they should be infused within 6 hours of thawing. Indications include fibrinogen levels of less than 80 to 100 milligram per deciliter with bleeding, a patient of DIC, liver disease, massive transfusion, and factor 8 deficiency. They are usually supplied, the dose is between 5 to 10 units, and in massive transfusion protocol, if we've already given beyond 10 FFPs, then cryo need not be given separately. Prothrombin complex concentrate, they are required for urgent reversal of warfarin in life-threatening bleeding conditions and in deficiency of vitamin K dependent factors in settings where no other concentrate is available, like factor 10 and factor 2 deficiency. Coming to the complications of blood transfusion. The blood transfusion complications can be divided into hemolytic transfusion reactions and non-hemolytic transfusion reactions. The hemolytic transfusion reactions will include acute hemolytic transfusion reactions, which can be immune and non-immune mediated. They can be delayed hemolytic transfusion reactions or delayed serological transfusion reactions. Non-hemolytic transfusion reactions can be reactions associated with fever following blood transfusion, reactions associated with breathlessness, or with rash. And there are some miscellaneous transfusion reactions. We'll cover one by one each of them. Coming to acute hemolytic transfusion reactions, the onset is within 24 hours of transfusion. They can be immune or non-immune related. Delayed will be 24 hours to 28 days after transfusion. And then there is a category called delayed serological transfusion reactions. Coming to acute hemolytic transfusion reactions, the patient will present as having fever, chills, chest pain, abdominal pain, back or flank pain. Patient may have GI symptoms like nausea, vomiting, diarrhea, wheezing, anxiety, or dark or high colored urine or a red colored urine. And in the late stages, patient may go into DIC or a hypotension. The causes can be immune mediated like ABO incompatibility, wherein ABO incompatible RBCs are transfused into another patient. The recipient IgM, NTA, NTB, or NTAB antibodies are formed, which cause severe, potentially fatal complement-mediated intravascular hemolysis, or administration of out-of-group platelets like group O platelets to group A recipient. Coming to non-ABO incompatible, IgG antibodies are formed in blood groups like RH, KEL, or Duffy systems, LO antibodies in a previously allo-immunized patient. But they will cause extravascular sequestration where the lifespan of an RBC is shortened and the patient will have similar but much milder symptoms. How do we decrease these reactions? We should have RFIDs for patients, and for samples, there should be pre-transfusion bedside patient identification procedures. Blood bag should be labeled, patient record should be checked. Two determinants of the recipient blood group should be done before non-group O RBC transfusion. Group O whole blood, plasma or platelets should be screened for high titer anti-A antibodies. Coming to the non-immune mediated reactions, they can be due to thermal injury by direct exposure to ice or heat, mechanical injury by pressurized infusions, or osmolar injury when we co-infuse the RBCs with hypotonic solutions. How do we decrease them? We avoid the extremes of temperature, pressurized infusions to be avoided, and co-infuse only with isotonic solutions. How do we diagnose acute hemolytic reactions? Visual inspection of recipient's plasma and urine, retyping of donor and recipient RBCs, direct antiglobulin test, hemoglobinemia, hemoglobinuria, decreased serum haptoglobulin, unconjugated hyperbilirubinemia, increased LDH and aspartate transaminase levels, and decreased hemoglobin levels. How do we treat them? We stop the transfusion, maintain the urine output to a minimum of 75 to 100 ml per hour by the following methods: by administering fluids intravenously and possibly mannitol. If that doesn't happen, we start with furosemide. We alkalinize the urine, assay the urine and plasma hemoglobin concentrations, determine the coagulation factors, platelet counts, return the unused blood to blood bank for repeat cross-match, sends patient blood and urine sample to blood bank for examination, and prevent hypotension to ensure adequate renal blood flow. Delayed hemolytic transfusion reactions. Their clinical and lab features of hemolysis are present, as in acute. Direct antiglobulin test will be positive and signs and symptoms are same, but less severe than the acute hemolytic transfusion reactions. They may manifest as inappropriate rise of post-transfusion hemoglobin or unexplained fall in hemoglobin. Jaundice, hemoglobinuria, or pre-transfusion testing cannot detect the low or evanescent antibody titer. That is why these delayed hemolytic transfusion reactions happen. What are the causes? Exposure of foreign RBC antigen after transfusion or pregnancy. 3 months are required to produce detectable levels of these antibodies. If no further exposure to these antigens occur, the level of antibodies become undetectable in 50% of people in 5 years. Upon re-exposure to the same antigen, antibody response can occur in 3 to 21 days, which peaks between 7 to 10 days. We manage them by a direct antiglobulin test, antibody identification, and just give supportive treatment to the patient. So they should receive antigen negative units once LO antibodies have been detected in any recipient. RBC antibody screening test can detect these antibodies. We should have a centralized patient information database which can help patients who undergo transfusions at multiple centers. And in a sickle cell disease, they mimic a vaso-occlusive crisis. And there is something known as hyperhemolytic transfusion reactions, wherein lower post-transfusion hemoglobin as autologous RBCs also undergo the hemolysis. Delayed serological transfusion reactions. Here the LO antibodies are only identified serologically without detectable symptoms and signs of hemolysis. Now we finished. If we look at this flow chart, we've finished the hemolytic transfusion reaction part. Let's come down to the non-hemolytic transfusion reactions. Reactions associated with fever following blood transfusion. The definition of a non-hemolytic fever causing reaction is fever more than 38 degrees Celsius and a change of more than 1 degree Celsius occurring during or within 4 hours of transfusion without other causes like hemolytic transfusion reaction, bacterial contamination, or any other underlying condition. The other possible symptoms in a febrile reaction would be chills, rigors, anxiety, tachypnea, or headache. This is usually a diagnosis of exclusion, and it is usually caused by pyrogenic cytokines and intracellular contents released by donor leukocytes. The differential diagnosis is hemolytic transfusion reactions, so we need to screen here for auto or LO antibodies. We need to conduct a Coombs test, which would come out negative. We need to confirm bacterial contamination, if any, by finding out if there was any inadequate sterile preparation of the phlebotomy site, opening of the blood container in a non-sterile environment, the presence of bacteria in the donor circulation at the time of blood collection. or if the patient is already having septicemia or dengue. We also need to rule out transfusion-related acute lung injury by making sure there are no signs of acute lung injury or breathlessness. The etiopathogenesis of this can be recipient WBC antibodies which react to donor HLA or other antigens, or a cytokine released from the WBC and its accumulation during storage. Non-leukocyte-reduced platelets and RBC products can cause these type of reactions. These type of reactions happen the least with the plasma. So the solution is either pre-storage leukodepletion or a leukoreduction helps decrease these antigens. Use of platelets, which can be stored in platelet addition solution, will also help decrease febrile reactions, and decrease in total plasma content results in fewer donor-derived cytokines or donor-derived antibodies against patients' WBCs. Now coming to reactions associated with breathlessness during transfusion. They can be of three types: transfusion-related acute lung injury, transfusion-associated circulatory overload, or transfusion-associated dyspnea. Coming to transfusion-related acute lung injury / circulatory overload, the transfusion-related acute lung injury can be anti-leukocyte antibodies causing leukopenia and fever. The pulse and BP of the patient would be either normal or low, and they are usually caused by plasma and plasma-containing products like plasma and platelets. While a circulatory overload, as is very obvious by the name, is because of fluid overload presenting with raised AVP, tachycardia, and hypertension. Leukocytes would be normal here, and BNP would be raised. So how do we differentiate between the two? In TACO, we will find new onset or exacerbation of 3 or more of the following within 6 hours of cessation of transfusion, like acute respiratory distress presenting with dyspnea, cough, or orthopnea, elevated BNP, elevated CVP, evidence of left heart failure, evidence of positive fluid balance, and radiographic evidence of pulmonary edema. While in TRALI, there will be no evidence of acute lung injury prior to transfusion. Acute lung injury will onset during or within 6 hours of cessation of transfusion, and it would present with hypoxemia defined by any of the following methods: PaO2 by FiO2 ratio of less than equal to 300 millimeters of mercury, oxygen saturation less than 90% on room air, and radiographic evidence of bilateral infiltrates without evidence of left atrial hypertension, that is circulatory overload. So TRALI usually occurs is a non-cardiogenic pulmonary edema occurring within 6 hours of transfusion. The signs and symptoms would be fever, dyspnea, fluid in the endotracheal tube, severe hypoxia, and under anesthesia, patient will present with persistent decrease in oxygen saturation. Chest X-ray will show pulmonary edema. Risk factor is receipt of FFP or whole blood from females, especially multiparous donors, high interleukin-8 levels, liver surgery, chronic alcohol abuse, shock, higher peak airway pressure while being mechanically ventilated, smoking, and positive fluid balance. Pathogenesis of TRALI can be pulmonary edema without circulatory overload. There are two hypotheses. The antibody hypothesis is the first one. Herein, the HLA antibodies and HNA antibodies in transfused component react with the neutrophil antigen in the recipient. The recipient's neutrophil lodge in the pulmonary capillaries and release mediators that cause pulmonary capillary leakage. Coming on to the other theory, that is neutrophilic priming hypothesis. Here, the patients with this condition like infection, surgery, and inflammation predisposed to neutrophilic priming with endothelial activation. Bioactive substances in the transfused component activate the primed sequestrated neutrophils, and pulmonary endothelial damage occurs, leading to a TRALI-like situation. How do we decrease these reactions? For TRALI, we exclude female donors for plasma, especially with a history of pregnancy or known anti-leukocytic antibodies. We collect plasma only from male donors and use platelets which are suspended in additive solutions. For TECO, we identify patients who are at risk of fluid overload. Newborn babies and elderly cardiac patients are more prone, and use diuretics whenever we feel we are facing a circulatory overload condition. Now coming to reactions associated with rash following blood transfusion. They can be allergic and anaphylactic transfusion reactions, like plasma protein allergy presents within hours of transfusion. post-transfusion purpura, which appears late, 5 to 12 days, and associated with transfusion of cellular components mediated by development of antiplatelet antibodies. Transfusion-associated graft versus host reaction, which appears 1 to 6 weeks after transfusion and is characterized by fever, rash, liver dysfunction, diarrhea, and pancytopenia. So these are type 1 hypersensitive reactions. The symptoms will vary from urticarial rashes, pruritus, angioedema to anaphylaxis, and which may be characterized by hypotension or respiratory compromise. It can be multifactorial, donor, product, or recipient factors may be there. Plasma proteins are most commonly implicated, especially in plasma and platelet transfusions. There may be atopic predisposition with high immunoglobulin E levels. There may be deficiency of specific plasma proteins like IgA, heptoglobulin C3 and C4. It can be food or medication exposure if present in donor plasma like peanuts and aspirin. How do we decrease these reactions? Patients with severe allergic transfusion reactions may be tested for absolute IgA deficiency and presence of anti-IgA antibodies. Use IgA deficient or washed components for such patients. Prevent such reactions using plasma mitigation techniques like platelets stored in platelet additive solutions, solvent detergent plasma, or washing blood products is most effective. Giving IV immunoglobulins at 1 gram per kg single dose may help increase the platelet count in platelet transfusion purpura. Transfusion of antigen-negative cellular products like platelets for subsequent transfusions, and preventing transfusions for first-degree relatives and irradiation of blood products to prevent transfusion-associated graft versus host disease. Coming to other transfusion reactions, they can be transfusion-associated hemosiderosis, which happens in cases of repetitive transfusions like blood ferritin more than 1000 microgram per liter with or without organ dysfunction. The treatment is by using the chelating agents. There can be transfusion-associated hyperkalemia when high potassium levels more than 5 millimole per liter or 1.5 millimole per liter net increase within an hour of transfusion is noticed. The treatment is use of RBCs which are less than 5 days old and use of washed RBCs. Other mitigation strategies, single best modality for prevention and risk mitigation is avoiding an unnecessary transfusion. Right product to right patient at the right time is a dictum to follow. Safety of restrictive approach is always there. Adopting non-transfusion alternatives when possible, and perioperative blood management strategies like intraoperative cell salvage, acute normovolumic hemodilution, antifibrinolytic agents, viscoelastic point of care tests to guide transfusion decision, and avoidance of unnecessary transfusions will really help decrease such reactions. So we have to be proactive in identification of high-risk patients. We should be very strictly adherent to recommend clinical processes. We should be aware of the transfusion pathophysiology. We should be able to promptly diagnose, response, and treat the reactions. This is one chart which really helps us diagnose bedside or by the simple lab test as to how to deal with a suspected acute transfusion reaction. So the first step is to stop transfusion, make sure IV line is working, confirm the correct product for the patient, assess the patient for fever, cardiovascular status, respiratory status, urticaria, or angioedema. If there's no fever or respiratory distress, we suspect TACO. If there's fever with or without chills, respiratory distress, and hypotension, we'll start thinking of TRALI. If there's fever, chills, along with otherwise patient is asymptomatic, we think of febrile non-hemolytic transfusion reactions. If there is fever with or without chills, hypotension, flank or backache with bleeding, this is the most dangerous acute hemolytic transfusion reactions. We carry on a Coombs test, we do the CBC, we do the urine dipstick test and start treating the patient. If there is fever with or without chills, with or without hypotension, we suspect sepsis in the patient. If there's urticaria, bronchospasm, angioedema, or hypotension, we think on the lines of urticarial or anaphylactic reactions. So we should ultimately know that blood transfusion is like a marriage. It should not be entered upon lightly, unadvisedly, or wantonly, or more often than is absolutely necessary. Thank you.
So at the end of talk, we are wiser, like most of the components, what are the blood components are available to us as of today, and what are the various transfusion related reactions have been nicely covered by Dr. Dua. And it is also important, as he said, that the judicious use of blood components and blood in today's era is very important. And every drop of blood should be justified. So, as also we know that it is a medicine which we cannot just overuse or underuse. It has to be optimally justified wherever and whatever, in what way it is indicated. He nicely quoted and summed up his talk. So any questions or queries from the PG students or our panelists who are joining us are most welcome. One.
There are no questions in the chat box.
Okay, I think very few people have joined. Maybe today was holiday and too early for them to get out of bed. So thank you, Dr. Dua. It was nice to see you today on morning on the screen. And thank you, Sipriya, for
Thank you, Dr. Singhal, for your gracious time. And thank you, Dr. Dua. It was such a comprehensive presentation. I think there are no doubts because you covered everything. So thank you so much, Dr. Dua. Thank you, sir. Thank you, Dr. Singhal.
thank you so much.
So now without delay, let's proceed to our next session. That will be chaired by Dr. Baljit Singh. He is a professor and head of the department in Department of Anesthesia in SGT Medical College, Gurugram. He has 160 publications and 11 book chapters to his credit. And he has been examiner for MD, DA, PDCC, DNB, PhD, and assessor for National Board of Examination of MCI and MC. And to his achievements, he is a subject expert for UPSC and various state public service commission. From 2009 to 2018, he's been member board of directors of Indian Confederation of Healthcare Accreditation. From 2010 to 12, he's been treasurer of Indian Society for Study of Pain. And he was member of Governing Council ISA National from 2009 to 11. And he was vice president of Indian Society of Anesthesiologists 2017-18. And his director, Scientific Committee, Indian Resuscitation Council, CEO of Indian College of Anesthesiologists, and listed in Marcus Who's Who in Medicine 2012 edition. I welcome you, sir. Very good morning. And thank you for coming and giving your time. Thank you. I welcome you, sir. Over to you, sir.
Thank you so much, Dr. Shapia, for a very generous introduction. Well, good morning, everyone. After a very nice talk by Dr. Amit Dua, I enjoyed his talk, and beautifully he summed it up by drawing an analogy which we can't forget. And before we go ahead, I must like to congratulate Dr. Mohandeep Kaur and of course the whole Appec team who have organized such a beautifully arranged scientific program for postgraduate students, particularly.
Thank you, sir.
Exam-going postgraduate students. Okay, so now let's go ahead with the next talk, and the next talk is an equally important topic. That is diagnosis and management of brain dead as potential donor. And this talk will be delivered by Dr. Dirja Sharma. I would request Dr. Dirja Sharma to take over. She is the vice president. She is affiliated to Max Healthcare Institute Limited, Max Super Specialty Hospital, Shalimar Bagh, and her areas of special interest include palliative care, difficult airway, and quality in anesthesia. Over to you, Dr. Dirja Sharma.
Good morning. Today we will be talking about diagnosis and management of brain dead as potential donor. A 37-year-old male patient was admitted in ER with history of road traffic accident and loss of consciousness. Patient was treated in district hospital initially and shifted to referral center. When received, the patient was already intubated on ventilator. The pupils were bilateral, dilated, and non-reactive. Vitals were, however, well maintained and patient was not requiring any inotropic support. What should be the further management? The patient was admitted under a neurosurgeon in the ICU and was sent for CT and MRI from them. On review, the neurosurgeon found that there was diffuse and large-scale brain hypoxia, and even the next morning, pupils were dilated and non-reactive. So, what do you think is the diagnosis of this patient? Is this patient brain dead? Is this patient a potential brain dead donor? So, in today's lecture, we would be learning about what is the definition of brain death, how to diagnose brain death, who is a potential brain dead donor, and how to manage a potential brain dead donor. A potential organ donor is defined by the presence of either brain death or catastrophic injury to the brain, which could progress beyond irreversibility and may fulfill brain death criteria. In India, the legal framework for organ donation from a brain dead patient is in place as per the Transplantation of Human Organ Act 1994. It was further amended in 2014 to include formation of a national organ transplant and tissue transplant organization with 5 regional levels and each state having its own organ and tissue transplant organization. As per the Transplantation of Human Organs Act, the deceased person means a person in whom permanent disappearance of all evidence of life occurs by reason of brainstem death or in a cardiopulmonary sense at any time after live birth has taken place. Brainstem death means the stage at which all functions of brainstem have permanently and irreversibly ceased. So what are the components of a brain death? First, we need to establish irreversible cause of coma. There should be absent brainstem function. Apnea should lead to a PCO2 more than 60 millimeters of mercury, and all the confounding factors should be ruled out. A brain death can then be done if the core temperature of patient is more than 32 degrees Celsius. The metabolic parameters are within normal limit. There are no endocrine dysfunctions and drug intoxication has been ruled out. How does brain death actually occur? In case of major brain ischemia, because of brain swelling, blood collection, obstruction to CSF, there is rise in ICP. The blood flow decreases and ultimately stops. The brain cell dies. This leads to irreversible ischemic death of the brain cell. And this is the stage when the patient becomes a potential brain dead donor. If this situation carries on, the patient ultimately dies. For diagnosing brain death, we need to take detailed history as well as physical examination, including CT and MRI, to establish potentially irreversible coma. We need to exclude confounding factors such as presence of shock or hypotension, hypothermia with core temperature less than being 32 degrees Celsius, neurotoxic snake bite, brainstem encephalitis, Guillain-Barré syndrome, encephalopathy, severe hypophosphatemia, or taking of drugs known to alter neurological, neuromuscular, or EG function like anesthetics or NM blockers. In fact, in the kind of scenario as we just discussed, if the patient is referred from another center, it is better to wait for at least 5 half-lives of the drug in setting of normal KFT and LFT, and also check for train of 4 response for NM blockade before trying to attempt diagnosis of brain death. A complete neurological examination entails looking for response to painful stimuli. Painful stimuli can be given in the supraorbital region or nail bed. The test need to be carried out for function of cranial nerves such as corneal reflex, pupillary dilatation, caloric test, and cough reflex. Apnea test is then carried out. In case the patient is too sensitive and not able to maintain the oxygen saturation, then apnea test utilizing the PFAL can be done as shown in the figure. Prerequisites for conducting an apnea test includes core temperature being more than 36.5, U volumia or positive fluid balance in previous 6 hours in the patient, normal PCO2 and normal PO2. To conduct the apnea test, we need to pre-oxygenate the patient with 100% oxygen for 10 to 15 minutes and then do a baseline ABG. Need to connect pulse oximetry and disconnect the ventilator. Can deliver 4 to 6 liters per minute of oxygen to the endotracheal tube using a soft catheter for apneic oxygenation. Need to look closely for any respiratory movements by way of abdominal or chest excursion. Measure the arterial PO2, PCO2 and pH after 10 minutes. For every minute of apnea, there should be a rise of 3 millimeters of mercury of PCO2. If we observe respiratory movements during the apnea test, it clearly rules out brain death. If the patient has systolic blood pressure following below 90 millimeters of mercury or has a precipitous fall in the pulse oximetry saturation or becomes dysrhythmic, we need to immediately reconnect the patient to ventilator. If respiratory movements are absent and arterial PCO2 is more than 60 millimeters of mercury or has risen by 20 millimeters of mercury over the baseline, the apnea test is considered positive. That is, it supports the diagnosis of brain death. If PCO2 is less than 60 millimeters of mercury and PCO2 increases by less than 20 millimeters over baseline, the result is indeterminate and a confirmatory test can be considered or apnea test can be repeated. After an appropriate 10-minute apnea test can be repeated after pre-oxygenation for 15 minutes with FiO2 of 1 and normalization of patient PaCO2 40 millimeters of mercury. When should the apnea test be done? If the patient has had a major neurosurgery or confirmed aneurysm, then apnea test should be attempted only after 4 hours. In case of hand injury, after 6 hours. In case of spontaneous intracerebral bleed, it should be done after 6 hours. In case of brain hypoxia following cardiac arrest, apnea test should be done only after 24 hours. And in any of the above condition where there is a suspicion of drug intoxication and there are no screening facilities available in the hospital, then apnea test should be attempted only 50 to 100 hours have elapsed. There is no need for consent for carrying out apnea test. However, assent from the family should be taken. They should be informed. In case of hemodynamic instability, we can use vasopressors and hormone supplementation to correct that before apnea test. In case of pulmonary dysfunction, pre-oxygenation, apneic oxygenation, recruitment maneuver before the apnea test or apnea test with PFAL can be done. In case of chronic CO2 retention or COD patient, target higher than the CO2 or more than 20 millimeter rise in CO2 should be considered. And for other factors, we must need to correct the metabolic factors to look at positive apnea test and subsequent diagnosis of brainstem death. If following observations are done during the apnea test, for example, there is spinal reflex induced skeletal muscle contraction, sweating, blushing, tachycardia, normotension without pharmacological support, or absence of diabetes insipidus, brain death can be declared. However, if there is decerebrate or decorticate posturing, extensor or flexor motor response to painful stimuli, or seizures, brain death cannot be established. Confirmatory tests for brain death include EEG, cerebral angiography, transcranial Doppler, and radionuclear scan. However, as per TOHA, the ancillary tests are not mentioned at all. Therefore, in our country, the legal acceptability of these can be challenging. The indication for ancillary tests are patient with cranial or cervical injury, cardiovascular instability, severe facial trauma, autophagia, eye agenesis, because of which the clinical examination and clinical test cannot be performed, or the panel of doctor is in doubt or disagreement with the diagnosis. Diagnosis of brain death is established and recorded by two doctors not belonging to the retrieval and transplantation team. Out of the two doctors, one must be a specialist in neurology. For certification, we need a panel of 4 doctors, including doctor in charge of the patient, doctor in charge of the hospital where the patient was treated. An independent specialist of unspecified specialty can be physician, surgeon, or intensivist, a neurologist, or a neurosurgeon. The clinical examination and apnea test needs to be done 2 times after an interval of 6 hours, and the time of death is the end of second apnea test. For documentation, all phases of determination of brain death should be clearly documented in the medical record, and justification and result of confirmatory test should also be recorded. All the 4 doctors need to sign on each and every test being done for diagnosis of brainstem death. Clinician in charge should initiate the conversation about testing for brain death with family. However, after brain death certification, the ICU in charge should inform the transplant coordinator, who should counsel the family regarding organ donation. For the process of consent, it needs to be taken from deceased next of kin. The deceased consent, by that I mean that we can look at if the deceased had ever expressed the wish for organ donation or is part of the NOTO list. And in our country, consent from the family and next of kin is a necessity. So the surrogate decision making in such condition can be done by the spouse or adult son or daughter or the parent. In case of medical legal case, the coroner's consent needs to be there. We need to inform the SHO of the police station where the medical legal case was registered. Exclusion criteria for organ donation include infection with HIV, Epstein-Barr virus, systemic viral infection with measles, rabies, adenovirus, parvovirus, herpetic meningoencephalitis, active malignant disease, or history of malignancy with high risk of transmission, even though the patient may be apparently disease-free now. For example, in case of melanoma and choriocarcinoma, bacteremia and fungemia are not absolute contraindication for organ donation because treatment for these can be done in the PPDD. Acute organ dysfunction, in particular acute renal failure in a setting where the patient had normal functions earlier, is not a contraindication. There is no maximum age for donor. However, the marginal donor is only justified if life expectancy after transplant is supposed to be more than the life expectancy which the patient has with conservative treatment. According to the ICCM position statement for PBDD, if recipient is less than 45 years old, the ideal age of deceased donor is for kidneys up to 60 years, for liver up to 60 years, for kidneys and pancreas 18 to 45 years, for pancreas 7 days to 50 years old, for heart 45-year-old, and for lungs 60 to 65-year-old. If the PBDD patient is more than this age, the donation can still occur, but then such a donor is a marginal donor. For the care of PBDD, extra continued, which was there for previously in the ICU. Investigation should be done only to facilitate organ retrieval. The physiological events which occur in brain dead patients are that following medullary ischemia, there is autonomic storm leading to cardiac ischemia, hypertension, and arrhythmia. Uncal herniation and spinal cord ischemia causes depletion of catecholamine surge. There is dysfunction of hypothalamic pituitary adrenal axis and thyroid dysfunction, leading to vasodilatation, polyuria, and metabolic imbalance. This causes hypotension, hypothermia, hypoglycemia, hypovolemia, and dyslipidemia. Patient will have diabetes insipidus, may have hypothermia, and once hypothermia sets in, it becomes difficult to rewarm. Patient may have hormonal dysfunction such as low T3 and hyperglycemia due to low insulin. Anemia, coagulopathy, and immunological changes may occur. As part of journal measure, the infection control should be done and hygiene should be carried on as it was being done for the live patient. Frequent turning of patient for decubitus ulcer prophylaxis, skin care, urinary and intravascular catheter care should be done. Bronchial toilet should be done. Eye care by taping of eye can be done. The heat loss should be reduced by active warming. A nasogastric tube must be inserted for gastric decompression. Arterial and central venous lines should be inserted, but they should be preferably done in the upper limbs because femoral line readings can become erratic once organ retrieval is being done. So routine monitoring includes ECG, blood pressure, pulse oximetry, core temperature, hourly urine output, and central venous pressure. Bedside echocardiography for assessment of fluid deficit may be done. Use of Swan-Ganz catheter and cardiac output monitor should only be done in unstable donors who have persistent acidosis and evidence of tissue hypoperfusion. Arterial blood gases, lactate, electrolytes, and blood sugar need to be done 2 to 4 hourly. Hemoglobin, hematocrit, complete blood count, HIV, HBC, hepatitis C, liver function tests, coagulation profile, cytomegalovirus virus, etc. should be done. Mandatory investigations include blood group, HIV, antibodies. Risk of transmission may, however, occur. Culture of blood and urine may be required, especially if the patient is hospitalized for more than 72 hours. And some additional tests may be required for heart transplant, echocardiography, and bronchoscopy for lung transplant. The goals for maintenance of PBDD rule of 100 is is something that all of us should know. Systolic arterial pressure should be more than 100 millimeters of mercury. Urine output should be more than 100 ml per hour. Pulse, the partial pressure of oxygen more than 100 millimeters of mercury. Hemoglobin more than 10 grams per cent, and blood sugar in the range of 100 milligrams. For hemodynamic management, if there is hypertension, no treatment is needed. For hemodynamically significant bradydysrhythmia, isoproterenol, epinephrine may be used. Basic monitoring of pulse oximetry, arterial line, and echocardiography should be carried on till organ retrieval. The goals for this monitoring should be a MAP more than 70 millimeters of mercury, urine output more than 1 ml per kg per hour, and there should be minimum vasopressor requirement in this situation. Ejection fraction should preferably be kept over 45%. If there is further instability, then fluid should be given to the patient or vasopressor may be increased. First line is vasopressin at 2.4 units per hour, and second line is norepinephrine or epinephrine. If there is continual instability, then we should introduce the pulmonary capillary wedge pressure monitoring should be done. TE and CO monitoring should be done. The goals for this is cardiac index of more than 2.4, pulmonary capillary wedge pressure of from 8 to 12 millimeters of mercury, and a stroke volume variation of 12%. If goals are not met, then we must consider hormonal replacement, increasing vasopressin up to 4 units, methylprednisolone, thyroxine, and insulin. So for hypovolemia, which fluid should be used in PBDD? Crystalloid with balanced salt content so as to avoid hyponatremia and hypercholoremic acidosis when used in resuscitation target. Administration of excessive Intravenous fluids containing 5% dextrose may further complicate hypoglycemia. Hesteril starch is absolutely contraindicated because it damages renal epithelial cell and causes early graft dysfunction in transplanted kidney. Albumin solutions may be considered to reduce the amount of volume given, although usually only moderately effective, and high sodium content of albumin-based solution needs to be taken into count. The most commonly used fluids are Ringer's lactate, Plasma-Lite A, Ringer's acetated, half normal saline. Packed red cells should be transfused to maintain a hematocrit of 30%. Central venous pressure alone is a poor guide. Repeat bedside echocardiography should be done. Pulse pressure variation is a good method to see for optimal fluid state. Urine output 1 to 3 ml per kg per hour in absence of DI. Cardiac insects more than 2.5. However, in high cardiac output state due to vasodilatory shock, it may be a confounder. And for central venous oxygen saturation of more than 70%, however, in low basal metabolism due to brain death, it may be a confounder. Hormonal resuscitation will be done with vasopressin 1 unit bolus followed by an infusion of 0.5 to 4 units. Methylprednisolone 15 milligram per kg immediately and then repeated every 24 hours. Alternatively 250 milligram followed by 100 milligram per hour. And insulin infusion to maintain blood glucose between 80 to 150. Thyroxine 20 microgram bolus followed by infusion of 10 microgram per hour. T3 can be given as 4 microgram bolus followed by an infusion of 3 microgram per hour. T4 improves the hemodynamics and prevents cardiovascular collapse. However, IV T3 is not available in our country. So, alternatively, we can give thyroxine oral 300 to 400 microgram 8 hourly through the Ryle's tube. And this has been suggested by Noto. The dose of desmopressin and vasopressin with acceptable urine output. To have a urine output of 3200 ml per hour, we can give nasal puffs every 4 hours, 1 to 2 of desmopressin, and vasopressin IV infusion at a dose of 0.5 to 2 units per hour. WIP's approach is just an acronym I wanted to share with you. It's an easy acronym to remember. So along with the rule of 100, we must ensure ventilation, infusion, pumping, pharmacological support, and specific interventions for our PBDD. And here I'm using just one chart you can refer to later on for the target range of all the indicators for PBDD management. For temperature, respiration, and hematological management, the hypothermia should be prevented and all the patients should receive surface warming. If temperature is less than 34 degrees Celsius, core warming should be done. Respiratory passage should be kept clear by suctioning, postural drainage, and application of PEEP to avoid atelectasis. Interstitial fluid overload should be avoided. In case of active bleeding, the cause of bleeding should be corrected and blood products should be used. In case of worsening coagulopathy, organ retrieval should be hastened. Antibiotics, as per culture report, should be given. Routine antibiotics are not advocated. Nutrition should continue as per the standard ICU protocol, and enteral feed helps in organ functioning. Hepatotoxic and nephrotoxic drugs should be avoided at all cost. For organ-specific dormant maintenance, adequate fluid volumes are required for liver and kidney maintenance. Hypernatremia may cause primary liver graft, so should be avoided totally in a PBDD where liver is to be harvested. Restrictive fluid balance along with lung protective ventilation for lung procurement should be done. An ideal perimeter for donor heart is LVF more than 50%, cardiac index more than 2.5, and a pulmonary capillary wedge pressure less than 15 millimeters of mercury. However, heart can be considered for donor even if we are not able to perfectly meet these criteria. Intraoperative consideration for organ retrieval include supportive measures from ICU which should continue. Warming should continue. The patient is positioned supine and skeletal muscle paralysis should be provided to suppress spinally mediated reflex contractions. So I have seen very often that people consider a PPDD needs no anesthesia. However, it is important to give neuromuscular blockade and volatile anesthetic to this patient. The reflex sympathetic response to surgical stimulus can be attenuated with volatile anesthetic, and we like using sevoflurane and isoflurane. Heparin should be given before cross-clamping the aorta. Positive pressure breath should be given before lung retrieval, after which the machine can be disconnected. And here I like to emphasize that there should be respect for closure of body and send off from the OT. An anesthesiologist should ensure that it is done. For organ preserving cardiopulmonary resuscitation, we should do CPR in case of cardiac arrest to preserve organ for transplantation in a PBDD. The ethical consideration here is that normally we do a CPR to revive a patient, but here we are looking at retrieving, prolonging the organ function for retrieval. It's an aggressive procedure, and the organ retrieval should be hastened post that. In fact, we've had one patient in our center who had CPR, following which we did organ retrieval, which were taken up successfully in all the recipients. So here I'm just sharing two checklists for you. One is the contraindication to organ donation checklist, and second is the checklist for PBDD management, which we can go through at your leisure. All the best and thank you.
Thank you so much, Dr. Deja. Excellent coverage of the topic. I think I would, more than agree with the statement that you just made, that there should be a respectable send-off to the person after the donor. Look, he may have had brain death. He's virtually dead for the relatives and for the world, but he is providing lives to others to live. And I don't think there can be a better gift that somebody can ever provide to anyone. Thank you so much for an excellent coverage. I think, the need for organs for transplantation is increasing at a rate that is faster than the availability of these organs. So it's very important for us that whatever organs are possibly available for donation and further transplantation, those organs must be respected thoroughly. When I say respect, it means that those organs should be maintained in as much normal physiological parameters as possible. And we must, keep everything with regard to the respect to that organ in place. There are a lot of issues which are involved. There are two main components of organ transplantation. One is that you diagnose a brain death. It's very important. There are a lot of parameters with which you do that. And let's not forget that there is medical legal significance also. We can't just take the patient and take an organ from him and put it in somebody else's body. No, there are lots of things, and you have covered the topic extremely well. And then, of course, again, many people think that, well, the deceased person is there, so it's okay, just give a decision and take the organ out, because he's not going to know what's happening to the body. But that's not right. You have stressed that yes, we should give proper anesthesia with volatile anesthetic, neuromuscular blockade, and everything. Well, I compliment you for the talk, very well covered, and I leave the forum open for any questions in case there is. There was one in the chat box which I saw was that is tuberculosis a contraindication to organ transplantation?
Yeah, thank you, sir. Thank you so much for your nice review. I have already covered this point in the last checklist for different disease-wise list that I've given. If patient has active tuberculosis and miliary tuberculosis is a contraindication, we don't pick up that patient for organ donation. So you are right about that. Initially in the slide, I had just talked about major points, but in the end, I have given a very exhaustive list. In fact, if the patient has had a previous diagnosis of acute abdomen with bowel, ischemia, or has had severe sepsis as the diagnosis before brain death is done, then that patient is also poor, is not taken up for organ donation.
Well, thank you so
Good.
much. I think very comprehensive answer, and I hope the person who asked that question is satisfied with that. I don't see any other questions in the chat box. Dr. Sarpriya, do you have any?
No more questions, sir. That was the only question.
Yeah, well,
So
in
that
case
ma'am
there's
has.
no more questions, I'm handing over it back to you. Thank you so much for the privilege that you gave us, gave me, and of course, Dr. Leader, the platform to share, share time together on this wonderful program that you're organizing. Compliments once again, and congratulations for a very, very well conducted program. Over to you, Dr. Priya, and have a nice day.
Yeah,
Thank you so much, Dr.
Yeah.
Balji.
I'll
Thank you
also
so much,
like to
Dheerja
thank.
ma'am.
Yeah, thank you so much, Sarpriya. Thank you so much to Dr. MD and also to Sir for taking time out to present. Thank you so much. Very comprehensive, and my compliments to you.
Thank you so much, ma'am. Thank you so much, sir, for your time, precious time. Thank you, sir.
Thank you.
So that was a very comprehensive lecture by Dr. Dheerja. Now let us proceed to our next session that will be chaired by Dr. Pranav Bansal. He is professor and head of the Department of Anesthesia in BPS Government Medical College, Sonipat, Haryana. He has so many achievements to his credit. He has authored more than 50 articles in international and national journals with more than 200 citations. He has authored a chapter in textbook of cardiology. He was member of editorial board and reviewer in many international and national journals. He's ex-professor in Department of Clinical Skills at Medical University of the Americas, St. Kitts and Nevis Federation, Caribbean Islands in 2016. And his area of interest are ultrasonography in regional anesthesia and pain management. I welcome you, sir. Dr. Bansal, thank you so much for the time you are giving us. Over to you, sir.
Thank you very much, Dr. Shifpriya, for such a nice introduction. I welcome all the faculty members and the delegates on this wonderful platform of Appec 2022. I congratulate first of all to Dr. Mohandeep Kaur ma'am, Dr. Akhilesh, you yourself and all the team for organizing such a wonderful online PG conference. And the topic which I have to introduce and speaker is Dr. Divya Jain ma'am. And the topic for her is truncal blocks. Now, students, you might have got a glimpse of this topic day before yesterday on 27 in pediatric regional anesthesia, where Dr. Anju Gupta covered it. Now, since the morning, the session has been wonderful, whether it was all the topics, whether it was Dr. Dheerja or Dr. Amit Dua. So now I'll introduce Dr. Divya Jain. She is a very dynamic speaker and an excellent clinician. She's professor in the Department of Anesthesiology and Intensive Care at PGI Chandigarh. Her area of interests are airway management, pediatrics, simulation, research methodology. So she'll be covering truncal blocks. So over to you, ma'am. Thank you.
Thank you very much, sir, for your very good morning. I'm Dr. Divya from PGIMER Chandigarh, and today I would be talking on truncal blocks. Before beginning, I would like to thank Team RML for giving me this opportunity. So without wasting time, let's start off. So in the recent past, we have seen that truncal blocks have gained a lot of popularity. First, because of the increasing use of ultrasound, and secondly, the ease by which these blocks can be placed. So today in my talk, I'm going to cover the blocks which are given in the anterior abdominal wall, the chest wall, like the transverse abdominis, rectus sheath, ilioinguinal, quadratus lumborum, the pecs, serratus anterior, the paravertebral, and the erectus spinae. So before beginning, we need to understand that the relationship between the transducer of the ultrasound and the anatomy. Now, if I hold my transducer in the transversely, then all the anatomical structures would be viewed from medial to lateral. And if I hold it in a sagittal plane, all the structures, anatomical structures, are going to be visualized from cephaloid to caudal, in caudal direction. So we start with the transverse abdominis, which is one of the most popular blocks, which is being given. Looking at the anatomy of the abdominal wall, the main muscles include the rectus abdominis, which lies in the center. In the lateral side, we have the external oblique. Below that lies the internal oblique, and below that lies the transverse abdominis. Now, this is the plane between the internal oblique and the transverse abdominis, from where the nerve roots from T7 to T12 and L1, that is the ilioinguinal and the iliohypogastric, these nerves pass through. So this becomes the point of interest of in the TAP block. So depending upon which approach we select, we have different approaches are used for different, depending upon what indication is there. So like for the lower abdominal surgeries, we generally prefer a lateral approach, because if we see that if I give the block in the slightly laterally, so the nerves blocked are going to be T10 to L1. That is because they arise mainly laterally in the plane between the transverse abdominis and the internal oblique. So it provides anesthesia to the lower abdominal wall. While if I use a subcostal approach, that's the other type of an approach which is used, then it blocks the T7 and till T9 in the same plane between the internal oblique and the transverse abdominis, and provides anesthesia to the upper abdomen. So therefore, it's also called as the upper quadrant block. So these are the two main ultrasound guided approaches. Before the advent of ultrasound, we used to use the landmark technique of giving this same block. For this, we had the major landmarks were the external oblique muscle, which was lying anteriorly. Posteriorly was the latissimus dorsi, and inferiorly we had the iliac crest. In between them was a small triangle of Petit, which was our major landmark. So from this formed the point of insertion, where the Tuhi needle is inserted till you feel the two pops. One, when you penetrate the external oblique muscle and the internal oblique, and the second, when internal oblique muscle is penetrated between the fascia, that is where you enter the fascia between the internal oblique and the transverse abdominis. Now, as we are entering here laterally, so basically depositing local anesthesia at this plane would provide anesthesia to the lower abdominal wall. So coming to the lateral approach, how I use it, using an ultrasound. For this, I hold my probe, the linear probe, transversely between the iliac crest and the costal margin. And I visualize the external oblique, internal oblique muscle and the transverse abdominis, which are lying parallelly. So my point of interest again lies between these two muscles, that is this fascia. So to enter it, I insert my needle from the medial side. This is the medial side here. And the drug, 10 to 15 ml of the drug is deposited in between this plane. Now for all the facial blocks, these are generally volume dependent, and you need to give larger amount of volume, that is approximately 10 to 15 or at times 15 to 20 ml of this to block the nerves, because it's not, the injection is not being given directly at the nerve but in the fascia. So this block is given at the level of the anterior axillary line. The subcostal, the other approach we were talking of, here again we need to enter the fascia between the internal oblique and the transverse abdominis, but for this we hold the probe just below the costal margin, very close to the midline. Now here again, the needle is inserted from the lateral side till you enter this fascia between this and deposit 20 to 25 ml of local anesthetic at this site. So these are the two ultrasound guided approaches for TAP block. Coming to the rectus sheath block, now this type of a block is mainly given for umbilical surgeries or for the midline incisions. So if you look at it, if I hold so basically if you look at it, rectus abdominis is a muscle which is a spindle shaped, extending bilaterally on both the side, and it is joined together by linea alba. Laterally, it tapers down into linea semilunaris, which further continues and tapers to form the external oblique, internal oblique, transverse abdominis, what we were talking of. So if I use my ultrasound probe and hold it in the midline direction, move it slightly laterally to recognize the three layers of the abdominal, lateral layers of the abdominal wall, that is the external, internal, and the transverse abdominis. Okay, so in the medial side, I can see the semilunaris, and medial to it lies the rectus abdominis, which is bounded by the rectus sheath, the anterior and the posterior rectus sheath, which is very beautifully visualized on the ultrasound. Now, once you see this rectus, the posterior layer or posterior sheath of the rectus abdominis, between this transverse abdominis, just at this level, now you inject, you hold your linear probe transversely, and from the medial side, you insert the needle till you enter the posterior rectus sheath between the rectus abdominis and the posterior rectus sheath. And this is the fascia where I give 10 to 15 ml of local anesthetic. Now, these blocks are generally given bilaterally. Always remember, so you need to adjust your dose because it has to be given bilaterally. And it can block the nerves between T9 to T11. So as I told you earlier, where we are inserting, a lot depends, it is going to block the nerves at that site only. Although the anterior abdominal compartment has a huge innervation, but my needle insertion goes near the midline, so it blocks the nerves close to that from T9 to T11. Coming to the other type of block, that is the ilioinguinal iliohypogastric nerve. That is another type of an abdominal block. For this, the major landmark is the anterior superior iliac spine. So this is the point from where, just above the anterior superior iliac spine, the ilioinguinal and the iliohypogastric nerves, they penetrate and enter the plane between the internal oblique and the transverse abdominis fascia. So this is the plane where again we are going to deposit the local anesthetic for giving. So it is mainly used for surgeries like the inguinal hernia repair surgeries. So for this, you hold your linear probe again in a slightly oblique direction. That is, one of the tip is facing towards the umbilicus. And now, what do you see? Again, those three layers. The external, that's why I'm saying it's a very easy block, because it's very easy to recognize muscles. You don't have to recognize those nerves individually. We are just trying to focus on big muscles, external oblique, internal oblique, and transverse abdominis, which is visualized like three layers of the cake. And where I need to enter between the internal oblique and the transverse abdominis. If you are lucky enough, you can actually visualize the nerves here. The ilioinguinal and the iliohypogastric, both nerves can be visualized in this plane at the level just superior to the anterior superior iliac spine. So I insert the needle from the medial side and inject almost 10 ml. Here, a slightly lesser amount of local anesthetic is used because here nerves can actually be seen. So 8 to 10 ml of local anesthetic is injected between these two muscles, and you can anesthetize that area for inguinal surgeries. Now coming to moving, now we start moving posteriorly. That is, the most common block nowadays being performed is the quadratus lumborum. The main indications of performing quadratus lumborum block is cesarean section, abdominal hysterectomy, nephrectomies most commonly, especially in renal transplant patients coming as donors for renal transplant, prostatectomies, abdominoplasties, iliac crest graft, and also hip surgeries. Now, looking at the anatomy of this, you can see, so far we had been talking about the three layers, the external oblique, the internal, and the transversalis abdomen. So we see here that the fascia just below the transverse abdominis muscle, that is the transversalis fascia. Now, if I move slightly posteriorly towards the back, this fascia ends into thoracolumbar fascia. Now, this fascia engulfs a muscle which is called as the quadratus lumborum. And now, using this fascia to inject the drugs can it can provide anesthesia to to a large surface area, that is from T10 to almost L3. How is the block given? Various approaches have been proposed for giving quadratus lumborum block. The first approach was given, which has been called as the quadratus lumborum block 1 approach, 2 and 3. So if we talk about the first approach which was proposed, was when the drug local anesthetic, here this is the quadratus lumborum muscle, and here the local anesthetic is injected just where it meets the transversalis fascia, that is on the lateral side. So this is also called as the lateral approach. Now, if I target the posterior border of the quadratus lumborum, again, I insert the needle from the lateral side. Okay, the patient is lying laterally, facing away from you, and here laterally I insert the needle and the drug is injected on the posterior border of the quadratus lumborum. This is the quadratus lumbar block 2 approach. The third approach is when I penetrate across the muscle, that is transmuscular approach, to deposit almost 15 to 20 ml of local anesthetic on the anterior border of the quadratus lumborum muscle. This is the third and one of the most common approaches which is being used nowadays for nephrectomies. Here, if you look at it, the patient is lying laterally, and from the lateral side, I insert my needle to give the block for the lateral approach. I give it in the lateral border, just where I can visualize all the 3 muscles, and for the anterior approach here, the drug is given on the posterior border. The drug is deposited on the posterior border of the quadratus lumborum. Here, again, 15 to 20 ml of local anesthetic is deposited. The third approach here, I move my transducer little at the back. The patient is lying laterally. I move the probe slightly backward, and the needle is inserted here medially now. Medially, and I go transmuscular approach, crossing the quadratus lumborum and depositing the drug on the anterior border of the quadratus lumborum, that is between psoas major and the quadratus lumborum. This is the third approach which has been proposed. So this was about quadratus lumborum. Coming to the most important block, what we feel is the paravertebral, or I would say one of the most ancient blocks. It's been given since a century now. Now, if we look at the anatomy of the paravertebral block, it is a wedge-shaped which lies just at the site of the vertebral bodies. Now, it is bounded posteriorly by the superior costotransverse ligament, and anteriorly it has the parietal pleura. Superiorly and inferiorly, we can see it has the head of the ribs. So these are the most important landmarks for the paravertebral space. It has wide range of indications depending upon the site where the block is inserted, where your needle is injected. So it can range from the thoracic surgeries to the abdominal surgeries. Now, when you are depositing a drug at a particular level and you give almost 10 to 15 ml of the drug, it can block 2 dermatomes up and 2 dermatomes down and anesthetize that particular area. So it can be used, mainly we use it for the thoracic area, that is for breast surgeries and thoracic surgeries. It is also used for cholecystectomies, herniorrhaphies and appendix surgeries as well. Along with this, it gives excellent pain relief for the rib fractures also. For this, many people use it. Before the use of the ultrasound, landmark technique was very commonly used for giving paravertebral. As I told you, this block has been given since 1905. But it was the first time when this block was first given. So since that time, people have given a lot of techniques have been proposed. The most commonly used technique I'll describe here. So for this, you make the patient, just sit down, and you can feel the spinous process, mark the spinous processes very nicely. 3 centimeter lateral to the spinous processes lies the transverse process. Okay, now you insert your 2He needle at this very point, start walking on the transverse process just above it, then slowly go inside and keep inserting the needle till you feel a loss of resistance or a slight pop-up or a giveaway sensation. So this is when you have traversed the superior costotransverse ligament, which is lying posterior to your space. Local anesthetic is then injected. That is how much? 10 to 15 ml of local anesthetic is injected after gentle aspiration, confirming that you are not in the epidural space. Just anterior to your this place lies the parietal pleura. So you need to be very careful when you are performing this block. So the use of ultrasound has really revolutionized the techniques for paravertebral block, and now therefore it is now extensively being used. Various techniques again have been proposed. You can use it, keep the needle, your probe in the transverse direction or in the sagittal plane. Now the structures which are visualized remain almost the same. That is your spinous process, your ribs, and your transverse process. These are the main landmark things which you need to, anatomical landmarks, which you need to recognize in the ultrasound, whichever technique you are using. So if I look at the transverse technique, for this, I use a linear probe. It is held transversely, almost 8 centimeters lateral to the midline. We use the in-plane technique. So when your probe is lying over the transverse process, we will find that the space in between the ribs is mainly occupied by the external intercostal muscle, and lower to that lies the internal intercostal muscle. So medial to that is the transverse process, which is recognized as an anechoic shadow after this, a hyperechoic and then an anechoic shadow of a bony structure. Below that, you can actually, the shiny layer of the pleura can be recognized, from which you need to be very careful not to puncture. So laterally, you insert your 2He needle. Under guidance, go just lateral to the transverse process. Inject your 15 to 20 ml of local anesthetic. You can see the local anesthetic spreading down and the pleura coming down. So that gives you confirmation that you are in the right space. This was about the transverse technique. So if I look at the sagittal technique, for this, I hold my linear probe sagittally almost 5 centimeters lateral to the midline. So what do I see? So here again, 2 anechoic shadows. These are the 2 adjacent ribs which are seen. And in between that lies this hyperechoic shimmery structure, which is your pleura. So I start moving my probe slightly medially, and there you can see this rib is replaced by the transverse process. The moment I reach 3 centimeters from the midline, I can see the transverse process. In between that, the vision of the pleura is slightly obscured by the mediastinal structures. So I can tilt my probe slightly laterally, but under ultrasound guidance, inline plane technique, from the caudal direction, now I move the needle till I see enter just above the pleura. I inject my local anesthetic, just 5 ml initially, and I can see the pleura moving down, which shows that I'm in the right place. And then I inject the remaining amount of the 10 to 15 ml of the drug. So this can anesthetize 2 dermatomes up, 2 dermatomes down, depending upon the site of insertion where I'm placing. If I need it for a larger area, I can use multiple level blocks as well. As I told you, this paravertebral block is risky because of its proximity to the pleura. So therefore, we prefer relatively safer blocks. Erector spinae is one of those blocks which has recently been gaining popularity because of the ease of insertion of this block. So to understand what erector spinae, how do you go? You need to understand the relationship of 3 muscles. Like for the tab block, we saw that there were 3 muscles. We had to recognize the external, internal, and the transverse. Here again, we have, if your ultrasound probe is lying at the back, you need to recognize 3 muscle layers. That is the trapezius. Below that would lie the rhomboids, and below that would lie our erector spinae muscle, where you want to go. Now, if I deposit my local anesthetic, again 15 to 20 ml, we understand why we are giving that huge amount of volume, because all these are volume dependent blocks. So here I can now block the ventral and the dorsal rami of the spinal nerves very close. The drug through the costotransverse foramen, it can penetrate the paravertebral space and can provide anesthesia to, again, 2 dermatomes up, 2 dermatomes down from the point of insertion. This block, again, just like the paravertebral, has a wide range of indications. So for giving this, I hold my linear probe transversely at the back, and there I can see the transverse process. If from the midline 3 centimeter laterally, if you hold your probe sagittally 3 centimeters lateral, you can see the transverse process. Above that lies the trapezius, then the rhomboids, then the erector spinae. And this is the point just above the transverse process where you need to give your injection. So here I give my deposit my local anesthetic on the posterior surface of erector spinae. And I can see the space expanding between the transverse process and the erector spinae. The main indications for giving this block is this breast surgeries, cardiac surgeries, thoracotomies, thoracoscopic surgeries, abdominal, and even lower limb surgeries. Again, depending upon from which is your site of insertion of the needle. For a long time, the paravertebral blocks were considered the gold standard for the breast surgeries. But later we realized that they had their own complications. The risk of pneumothorax because of its proximity to the pleura. And secondly, it could just block the thoracic nerves. And what about the lateral and the medial pectoral nerves, which was again supplying the chest wall? So these are basically the branches of the brachial plexus, and they are spared in paravertebral block. So as a solution came the PEC blocks. Now these PEC blocks, if I grossly look at the anatomy, it is basically the chest wall is innervated by the lateral pectoral, medial pectoral, T2 to T6 spinal nerves, and the long thoracic nerve. For the PEC one, you keep the linear probe again. It lies between you hold the probe sagittally at the place between the second rib, between the second or the third rib. The patient is lying supine. His arm is abducted to 90 degrees. Now there, what do I see? I see again, like the layers of the cake, I see my muscles, the pectoralis major, below that lies the pectoralis minor. And again, as hyperechoic followed by an anechoic shadows are the 2 ribs. So my local anesthetic here is injected between pectoralis major and pectoralis minor. By depositing again 10 to 15 ml of the local anesthetic, I can block the medial and the lateral pectoral nerves. But it cannot block the thoracic nerves. Therefore, it can be used only for superficial breast surgeries. But if I want to use it for extensive breast surgeries which involve axillary clearance, then it can be supplemented with the PEC2 block. Now for the PEC2 block, along with the PEC1, if I move my probe slightly laterally in between the third and the fourth rib at the level of the anterior axillary line, so along with the pectoralis major, minor, I start seeing it below that, the third muscle layer starts coming up. That is the serratus anterior. Now the local anesthetic, if is deposited here also in a plane between the pectoralis major and the serratus anterior. So here you are giving 2 injections, the PEC1 and the PEC2. There you can get a good extensive coverage for a reconstructive breast surgeries. Other than this, we also have the serratus anterior block. For this, you need, again, the patient lies supine. The probe is positioned in the sagittal plane, in the mid-axillary. I move the probe more laterally, and the probe is now lying in the mid-axillary line between the third and the fourth rib. So almost posteriorly, you start seeing which basic, we have a huge muscle, latissimus dorsi, and below that lies the serratus anterior. Now here, if I give my local anesthetic in between these two big muscles, then the nerves blocked are the lateral cutaneous nerves of lateral cutaneous branches of the intercostal nerves from T3 to T9, along with the long thoracic and the thoracodorsal nerve. So this can provide me good anesthesia for rib fractures, for thoracoscopic surgeries, bare breast surgeries, and even for post-mastectomy pains. So these are basically most commonly performed the blocks for the chest. And basically, it was in a nutshell about the truncal blocks. So you need to realize these interfacial truncal blocks are easy. That is just a cakewalk. What we need to recognize is which layer you want to perform this block, which layer you need to walk. Thank you.
Thank you very much, ma'am. And as I said at the start of lecture, that you are an excellent academician and a very good teacher. Today, I can say that not only the students, but I also learned a lot. And it was a very excellent presentation, especially the presentation of layer of cakes. So it was such a nice idea. And in fact, I'll try to use it when I teach my PGs, the layer of cakes idea. Now, as I can see, there are no questions on the end of the delegates, but
There is one question, sir. I think ma'am has already answered in the chat box.
A dose of.
I
would like you two ma'ams.
I can. So I think the question asked to me was basically how much dose do you prefer to get a block 2 dermatome up and down? So for facial blocks, we need to remember that the dose per se is large, which I had been saying, like 15 to 20 ml, that is 0.3 to 0.4 ml would be sufficient for a paravertebral to get the block 2 dermatomes up, 2 dermatomes down, maybe 2 to 3 dermatomes, I can say. So I hope that answers the query of the person.
No, ma'am. No, I have a query, small query. Like these are all very technical blocks.
Yeah.
Now, of course, the indications are well given, like for cancer surgeries, for chronic pains, etc. But ma'am, for post-op pain, like if you have a choice, apart from the research, because we have to give thesis to the students and etc., and the development should go on, what will you prefer, ma'am? If it was an epidural or if it was a block? Like say PEG block, like say serratus anterior block, or you have an epidural choice?
Definitely, sir. Sir, I will take many a times nowadays, we have patients who are ASA 3-4 who might not be able to tolerate the sympathectomy. So in those cases, we are now getting in, on anticoagulants. So those are high risk populations where these blocks have come up as a savior for the anesthetist.
Yes, ma'am.
Especially that population.
Okay, ma'am. And do we frequently put catheters in these blocks? Can we or should we? So for prolonged analgesia, post-surgical?
Definitely, if you have a facility to take care of the catheter placement, it can be. But in our institute nowadays, we are generally preferring not placing the catheters, but just giving the drug for the post-op analgesia.
So it might be adequate enough for 24 hours, say 12.
Yeah, the patient, because mainly the pain lasts for that long. After that, the patient can be shifted to the oral analgesics. So it gives a good transition for that.
So I think that answers all my queries also. Thank you very much, ma'am. It was wonderful and excellent presentation. And thank you very much, Team Appec, Team RML, and Dr. Shivpriya. So I would conclude the session now. Thank you. Over to you, ma'am.
Thank you so much, Dr. Bansal, and thank you so much, Dr. Divya Jain. Ma'am, it was such a close to my heart. It was such a nice presentation.
Thank you so much.
I really loved it and thoroughly enjoyed it. Very, very well explained, ma'am. Thank you so much.
Thank you
so much, sir, for your time.
Thank you so much for the encouraging words. Okay. Yeah. Bye.
So let us now proceed to a very interesting short case presentation, very interactive short case presentation, which will be presented by Dr. Nitin Kumar. He is a postgraduate student in AB WIMS and Dr. RML Hospital. And moderator will be Dr. Shaili Dutt, who is a senior resident in AB WIMS and RML Hospital. And for this case, the external will be Dr. Bharti Wadhwa. She's director professor in Department of Anesthesia in Maulana Azad Medical College, New Delhi. And her area of special interest are obstetric anesthesia, analgesia, and pediatric anesthesia. I welcome you, ma'am. And over to you, ma'am.
Thank you. I would like to thank the organizers for inviting me on this very prestigious academic forum. Nitin has gone through the patient and he will now present the history and examination. Now, TURP usually comes as a short case in the examination, but very often it can also come as a long case. So students, you must bear that in mind. The difference between a short case and a long case fundamentally is that you go for a more relevant history when you are given the case as a short case with a specific examination. However, if this patient comes to you as a long case, you will go for a complete detailed history and a complete systemic examination. So this is what you need to bear in mind, that this, although today we are presenting this as a short case, can very well come as a long case to you in the examination. Over to you, Nitin. Please do start with the examination and history. Are you there, Nitin?
Good morning, everyone.
Yeah. Good morning, Nitin. Please proceed.
Good morning, ma'am.
Good morning.
Good morning, everyone. I'm presenting a case of a 62-year-old male patient, Mr. A, resident of Srilampur, Delhi, cobbler by occupation, presented to the hospital with chief complaints of increased frequency of urination for past 2 years and dribbling of urine for past 1 year. History of presenting illness. Mr. A was apparently already 2 years back when he started experiencing increased frequency of urination, which was gradual in onset, progressively increasing as he has to wake up at night 4 to 5 times to pass urine. There is also complaint of dribbling of urine for past 1 year, which was gradual in onset, progressively increasing. It started with a poor stream flow. Now there is dribbling of urine. Patient always feels there is incomplete emptying of bladder. There is no history of pain or pain or burning while urination or blood in urine. No history of fever, pain in flank region. No history of evening rise of temperature, night sweats, loss of appetite, weight loss. No history of previous catheterization. Patient is a known case of hypertension for past 5 years on oral medication. There is no history of diabetes mellitus, tuberculosis, asthma, jaundice, epilepsy, or any previous surgery. There is no significant family history. Patient is a vegetarian, consumes vegetarian diet, walks daily after meals, and can climb up a flight of stairs. He's a cobbler by occupation and belongs to low socioeconomic status. He took treatment for a month from a private clinician for the same condition. Examination. Patient was sitting comfortably on chair. He was conscious, cooperative, and well oriented to time, place, and person. Lean built and nourished. Patient is afebrile to touch. Pulse rate was 88 per minute, regular, normal in volume and character, no radioradial, radiofemoral delay. Vessel wall just palpable. BP 128 by 88 mmHg measured in left arm in sitting position. Respiratory rate 14 per minute, regular, abdominothoracic pattern. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema, GVP not raised. Airway examination in sitting position, there was no craniofacial abnormality. Both nostrils look normal. No loose teeth or artificial denture. Mouth opening more than 5 centimeters. Modified Mallampati grade 1. Thyromental distance 6.5 centimeter. Hyomental distance 6 centimeters. Sternomental distance 16 centimeters. Neck range of motion adequate. In a spine examination, spine was normally in alignment and curvature. Spinous process are palpable. Interspinous spaces are normal. No swelling, scars, rashes present over the spine region. In systemic examination, CNS patient was conscious and oriented. Jesus 15 by 15. Chest, bilateral air entry equal, no added sounds. In cardiovascular system, both the heart sounds normal, no murmurs, heard. Per abdomen, soft, non-tender, no organomegaly. Summary: a 62-year-old male patient presented with symptoms of increased frequency of urination and dribbling of urine for past 1 to 2 years. Patient is a known case of hypertension and is on regular medication. He has METs more than 4 and his vitals are within normal limits. Airway and systemic examination are within normal limits. Is likely a case of hyperplasia of prostate, posted for transurethral resection of prostate.
Okay. So thank you, Nitin. A few points here will be discussed for the benefit of all the students here. So in the history, you have taken a lot of negative.
Please unmute yourself.
I am unmuted.
You are not audible.
Audible, ma'am.
I'm unmuted right now.
Yeah, ma'am. It's okay, ma'am.
So am I audible?
Yes, ma'am.
Yes, ma'am.
I'm audible to you, Nitin?
Yes, ma'am.
Right. So, Nitin, in the history, you took a lot of negative history. No history of fever, no, so what was the significance of that?
Ma'am, to rule out, ma'am, my differential diagnosis, ma'am. Ma'am, to rule out, ma'am, renal cell carcinoma, ma'am, UTI infection, ma'am, or any other cystitis, ma'am, infection including.
Renal cell carcinoma will never present like this. Your first answer should have been to rule out UTI. Because urosepsis is an absolute contraindication for surgery of this kind.
Yes, ma'am.
The spine examination, you missed out the most important thing in this particular patient. That why do we want to do a spine examination in this patient?
Ma'am, we usually proceed such cases with, ma'am, our preferred choice of anesthesia is, ma'am, spinal anesthesia.
Very good. So you wanted to see whether the anatomy was
normal, ma'am.
Normal or not. But in this particular patient, who is a patient, as you have said, of a suspected hypertrophy of the prostate, I think you must be aware that these are the patients, very often they may not be a benign, it could also be an underlying malignant growth.
Yes, ma'am.
You agree with me that prostatic
Yes,
carcinomas are very much common with BHP. So in this particular patient, you should have gone for examination of the spine for tenderness. Because, can you tell me why now?
Ma'am, because of metastatic lesions, ma'am.
Yes. Prostatic carcinoma has propensity to go for metastasis to the vertebral bodies. So that is why here you did a very good job, but you missed out a very important point, which was that you should have checked for spinal tenderness here to rule out vertebral mets. So, and then whenever you get such an case in the examination, which is the examination which is absolutely confirmatory for benign hypertrophy of prostate?
Ma'am, per rectal examination, ma'am.
Per rectal examination, even though you may not do it, you should in the exam always ask for per rectal examination findings, right? And if that's not if not that, then you can ask for a UST, because you cannot confirm the diagnosis without these two findings. So you're well within your right to ask for findings of per rectal. Or if you do not get that, you can simply say that it appears to be a benign hypertrophy of the prostate based on the history and because here examination is not giving you anything. You're not really examining, to be confirmed with a per rectal examination. So this is what you need to focus on when you are taking a case of TURP. Right. So very, very good job, Nitin. Very well done. In the history, now you need to focus. Now, as we are all aware that BHP is a disease of the elderly. It will not happen in a young patient. So apart from, since this was a short case, you've done right by going for a specific history. If this comes to you as a long case, you must rule out all associated comorbid conditions. You must rule out all contraindications to particular conditions. All problems of geriatric anesthesia you must rule out, because this is an old patient. So you know that there are specific problems of geriatric anesthesia. So you must look into these aspects. And as you have very correctly said, you have looked into the presence of any urosepsis. In particularly in these patients, what is very important is to go for a detailed pulmonary and cardiac history and examination whenever you get this patient as a long case. in geriatric anesthesia, a problem which will be more significant for us will be problems of positioning, as these patients very often would have associated osteoarthritis. So this becomes extremely important. Another thing that you need to focus here is that this is a patient who has an this is basically what does BHP do? It leads to an obstruction to the urinary flow. So these are the problems that can lead to obstructive uropathies, correct, Nitin?
Yes, ma'am. Yes, ma'am.
And then there would be specific age-related changes in the renal system. So could you tell me what are the age-related changes in the renal system?
Yes, ma'am. Ma'am, in renal system, renal mass decreases by 30%, ma'am. There is decrease in GFR, decreased ability to concentrate urine, ma'am.
Very good. And so this is a very important point for all of you to know, because this relates us to our topic that we are talking today. Apart from reduction in renal blood flow, renal GFR, there is a reduced activity of the renin-aldosterone system in the older patients. There is a reduced concentrating ability, as Nitin said. There is a reduced ability to conserve sodium. This becomes very important in our patient. There is an increased sensitivity to osmoreceptors, and there is an increased secretion of ADH in response to surgery and anesthesia, which predisposes the patient further to water intoxication, which becomes a significant factor in such patients whom we are taking up for TURP. Right? So what all investigations would you ask for, Nitin, in this patient?
Ma'am, in this patient, I'll ask for, ma'am, complete blood count, ma'am, liver function test, kidney function test with serum electrolytes, urine routine and microscopy, PT-INR, ECG, chest X-ray.
Why will you ask for an LFT in
and
this
PGCM.
patient? Why will you ask for an LFT in this patient?
Ma'am, if we are using, ma'am, for drug elimination, in such patients, ma'am, we usually go for heavy bupivacaine. We proceed the spinal anesthesia with heavy bupivacaine. Bupivacaine is eliminated by liver, ma'am. Elimination of bupivacaine is by
I'm
liver.
so
And
happy,
any
Nitin.
other drugs, ma'am, which are
Nitin, I'm so happy you said all this, because this is, I just wanted to make sure that none of you say this in the exam. See, you should not go for unnecessary investigations. LFT is to be done only when indicated in such a patient. If I was to go by your logic that you're using bupivacaine, then every patient who gets spinal anesthesia would need LFT. If a patient has no indication, no clinical indication that warrants the need of LFT, you are not supposed to go for LFT. It is not part of your routine investigations. Your routine investigations would be your CBC. You missed out something very important in this patient who's an older patient, which is blood sugar.
Yes.
Sugar is a very important investigation. You will go for a complete KFT, because we just discussed that it is going to may cause obstructive changes, and older people have age-related changes. You will go for a baseline serum electrolytes, which may include, baseline serum electrolytes will include what all?
ma'am, sodium, potassium, chloride.
Very good. And?
Calcium,
Yes,
phosphorus.
calcium is very important, not phosphorus. Calcium becomes very important. You will go for your ECG and your X-ray and urine analysis. Again, very important to rule out urosepsis and as a baseline investigation. And as you very correctly said, PT-INR. Now, I said specifically calcium. We'll come to that later. You remind me of that. Remind me about that. Anything else in the investigations?
Ma'am, BGCM.
Yeah, PGCM, something that probably the surgeon has already done, but you would like to also, have a look at.
Ma'am, ultrasound, ma'am.
Yes, ultrasound.
Ultrasound whole abdomen to see the size of the prostate.
Okay, ultrasound prostate. So why is the size of the prostate so important, and what is the normal size of the prostate?
Normal size of the prostate is, ma'am, prostate length is 3 centimeter and weighs around 20 gram.
Excellent. And why do you need to know the size of the prostate? It's going to be large. So why is it so important for us to know the size of the prostate?
Ma'am, there are certain factors which, ma'am, determines the bleeding bleeding during the procedure. One is the size of the prostate, ma'am. More the size of the prostate, more will be the vascularity of the prostate, ma'am, and the amount of.
What is your cutoff there? What are you worried about? What size?
Ma'am, size more than 45, ma'am, high chances of morbidity post-op 30 days. 45 gram, ma'am.
No, I think I would go for 60 grams. Okay, 45 is generally what we are operating at. So more than 60 grams is when we start getting worried that this will lead to a longer time for surgery, a greater blood loss. And above this size, we request the surgeon to probably go for an open rather than a transurethral prostatectomy. So in the history, we've missed out one thing, actually. I just realized you've not mentioned the patient's treatment history. Was this patient on any medical management?
Yes, ma'am. Patient was on, ma'am, any hypertensive drug which was not known to the patient. Ma'am, drugs which are relieving his urinary symptoms, ma'am.
Okay.
Most likely, these drugs can be, ma'am, 5-alpha reductase inhibitors, example finasteride, and ma'am, alpha adrenergic receptor blocker, ma'am, like tamsulosin, ma'am, prazosin, which relieves, smoothens the, it relaxes the smooth muscle of prostatic urethra, which causes easy passing of urine.
Sometimes these patients can also be on antimuscarinics for treatment of an overactive bladder. So does this affect us in any way? Of course, the hypertensive, we will not talk about that, but does the medical treatment of prostate hypertrophy influence our anesthesia management?
No, ma'am.
Well, you said that tamsulosin is a selective alpha-1 blocker. Can it have any cardiac effects? Cardiovascular effects?
Yeah, yes.
Blockers would lead to vasodilatation. So these patients are very prone for postural hypertension. They may complain of dizziness and, because by virtue of the alpha blocker effect. And you may, sometimes patient may have exaggerated hypertension, which we can, attribute to tamsulosin. And this is why when you have a patient on tamsulosin who has an exaggerated fall in blood pressure, since it's an alpha-1 blocker, tell me what would be the best management of postspinal hypertension in this patient?
Ma'am, phenylephrine, ma'am.
Excellent, excellent, very good, Nitin. So phenyl, now you have to bear this in mind that if you have a patient in the pre-op who is taking tamsulosin and has this problem, intraoperative hypertension, you should go for phenylephrine over all other drugs by virtue of its mechanism of action. Very good. Right, perfect. So we've gone through a history examination. Great job there, Nitin. What would be your preoperative advice and what would be your plan of anesthesia?
Preoperative advice, ma'am, I'll ask the patient for NPO, ma'am, written informed consent. I'll ask the patient to take his anti-angiolisis one day before the night and continue antihypertensive if he's taking amlodipine in the morning with sips of water. And anti-cialogoxam, anticholinergic if taking.
Why anticholinergic?
Ma'am, to decrease the secretions.
For so Nitin, wonderful. You're saying all the things which I did not want, do not want you people to say in the exam, but it's a very good learning experience for you. So as I said before, you should restrict yourself to, saying just the basic minimum. Let the examiner ask the question. So no, it's not a good idea to go for. We no longer give anticholinergics as a preoperative advice. Yeah, angiolisis, this is fine, good enough. So what you said before that was good enough. What's your plan of anesthesia?
My plan of anesthesia in this patient is, ma'am, spinal anesthesia.
Why?
Because, ma'am, the advantages of spinal anesthesia over general anesthesia in this patient is spinal anesthesia, ma'am, provide adequate anesthesia which relaxes the pelvic floor and perineum. It also helps the patient will be.
We don't want relaxation of the wait. We don't want relaxation of the pelvic floor and perineum. Why do you want relaxation of pelvic floor and perineum?
Ma'am, because the procedure will be performed there, ma'am.
Is performed periurethral. So why do you want relaxation of the pelvic floor and perineum? You need analgesia of the area, but why relaxation?
Yes, why
relaxation of pelvic floor? Okay, go ahead.
Yes, ma'am. And the patient will be awake during the surgery. So, ma'am, it's easy to assess mentation, which is usually hampered during
So when
during
you're
the
giving
procedure.
the
If the
exam, when you're giving the exam, don't think as it in a telescopic view. So first of all, you should simply tell me all the advantages of spinal anesthesia over general anesthesia, the non-specific advantages, which are
ma'am,
it
patient
will
will be awake, ma'am, during the procedure.
it will reduce the
Peripheral
risks
cooling.
of airway problems, right? All the general, not specifically for this case, all the problems of airway management, right? Then you're giving a single drug. Polypharmacies, you don't need to give too many anesthetic drugs. Patient is awake, no risk of aspiration. All right, these are the
Yes, ma'am.
general. You should not forget the general, the routine advantages of spinal anesthesia.
Yes,
okay, and specifically in this patient, what would be the advantages?
Ma'am, to assist mentation, ma'am, during the procedure. Because if hyponatremia proceeds during the procedure, there will be patient will be restlessness or agitation will be there,
So
which are signs of ma'am TERP syndrome.
You call it early detection of hyponatremia.
Yeah.
Then
yes, ma'am. Ma'am, there will be this spinal anesthesia causes ma'am peripheral pooling of blood, which will decrease the circulatory overload in these patients, ma'am.
Okay. More. Give me some more advantages of spinal anesthesia.
Yes, ma'am. Ma'am, venous stasis will be less in these patients, ma'am, because it decreases the systemic central venous, decreases the central venous pressures in these patients, ma'am.
And that leads to?
So
there'll be lesser blood loss.
Yes, ma'am. Lesser blood loss.
Very important for us. There'll be lesser blood loss. There'll be early detection of TURP syndrome or water intoxication syndrome. There'll also be an early detection of perforation. You are giving excellent post-operative analgesia. All right. You have a patient who's cooperative with you. Lesser. You see, these are all older patients. So in older patients, there will be less chance of post-operative cognitive dysfunction. With spinal anesthesia, we know that there are less chances of post-operative delirium and disorientation in the elderly with spinal anesthesia. Right? You can go for early ambulation. Early ambulation means lower risk of DVT. So these advantages should be on your fingertips because this is a very important question for TURP. So always start with the non-specific general advantages and then come for specifically in this particular patient, these would be your advantages. So how much drug would you like to give and what is your endpoint? What is the sensory level that you wish to achieve?
Ma'am, I wish to achieve T10, ma'am, T10 level.
Very good.
In these patients.
And how much drug would you give for that?
Ma'am, dose of drug depends on ma'am 2-3 factors, ma'am. Height of the patient, duration of surgery, ma'am, and till what level we need the block.
So in this patient specifically, I'm telling you, this is a patient with a height of say 5 feet 8 inches. How much drug will you be giving?
I'll give ma'am drug around ma'am 2.6 of bupivacaine plus. No, lesser drug will be used in these patients, ma'am, because there is decreased epidural space in older patients.
Yes, and we want block only till T10. Why do you want
T10 level, ma'am?
2.6? I would give 1.8 or maybe 2.
Yes.
Right?
Yes.
And why do we go till T10? What is the nerve supply of the prostate?
Ma'am, parasympathetic supply is from S234. Sympathetic supply is from T11 to L2.
But why do you want to block till T10? Then why do you want to block till T10?
Ma'am, till T10, ma'am, if the level goes below T10, ma'am, patient will feel uncomfortable because there is due to over distension of bladder, ma'am. And if the level goes above T10, then it will mask the symptoms of ma'am perforation, iatrogenic perforation of bladder.
Very good. Very good. Very good. So that's the reason for giving a lower dose than a higher dose in these patients. Right, right. So you've given spinal block and you just like made the patient supine after giving the spinal block, and the surgeon tells you that, okay, can I take this patient in lithotomy position? Will you allow the surgeon to take the patient in lithotomy position, or would you like to wait for some time?
Yes, ma'am. I'll wait for ma'am for drug to settle in till T10 level, ma'am. Then last
After
positioning
5
of the
minutes,
patient.
after 5 minutes, the level has reached T10. In fact, in 3 minutes, the patient's level has reached T10. Will you allow them to put the patient in lithotomy position? For that matter, any case in which you are doing a surgery in lithotomy position after giving spinal, should you wait? For how long and why? So what happens, see, is that if you remember the curvatures of the spine, you have a thoracic curve and a lumbar curve. The lumbar curve, we call it the lumbar lordosis. Right? So what happens to the lumbar lordosis in the lithotomy position?
It flattens, ma'am.
It flattens out. That means that there was a hump which was first previously, keeping the drug from going cephalad.
Yes, ma'am.
But now that hump is gone, it's flattened out the lordosis. The drug can go cephalad easily.
Yes, yes.
And the surgery is performed with the lithotomy position and very often head low also. The surgeon will ask you to go for a head low. That means that the drug can now migrate cephalad. So what do you do then? You wait for the drug to get fixed.
Yes.
Local anesthetic to get fixed. So what I'm asking you is, how long will the drug fixation take?
Maximum 20 minutes, 10 to 20 minutes.
5 to 20 minutes is the time. So you ideally wait for some time for the patient to, for the drug to get fixed. Generally by 10 minutes, your drug fixation is mostly done, completed by 20 minutes. So you wait for that time. After only 8 to 10 minutes, will you allow the surgeon to start making the position? Okay.
Yes.
Right?
Yes.
Okay, now coming to the most commonly asked question is that now your surgery started and they will be irrigating the bladder urethrially. And what are the properties of an ideal irrigating fluid?
Yes, ma'am. Ideal irrigating fluid should have the following properties. It should be isotonic, non-hemolytic, non-toxic, non-metabolizable, electrically inert, easily excretable, transparent, easily sterilized, and inexpensive.
Very nice. So which is the irrigating fluid that is commonly used?
Glycine, because it has osmotic activity or osmolality similar to the blood plasma.
Does it? What is the osmolarity of glycine?
Ma'am, moderately similar, ma'am. Glycine has osmolality of 1.5%. Glycine has osmolality of 220 milliosmol, and glycine 1.2% has 175 milliosmol.
No, we are using 1.5, right? Let's talk about only 1.5. So you said 220 milliosmoles, and what is the blood osmolarity?
Ma'am, 275 to 295.
So it is not
milliosmol.
So it is?
Yes, ma'am.
It is hypotonic.
Hypotonic.
It's not isotonic.
Yes.
Right? But we still use it. Why?
Because ma'am, it matches ma'am other properties of the ideal isotonic solution.
What are the other ideal irrigating solutions?
Ma'am, other
ideal alternative to glycine. This is hypotonic, right?
Normal saline.
It has very good visibility. It has low electrical conductivity. It is cheap and it's easily available, right? Normal saline. Will you use normal saline?
Ma'am, we can use normal saline with ma'am bipolar TERP, ma'am.
Nobody uses it. You can use it when you're using a harmonic, which is either using a laser or you're using an ultrasound, which is a ultrasound cautery like, which is a harmonic cautery. Because there is no electrical dispersion that's happening.
Ma'am,
Okay, so
electrical
don't say
dispersion
normal
or
saline at all.
electrical-
Alternative to, there are better alternatives to glycine, which are probably not available, given in your textbooks though.
Ma'am, sorbitol, ma'am,
Yes,
cytal, mannitol.
very good. So how much
uh,
sorbitol and how much mannitol
uh,
percentage?
Ma'am, 3% ma'am sorbitol and 5% mannitol, ma'am.
3.5%. So you need to read this up, okay? And this is used in combinations where cytal is a combination of
Combination of ma'am
mannitol
sorbitol and mannitol. Sorbitol ma'am 2.7% and
And-
cytal 0.54, mannitol 0.54%.
and cytosol is another alternative, which is sorbitol in 0.25% acetic acid. These are isotonic and they are physiologically more appropriate, but they have the problems of availability and they're very expensive. Now that brings me to a question that, can you tell me what you mean by isomol? What is isomolality, isomolarity? What is basically plasma or serum osmolality?
Ma'am, isomolarity, ma'am, molarity is number of solute or osmotic activity present in a solution. Number of solute in a solution. If the solution is plasma, ma'am, it is known as osmolality.
So the basic difference with, and what all solutes are we talking about here?
Ma'am, ions, majorly, ma'am, the plasma osmolality is constituted by 3 ions, 3 solutes, ma'am: sodium, glucose, and urea. Osmolality is calculated by the formula 2 into serum sodium.
Other anions being chloride and bicarbonates. They also
bicarbonates.
So when we are talking in terms of okay, right, okay. And what is the difference between osmolarity and tonicity? Isoosmolar and isotonic same hota hai?
Ma'am, tonicity is the activity of the solute present in the solution. Yes, ma'am.
So osmolarity, let me just deconstruct it and make it simpler for all of you to understand. Osmolarity is nothing but a measure of the osmotic pressure of a given solution, which is defined by the amount of solutes present per liter of a solution. Right? That's clear? It's the concentration of the solute in a fluid per liter. Whereas tonicity is a measure of the osmotic pressure gradient between the two solutions which are separated by a permeable membrane. So tonicity is a comparative when we're talking in terms of plasma or any other solution. So we talk of whether it is isotonic, hypertonic, right? So it is the pressure gradient between the two solutions which are separated by a permeable membrane. Whereas osmolarity is simply your measurement of the concentration of solute in the fluid per liter of a solution. Right? So that's how we deconstruct osmolarity, and tonicity. So please do not get confused in the exam and do not let anybody get you all frazzled up over this. So this is a very important point to understand. So we have decided to go ahead for spinal anesthesia, and we know which is our choice of irrigating fluid. Are there any particular patient situations where you would like to give general anesthesia?
Yes, ma'am. If the technique is difficult to perform, local infection is present at the site, patient's refusal, bleeding disorders or coagulopathies.
Also in patients who are, having a severe cardiopulmonary compromise, these are the patients in which we actually prefer to go for general anesthesia because this gives us a better control of the hemodynamics and the respiration. You may require to go for an invasive cardiac monitoring in such patients. Do not forget that these are old patients who are very old. They may be patients with CAD, maybe patients with reduced ejection fraction, with reserved, compromised cardiopulmonary reserve. So very often you may need to give GA in these patients. So if you need to give general anesthesia, what are the points that you will keep in mind specifically for a patient who is for TURP?
in general anesthesia, ma'am, we won't be able to assess the mentation of the patient during the procedure.
No, what will you safeguards you will keep while giving general anesthesia in this particular patient? Okay, let me simplify it for you further. Would you like to intubate this patient, or are you happy going for a supraglottic device?
Ma'am, intubate the patient, ma'am.
Why?
Ma'am, because there is a decreased pulmonary compliance in these patients, old patients, ma'am. There is reduced FRC residual volume in these patients, which will increase the pressure, airway pressures during the surgery.
Anything that will compound it further? So this is, you must remember, what you're saying is partly correct. I would have been happier if you had said that this surgery is done in a lithotomy position, very often with a head down tilt, which would further reduce your tidal volume and your FRC. And also this increases the risk of gastric regurgitation. So you would like to go for a definitive airway, like a endotracheal tube rather than a supraglottic airway device, right? So
yes,
now, so how will TURP or a water intoxication syndrome manifest under general anesthesia?
Ma'am, in TURP, ma'am, there will be overhydration. It causes overhydration, ma'am. First, there will be signs of hypertension.
Do not use the term overhydration. Do not use the term overhydration. Use the term fluid overload.
Yes.
Batao.
Ma'am, signs of hypertension and bradycardia may be seen in patients undergoing general anesthesia.
Right.
Which would this increased fluid overload also causes a pulmonary edema in such patients, which will lead to hypotension, ma'am, and bradycardia in these patients.
So you will have hypertension and bradycardia initially, which may progress on to hypotension,
hypovolemia,
hypotension later on. And as you said, pulmonary edema से और क्या होगा? Cardiac के साथ और कुछ होगा?
Yes, ma'am. Cerebral edema also, ma'am.
नहीं, pulmonary edema से कोई और manifestation होगी? Saturation will start to dip.
Yeah, ma'am.
Right?
Yes, ma'am.
So
oxygenation will be hampered, ma'am, and saturation will fall.
You know? So you will have hemodynamic instability. How will it will manifest as hemodynamic instability, and there may be hypoxia. There may be a fall in the saturation. Anything else? Okay, so let's forget about general anesthesia. Just tell me the clinical signs and symptoms of TURP syndrome.
Yes, ma'am.
Forget about general anesthesia. वैसे ही बताओ क्या होगा?
Respiratory, ma'am, there will be hypertension.
Symptoms से शुरू करते हैं.
Ma'am. Yes, ma'am. First, there will be, ma'am, agitation, restlessness, which will be told by the patient, or which can be seen, ma'am, which can lead to seizures or convulsions and progress into coma.
उससे पहले क्या होगा? Restlessness के साथ जो first landmark signs होते हैं. Can I organizers? Can I continue? I think we started late. Nitin, bolo, nobody's listening to us.
Yes, ma'am. Signs, ma'am, when the signs and symptoms depend on how fast the serum sodium falls. So if the serum sodium falls,
first sign is your first symptom is patient will be agitated, will be restless, and will have nausea. Okay, so these are the very warning signs that your patient is going into a fluid overload. Okay, so you got to look into this. Then other signs and other symptoms will be patient will become disoriented. Patient can become throw seizures. And the symptoms, these are the symptoms. The signs would be, as you very correctly said, there'll be hypertension, there'll be bradycardia followed by hypotension, and
Ma'am, dyspnea will be there, ma'am. Pulmonary edema,
dyspnea.
dyspnea,
They can be fallen in
hypoxemia.
saturation. Yes, they
Yes,
can
ma'am.
be fallen in
Hypoxemia.
saturation. Very good.
Yes,
There will
ma'am.
be also
Ma'am,
ECG
ECG changes
signs.
can also be seen.
Yes,
ECG
yes,
changes
very good.
can also be seen, ma'am.
Very good. What are the ECG changes?
Ma'am, widened QRS complex, ma'am, ventricular ectopics and ST elevation, ma'am.
Yes,
When the serum
yes.
sodium level falls below 115 millicoulombs per liter.
Excellent, excellent. So under general anesthesia, although these signs, symptoms will be masked, but you will see cardiovascular instability. You will see ECG changes, which you just
Yes, ma'am.
mentioned. And very important is because there is going to be a tremendous electrolyte and solute changes, you will have a reverse.
Yes, ma'am, you can continue.
Right. Thank you, Shivpriya. Right? Is that correct, Nitin?
Yes, ma'am. Yes, ma'am.
Right. So this is how you're going to. Now, what are your intraoperative concerns? What all can go wrong intraoperatively?
Ma'am.
We just talked about TURP, right? What else can happen?
Yes, ma'am. Ma'am, toxicity to the irrigation fluid, ma'am. If we are using glycine, there is glycine toxicity and ammonia toxicity will be present in these patients. Ma'am, bleeding will be present. Bacteremia, septicemia, hypothermia can also precipitate in such patients.
And
ma'am, perforation. Yes,
Bladder
ma'am.
perforation. So how do you detect bladder perforation? How do you come to know there's been a bladder perforation?
Ma'am, perforation can be of two types in such patients: intraperitoneal and retroperitoneal. Intraperitoneal will be detected sooner. Patient will complain of nausea, vomiting, abdominal pain, which will further progress to shoulder pain due to irritation of the phrenic nerve secondary to.
Okay, bolo. What is more common, intraperitoneal or retroperitoneal perforation of the bladder?
Ma'am, retroperitoneal, ma'am.
Yes.
Because
So
the breach of prostatic capsule.
How will retroperitoneal manifest?
Ma'am, if there is a breach in the prostatic capsule, ma'am, the first thing the surgeon will notice is the irrigating fluid. The amount of irrigating fluid coming is not equal to the amount of fluid.
So there is failure of return of fluid, which will happen in both the situations. In retroperitoneal perforation, you will not get your classic abdominal pain and shoulder tip pain, but you will have a suprapubic, periumbilical, and an inguinal pain. So the character of pain is different. There will be tachycardia and hypotension followed by hypertension, and there will be failure of return of fluid. So these are three very important things that you keep in mind whenever you're thinking that there might be a bladder perforation. If the patient is under general anesthesia, there will be a sudden loss of relaxation and there will be irregular respiratory movements. This is how you detect your bladder perforation. Okay.
Yes.
Right. So we've talked about glycine issues, and let's just talk about now how to. I think we needn't talk about when higher rate of absorption. I think we all know this. So let's just talk about two very important things: that how do you detect, what are the objective methods of detecting excessive intravascular absorption during TURP, and what is the management? So what are the methods by which you can detect that there has been too much of a fluid absorption?
Ma'am, first we can see, ma'am, normally the fluid is absorbed.
Apart from your clinical signs and symptoms, what are the objectives?
At the rate of 1030 ml minute of resection time, and
No,
we
I'm
can
just
also
asking
carry
you.
amount of
Wait,
fluid
listen to my
absorbed.
question. Nitin, listen to my question. I'm asking you, how will you detect? Now, your patient has had a hypertension and bradycardia. You want to know whether it is due to fluid overload or whether it is due to any other cause. So how will you come to know?
Okay, ma'am. Ma'am, blood investigations, ma'am. I will send ABG, ma'am, and serum electrolytes.
You will go for serum sodium. You will go for serum osmolarity. You can go for your hematocrit. Anytime there is high fluid overload, the hematocrit will go down or go up?
Ma'am, go down, ma'am.
Go down. You can go for CVP and blood pressure management. You can correlate your blood pressure with CVP. That will give you an idea whether the patient is in fluid overload or not. And recently we have something known as ethanol tagged irrigation, wherein 1% ethanol is added to the irrigating fluid. And like you do for an alcohol detection test, ethanol
Yes,
detection breath test can be done, right? So the moment you start getting traces of ethanol in the breath, you come to know that your patient has now excessive fluid has been absorbed and you need to look into it. Now I want to tell me one thing. What is more dangerous for the patient, a hypoosmolarity or a hyponatremia?
Ma'am, hypoosmolarity, ma'am.
Why is that so?
Ma'am, because in hypoosmolarity there will be, ma'am, shifting of intravascular fluid into the extravascular compartments, ma'am, which will cause, ma'am, accumulation of fluid in the interstitium of lungs and, ma'am, in brain also.
Very good,
ma'am,
very good, very good, very good. So the more important factor is to go for a correction of osmolarity than hyponatremia. And the advantage with glycine has always been that it, even though it may cause hyponatremia, it maintains the osmolarity. The patients are more or less stable. Right, great. So that brings us to how will you manage hyponatremia?
Yes, ma'am. Hyponatremia, ma'am, can be managed with the clinical signs, ma'am. If there is no clinical signs and the serum sodium
when do you start?
is falling till 120.
Okay.
Yes,
okay. Then how will you start the treatment?
Ma'am, first I'll try to restrict the IV fluids and give furosemide to the patients to remove the extra fluid from the body. And if the serum sodium is falling
Nitin,
below,
we'll stop here. We'll stop here. There is only one indication of Lasix in TURP. What is that? Lasix can be a problem. Even though Lasix will remove the free water from the circulation, it will lead to further hyponatremia.
Loss of hyponatremia and mother.
Yeah, so why do you want to give Lasix as the first line of treatment? It is not the first line of treatment. You just said that you will start managing the patient when the patient has a low sodium less than 120, you yourself said, and we said the patient is in severe hyponatremia, right? Before that, we just give supportive therapy.
No, ma'am. In from hyper. Yes, ma'am.
हाँ बोलो.
Ma'am, in severe hyponatremia, we'll go for, ma'am, 3% hypertonic saline, ma'am.
Yes. So why did you say Lasix? There is only one
in case
indication
of fluid
of
overload, ma'am.
There is fluid overload. Hyponatremia is because of fluid overload. Hyponatremia is because of fluid overload, but Lasix is not your first line of treatment in TURP syndrome. Hypertonic saline is preferred. There is only one indication of Lasix, and that is when the patient has associated acute pulmonary edema caused by the hypervolemia. That is the only time that we use Lasix. Please remember this. We will go for, our management will be, I'm so happy you said that because I wanted to correct it. We want to start supportive therapy. We will stop surgery. We'll stop all IV fluids. Yes, by the way, what is our IV fluid of choice?
Ma'am, normal saline, ma'am.
Very
or
good.
ringer lactate, ma'am.
Not ringer lactate. It is normal saline because we would like to counterbalance the hyponatremia by giving normal saline. Remember, it is always normal saline, nothing else unless contraindicated. We will give supportive treatment. We will start vasopressors. We will not give fluids to treat the hypertension. We will give vasopressors, right? We will give atropine for the bradycardia. We will intubate and give IPPV wherever required. If the patient has seizures, we will give anticonvulsant therapy and even magnesium if persistent seizure therapy, persistent seizures, we will go for magnesium.
Yes.
Lasix is not your first line of therapy. Hypertonic saline is, right? Now, how does hypertonic saline work?
Ma'am, hypertonic saline, ma'am, the tonicity of the hypertonic saline is, ma'am, more than the plasma. Then it, ma'am, it retains the water, ma'am, inside the body, and sodium.
Basically, it is
sodium
going to
also.
shift the fluid from the intracellular to the extracellular compartment.
Extracellular, yes,
It
ma'am.
will correct the sodium levels. And a very nice thing about hypertonic saline is that initiates osmotic diuresis. Right? So your concept of fluid is also now clearing. Fluid is getting cleared out. Your sodium is getting corrected, and the fluid is getting shifted from the intracellular to the extracellular compartment. So that is how saline works. Now, problems with hypertonic saline?
Yes, ma'am. If ma'am saline infused faster, if the acute correction has been done faster, there are chances of cerebral pontine demyelinosis.
And earlier than that, as I said, it is going to expand the circulation, so it can lead to hypovolemia. It can itself lead to cerebral and pulmonary edema if given too rapidly. Okay.
Okay, ma'am.
Rather than correcting, it can further lead to that. So it is very important that you go for a proper slow correction. And what is that rate of correction?
Ma'am, it should not be more than 10 to 12 millicoulomb per day, ma'am, or 0.5 millicoulomb per hour.
Okay, right. So it should not be, some people say that, some people say not more than 1 millimole per liter per hour in first 24 hours and all. It depends, but you very correctly, you said that. Very good. Excellent. And how do you give your correction?
Ma'am, if I want to increase the serum sodium, if the body weight, it is given according to the body weight, ma'am. If the patient is around 70 kg and if I want to increase the serum sodium by 0.5 millicoulomb, then I'll multiply 0.5 into 70. Then I'll start this hypertonic saline at 35 ml per hour,
ma'am. No, what are you looking at? You'll actually go by twice the total body water, actually. 2 times the total body water will raise the serum sodium by 1 millimole per liter. Right? So that's how you're supposed to go. So if you took a 70 kg and you said 0.5, we generally take 0.5, 0.6. So taking 0.5, that makes it 35 liters. So twice of that is 70 liters over 1 hour of hypertonic saline over 1 hour will raise the serum sodium by 1 millimole per liter. But okay, never mind. Good enough. Good enough. Great. So excellent work by you, Nitin.
Thank you,
very, very well tackled, considering that I gave you no leading questions. I made sure that it was a totally spontaneous and extempore kind of a presentation. But I thought this would be good for you, so I went for that. Just one last question I have, which I love to ask as an examiner, and many examiners love to ask, is, and I think I did talk about it when we were discussing, is that very often apart from TU RP, you may be asked by your examiner that in case it's a bladder tumor, we go for something it's called TU RBT, right?
Yes, ma'am. Yes, ma'am.
So you've taken up the patient under spinal anesthesia. Everything was going well. You had a great level, and the surgeon says the patient is kicking me. What is happening there?
Ma'am, this is because, yes, ma'am, this is because of, ma'am, a sparing of obturator nerve. When there is electrical stimulation of obturator nerve near the lateral wall of the bladder, a reflex is generated, ma'am, and it causes abductor reflex, which can lead to perforation in these patients, bladder perforation in patients of TURBT.
Right. Very good. Very good. So that's a question that we all love to ask. So I just wanted to cover that up. Great job. This was very tough for you because I want to share with everybody that I didn't share any of the questions with him. I just told him what to study from, and I wanted him to have that ADR rush that happens with the exams. It was for him a total preparation for that, but you did a great job, Nitin. Excellent.
Thank you, ma'am.
So we'll just go on do we have any questions? I think we have some questions.
Yes, ma'am. We have few questions. First question is how ethanol comes in breath and detected.
So ethanol, Dr. Reena, ethanol gets absorbed along with the fluid and through circulation through the body, like it happens when you drink alcohol. Through the blood circulation, it then moves out from the pulmonary vessels into the lungs and out through our breath. And like breath detectors are used for alcohol consumption, similarly, this is used in such patients.
One more question is there, ma'am, from Dr. Siddharth. How does glycine maintains the osmolarity even though it is hypoosmolar in case of TURP?
So glycine, we use 1.5%. It is slightly hypoosmolar. It's like slightly hypotonic. It is not very hypotonic. So it is able to maintain its osmolar. It maintains the osmolarity. No, you mean it will not cause or isoosmolarity. It will also lead to hypoosmolarity, but not to the extent then as when we use distilled water. And the effect will be much less as compared to the hyponatremia. So this is what happens.
One question is there. Can you please repeat the significance or reason to achieve level T10?
So a level of T10 is extremely important because we want to, even though the pain fibers for the prostate are your sacral fibers, you must remember that while we are doing the TURP, there is a lot of distension of the bladder that's happening because all the fluid is being irrigated through the bladder, right? So we need a continuous distension of the bladder. Now that is a very painful and uncomfortable sensation for the patient. Since the pain fibers are till T11 of the bladder, we want to go for a T10 block. And we don't want to go beyond that because we don't want to mask the pain. Like supposing I went up to T6. Now, if I would be masking the pain of a bladder perforation then, because I will not get the sensation of peritoneal irritation, where that would happen when the irrigating fluid goes into the peritoneal cavity. So that is why we restrict to T10.
One last question is there, ma'am. Patient is under spinal anesthesia, then how will he complain of inguinal pain?
It is called the breakthrough pain. That will happen,
yes,
irrespective of your spinal block. And along with the inguinal pain and the suprapubic pain, there will also be a periumbilical pain. So this is a very classic seen with retroperitoneal bladder perforations, which are actually more common than your intraperitoneal bladder perforations.
That's all in the chat box, ma'am. It was such a detailed case discussion. I think you have not left anything. It was a short.
I've taken more time. I'm extremely sorry for that.
No, ma'am. Actually, we were so engrossed, so we thought, no, it has to be. So
I'm so grateful to you for that. I was enjoying myself so much. I lost track
that's
of the
what
time.
we were also enjoying, ma'am. So we didn't want to interrupt you.
Aarti, can I add? That was a lovely discussion.
Oh, thank you so much coming from you, Dr. Gurmi. I'm
not at all. It was
so good.
as complete as it can be, and it will be. I'm sure it's going to be very helpful for the trainees. Excellent, excellent moderation.
Thank you so much. Coming from you, it means a lot.
And thank you, Dr. Bharti.
Thank you so much, ma'am.
Hidden from the screen, I'm also there watching you. Thank you so much.
Thank you, ma'am. It's always a pleasure to be part of it. Like, you're doing a great job, ma'am.
Yeah,
thank you for inviting me.
Great, great.
Thank you so much, ma'am. So I'll just now of today's. Can I have a quiz of the day? Quiz 1. So these are the two MCQs. First question is the paravertebral block is given between A, superior costotransverse ligament and the pleura, inferior costotransverse ligament and the pleura, transverse process and intercostal muscles, transverse process superior costotransverse ligament. Second question is, following statement is correct regarding PEG block. In PEG 2 block, 20 ml of local anesthetic is injected between the lateral edge of pectoralis minor and the serratus anterior at the level of first rib. B, the aim is to block the lateral rami of intercostal nerves and long thoracic nerve. C, PEG 1 block is useful for most of the breast surgeries, including axillary dissections. D, the lateral pectoral nerve and medial pectoral nerve are the main branches of the brachial plexus that innervates pectoral muscles. let us now proceed to our next long case presentation that is going to be very interesting, which the case will be presented by Dr. Astha Sahu. She's a postgraduate AB WIMS and Dr. RML, and it will be moderated by Dr. Devang Bharti. He's an assistant professor in AB WIMS and Dr. RML Hospital. And the external for this case will be Dr. Vimi Rivari. She's a professor in Department of Anesthesia, Pain Medicine and Critical Care in AIIMS, New Delhi. And her areas of special interest are critical care, hepatobiliary and liver transplant, acute pain, and simulation. I welcome you, ma'am. Over
Thank
to you, ma'am.
Thank you, Kanchi. Yeah, Astha, are you ready?
Yes, ma'am.
So you can begin, Astha. I think we are already
ma'am.
running a little late. So
Good morning, ma'am. Good morning, everyone. I'm here to present a case of Mrs. Priya. She's a 40-year Hindu female. She's a former athlete by occupation. She's a resident of Rajouri Garden, New Delhi.
I can't hear you, Astha.
Ma'am, 1 minute, ma'am.
Okay.
Presented with the chief complaints of decrease in urine output since 1 year and decrease in swelling in face and legs since 7 months. History of presenting illness. My patient was apparently well 1 year back when she noticed decrease in the volume of urine, which was insidious in onset and gradually progressive. Initially, the frequency of urination was 6 to 7 times per day, with the volume of urination was approximately 2 cups per urination, which gradually decreased to a current frequency of 2 to 3 times per day, with the volume remains half cup per urination. There is no history of pain in the flank region or any radiating pain to the perineal region. There is no history of fever, pain, or burning micturition. No history of foul-smelling urine or frothiness or blood in the urine. A patient had no history of consumption of any Ayurvedic medications. There was a history of long-term consumption of over-the-counter painkiller tablets. She also noticed swelling in the face and legs since 7 months, which was insidious in onset and gradually progressive. In the face, the swelling was more prominent around the eyes, which was noticeable more in the morning when she wakes up and gradually decreases as the day progresses. Her swelling was uniform around the eyes. It was not associated with redness, itching, or pain. In the leg, swelling was limited to the feet, which was increased as day progressed. The swelling was aggravated by increased fluid intake and decreased on fluid restriction. There is no history of breathlessness, palpitations, or abdominal distension. No history of excessive thirst, hunger, or vision changes. No history of recurrent sore throat or skin infection. No history of skin rash or joint pain. My patient reported.
Astha, just a minute. So can we go a little slow? In the first chief complaint, you said the patient had a history of decreased urine output, right?
Yes.
Can you go back to the slide?
Yes, ma'am.
Yeah. So why did you need to ask all this negative history? What are you trying to determine by asking all this negative history?
Okay, ma'am. Ma'am, about the pain in the flank region and radiating pain, ma'am, I'm ruling out any obstructive uropathy. About ma'am fever, pain, or burning micturition, I'm ruling out ma'am any urinary tract infections. Ma'am, again, ma'am, foul smelling urine is also for ma'am UTI and any frothiness. Ma'am, it denotes if there is any infection or even proteinuria can also lead to frothiness in the urine, ma'am. Or blood in the urine, ma'am, again hematuria, ma'am. So that will, if I'm ruling out if there is glomerulonephritis.
Okay.
And ma'am, yes, ma'am. Ma'am, consumption of Ayurvedic medication, ma'am, because this Ayurvedic medication, it consists of heavy metals, which
Correct.
can lead to acute renal failure, ma'am. That's everything.
Okay, fine. Next slide.
Okay, ma'am.
So when a patient complains of swelling on the face and legs, so what kind of history are you trying to elicit? in terms of trying to reach a diagnosis. So what kind of a question will you ask to differentiate between different causes of swelling? Because what are you most bothered about in these patients?
Ma'am, because of the kidney failure, ma'am, this patient, ma'am, there will be volume, ma'am, volume expansion will be there, ma'am, ma'am, which will lead to this fluid will accumulate in the body, ma'am. So, ma'am, I will differentiate, ma'am, ma'am. This because of this swelling, ma'am, it can denote a cardiac cause as well, ma'am. So I have to rule out the cardiac causes. Also.
So basically, it could be because of two reasons. First is because of the kidney per se and fluid overload as a result of kidney dysfunction. And the second could be an underlying cardiac cause or secondary cardiac dysfunction because of the CKD, right? Okay. So yes. These are the two things you're trying to differentiate, which may or may not be possible by history alone, right?
Yes, ma'am.
Okay, go on.
Ma'am, there is no history of breathlessness, palpitations, or abdominal distension. No history of excessive thirst, hunger, or vision changes. No history of recurrent sore throat or skin infections. No history of skin rash or joint pain. Ma'am, my patient reported to RML hospital with the above mentioned complaint where she was worked up, evaluated, and investigated for the same and diagnosed with renal failure and was started on medication and dialysis. My patient had history of fatigue and decreased appetite, which got relieved after starting on dialysis. And now, ma'am, my patient is posted for renal transplant. Past history, she is a newly diagnosed hypertensive since 7 months and started on BP lowering medication. She is compliant to medication and well controlled on medication. There was no history of diabetes mellitus or any other comorbidities, no history of any drug allergy. My patient had a history of trauma to the right knee in 2010 while participating in a competitive sports. She had complained of long-standing severe pain in the right knee. She consulted a doctor for the same and was diagnosed with right ACL tear and operated in 2012 under spinal anesthesia, and which was uneventful. But still she experienced a persistent pain and continued to take over-the-counter painkiller tablets for past 12 years. There is no history of any other surgery or anesthesia exposure, and there was no history of blood transfusion. Treatment history. She is on tablet amlodipine, 5 mg BD since 7 months, tablet telmisartan, 40 mg BD since 7 months, injection erythropoietin, 4,000 units twice weekly till 7 months, tablet calcium, 500 mg BD, and vitamin D3 sachet. She is on hemodialysis since 7 months. Ma'am, initially the dialysis session was twice per week, presently since 5 months, and which increased to thrice per week since last 2 months. Her each dialysis session was around approximate for 4 hours. Initially, the dialysis session was undergone through a catheter, and subsequently the AV fistula was created on the left forearm, and after that the dialysis are undergone through AV fistula since 5 months. Her dialysis sessions were uneventful. Personal history. She's a married woman with a 10-year-old son. Her husband works in an IT company. She consumes a non-vegetarian diet. She's a non-smoker and non-alcoholic, having normal bowel habits, normal appetite, normal sleep-wake cycle, and no known allergy to food. Family history. She lives in a nuclear family and there was no similar complaints in the family. Socioeconomic status. She belongs to a lower middle class according to modified Kuppuswamy scale. Her menstrual history, she attained a menarche at the age of 12. Her menstrual cycle is regular with a normal flow lasting for 3 to 4 days. Her last menstrual period was on 22nd of February. Obstetric history, she is G1, P1, live L1 with the full-term normal vaginal delivery at hospital 10 years back. Ma'am, in general physical examination, after taking informed consent from the patient.
Just a minute.
Yes,
so after the history, what is your provisional diagnosis?
Ma'am, after the history, my provisional diagnosis will be my patient is with a known case of hypertension with chronic renal failure, ma'am.
So is the hypertension a consequence of CRF, or the CRF is a consequence of hypertension? Because you have to word your diagnosis accordingly.
Ma'am, in my case, ma'am, might be my patient has landed into chronic renal failure because of the analgesic abuse. And ma'am, this hypertension is the consequences of CRF.
So you would like to reword it as a patient with chronic kidney disease with associated hypertension, right?
Yes, ma'am.
So that is the only comorbidity that you know as of now. Rest
Yes.
is going to be revealed only after examination and proper investigation, right?
Yes, yes, ma'am.
Okay, go on.
General physical examination. After taking informed consent from the patient prior to the examination, my patient was conscious, cooperative, oriented to time, place, and person. She is sitting comfortably on the bed. She is moderately built and nourished. Her weight is 60 kg. Height is 160 centimeter. BMI of 23.4 kilogram per meter square. Pallor present. There is no icterus, clubbing, cyanosis, or lymphadenopathy. Bilateral pitting pedal edema present. A neck veins not engorged. Her pulse rate was 68 per minute, palpated on the right radial artery, which was regular, good in volume and character. Arterial wall was not felt. There was no radioradial or radiofemoral delay. All peripheral pulses were palpable. Her BP was 136 by 84 millimeter of mercury, measured in a right upper arm in sitting position, and 130 by 80 millimeter of mercury in the standing position using an appropriate sized cuff. Her respiratory rate was 14 per minute, regular, abdominal thoracic type. Room air saturation was 97%. She was afebrile to touch. AV fistula was present in the left forearm, which was pulsatile, no redness or thrill present. Her venous access seems to be difficult. On airway examination, there is no visible maxillofacial abnormality, good oral and dental hygiene, no loose artificial or buck tooth present. Interincisor gap was 5 centimeter. Modified Mallampati grade 2. Calder test was normal with the normal functioning of a temporomandibular joint. Upper lip bite test grade 1.
That's okay. Asta, you can carry on. So the airway examination is
normal, ma'am.
Yes. So you can proceed. Aage.
Ma'am, in cardiovascular system also, ma'am, the cardiovascular system was also normal. In inspection, there was no pericardial bulge, visual pulsation of venous deformity, scar mark of previous catheterization present in the right side of the neck. In palpation, the apex beat palpated the left fifth intercostal space, 1 centimeter lateral to mid-clavicular line. In percussion, cardiac borders could not be adequately percussed. On auscultation, heart rate is 78 per minute, regular. S1, S2 heard. There was no added sound or murmur or rub noted. Coming to respiratory system, in inspection, respiratory rate was 18 per minute, abdominal thoracic type, bilateral chest movements were equal, no audible wheeze or stridor.
Asta, instead of reading out all this, can you tell us what exactly are you, knowing that the patient has chronic kidney disease, what are you looking for both in the cardiovascular system and the respiratory system on examination?
Okay, ma'am.
So because if your patient has largely normal findings, the audience will not be able to know what are you looking for, right? So yes, what are the important findings that you want to rule out in these patients?
Ma'am, in cardiovascular system, I'm rule out if there is any presence of arrhythmias. Ma'am, then ma'am, cardiomegaly, there is, or ma'am, I'm, yes, ma'am, ma'am, arrhythmias, cardiomegaly, ma'am, any murmurs, ma'am.
Right, very good. What else?
Ma'am, I'm rule out. I'm trying to rule out an presence of congestive heart failure, ma'am.
Correct. So, what are you looking for to rule out congestive heart failure?
Ma'am, I will look at the raised JVP, ma'am.
Okay.
Ma'am, presence of ma'am, crepitation, ma'am.
Correct. So that will come in the respiratory system, but presence of basal crepitations initially, unless the patient has florid pulmonary edema, where you will have crepitations all over the chest, right? Which is unlikely. Okay. Then what else?
Ma'am, hepatosplenomegaly, but ma'am, that will be a sign of congestive heart failure.
Okay.
Ma'am, ma'am, I will also auscultate for the pericardial rub, ma'am, for the presence of pericardial effusion, if present, ma'am.
No, so there a pericardial rub is more often associated with pericarditis and very small amount of pericardial fluid. So if you have significant amount of pericardial fluid or effusion, what are your findings going to be?
ma'am, cardiac tamponade, ma'am.
No, that is an extreme form of pericardial effusion. There, the patient is going to be hemodynamically unstable. Okay, so if you have significant amount of pericardial effusion, you're going to have muffled heart sounds. Okay, your heart sounds are not going to be very clear. Classically, they're called muffled heart sounds, and obviously the cardiac border is also going to be enlarged. So these two findings on examination are going to be evident, right?
Yes, ma'am.
And pericardial effusion is a very, very common finding in patients with CKD. It may or may not be significant, but invariably they have some amount of pericardial effusion, right? So you may not be able to detect it on examination. You will be able to detect it on examination only if it is significant, right? Most of these patients who are on dialysis, because of their efficient fluid removal, do not have fluid accumulation in pericardial space and pleural spaces. Understood? But there is possibility of having some amount of fluid. So you definitely have to rule it out. Okay, what about the heart sounds?
Ma'am, heart sound, ma'am, that arrhythmias can be there, ma'am, and ma'am, muffled heart sound, as you told, ma'am, and
what do you hear in a heart failure? What kind of heart sounds do you get?
Ma'am, S3,
correct.
Gallop rhythm, ma'am,
Yeah.
S3 sound.
Yeah. So that could be present. And what else? What about murmurs? What murmurs are you expecting in this patient? Say the patient does not have a valvular heart disease. Patient may have a coincidental valvular heart disease, which you have to roll out. But if the patient does not have a underlying valvular heart disease, what murmurs are you looking for?
Ma'am, my patient, as ma'am, he's a hypertensive, ma'am, and there will be left ventricular hypertrophy as well, ma'am, and congestive heart failure, ma'am. Systolic or diastolic murmur can be heard, ma'am.
What is diastolic and systolic murmur? So what there are two things. If the patient has significant involvement of the heart because of CKD, these patients are often at increased risk of ischemic heart disease, right? Or coronary artery disease. So if the patient has had a previous ischemic episode or infarct, it can be associated with MR, right? So you can get a murmur of MR. Or if the heart disease or the dialysis has been going on for a very long time, these patients can also have pulmonary hypertension. So when these patients have pulmonary hypertension, the patient can present with a murmur of TR, right? Tricuspid regurgitation. So these are the two things that you're looking for, which can indicate some underlying cardiac comorbidity, right?
Yes, ma'am.
Okay, fine. So what about the respiratory system? What are you looking at in the respiratory system?
Ma'am, in respiratory system also, ma'am, because of the volume overload, ma'am, I can find crepitation in the chest, ma'am.
That is if the patient has the florid pulmonary edema, right?
Yes, ma'am.
Okay. And what else?
Ma'am, patient will be tachypneic, ma'am. Tachypnea will be there.
Okay.
And ma'am, because of the fluid overload, there can be pleural effusion, ma'am.
Correct. What else?
And
what is one thing that you hope to rule out before taking up this patient, which you rule out in every patient in a PAC, but it is especially important for these patients? Presence of a lower respiratory tract infection. Okay, Asta? That you have to definitely rule out in these patients, because these patients are going to be on immunosuppression and in post-operatively, and that can flare up. So you have to be sure, because when you hear crepitations or conducted sounds in the respiratory system, you have to be very sure what is the origin of these crepitations. So if these are fine crepitations only in the basal region, it's most probably due to a cardiac reason. Okay, but if you have a localized crepitation in a certain part of the lung, it could be an indicator of a lower respiratory tract infection, right? Or if they are coarse crepitations, right? So you have to be especially careful about ruling the presence of a lower respiratory tract infection. Is that clear?
Yes,
And you
ma'am.
have to highlight this in your presentation,
Okay, ma'am.
right? Okay,
Yes, ma'am.
go on. Next system, yeah.
Okay. Ma'am, in abdominal examination inspection, abdomen is normal shape, umbilicus central in position, normal in shape, scar mark present on the bilateral groin region. There was no sinus or venous pulsation, no visible lump or hernia site is free. Now, on palpation, all 9 quadrants were palpated. Stomach was soft, abdomen was soft and non-tender, no fluid thrill, no organomegaly. On percussion, ma'am, tympanic note on percussion, no shifting dullness. Upper border of liver was liver dullness was on the right fifth intercostal space, mid clavicular line. On auscultation, ma'am, normal bowel sound heard. Coming to central nervous system examination, her higher mental function was normal, cranial nerves was intact, motor function was normal in tone and power. There was no atrophy, no abnormal movements. All sensory function and reflexes were normal, normal gait, and cerebellum and autonomic function was normal. Ma'am, in musculoskeletal.
No, do you expect any abnormalities in the CNS for these patients?
Yes, ma'am. Ma'am, if a patient is in, if there is a uremic syndrome, if patient is in uremic encephalopathy, ma'am, there will be, patient will be in altered sensorium. Patient will be irritable, ma'am, confused. And
so one is presence of encephalopathy. What else?
Yes. Ma'am, there will be, ma'am, polyneuropathy, autonomic dysfunction might be there, ma'am. And they, ma'am, in this patient, there will be mixed sensory and motor distal polyneuropathy will be there.
Correct. So once you rule that out, why? Why? Especially if you are planning why do you want to rule out the peripheral neuropathy?
Ma'am, because ma'am, if ma'am, I have to rule out peripheral neuropathy, ma'am, because ma'am, it denotes a severity of renal disease and.
So as anesthetist, what is important to you is that the presence of neuropathy tells you could be because of 2 things. One is because of the renal or uremia or renal failure, which is less likely, but more often the majority of these patients will have diabetes. Okay, so diabetes itself can lead to increased incidence of peripheral neuropathy. And why is it important for us to know that is first is peripheral neuropathy, second is autonomic neuropathy. Autonomic neuropathy is very evident, and peripheral neuropathy, why we need to know is in case we are planning to give regional anesthesia. Okay, so if you are planning to give regional anesthesia, it is very important to document the presence or absence of peripheral neuropathy and what kind of peripheral neuropathy. Okay, then it becomes medically important, right?
Yes.
And to prevent what? Prevent injuries during positioning. Okay? Yeah.
Okay. Ma'am, so my provisional diagnosis is a 40-year-old female. It's a known case of hypertension and history of long-term analgesic abuse. Is a case of chronic kidney failure posted on medical hemodialysis, posted for renal transplant.
So one more thing, Asta, one thing that you missed in history was for CNS, did you ask for history of TIAs? Can these happen in these patients? And what kind of history will you ask?
Ma'am, I can ask for if a patient had sudden loss of consciousness or sudden fall, ma'am. And ma'am, I can ask for ma'am, history of altered sensorium, ma'am. If patient have a seizure, any seizure history, ma'am.
Seizure will not tell you. What I'm trying to ask you is that how will CKD affect the CNS?
Ma'am, because
you tell encephalopathy as a consequence of uremia. What else?
Ma'am, CKD is also, ma'am, a hypercoagulable state, ma'am, and because it can lead to thrombosis thrombosis and ma'am, which can increase the incidence of cardiovascular accidents, ma'am.
Okay, what else? What else? More importantly, it is associated with vascular disease. Okay, so just like you have coronary artery disease, you can also have cerebrovascular disease because of arterial stiffening. Okay, so these patients can have carotid thickening and decreased flow through the carotids, which can initiate a TIA. So that is why it is important. And this is especially important in patients who are slightly elderly, okay, more than 50 maybe. Okay, so in younger patients, it's less likely, but for the sake of completion, you need to ask or rule out any such reasons for suspecting the cerebrovascular disease. Okay. Yeah. Okay, so you have this diagnosis of this patient who has CKD and is on dialysis. Okay, so if the patient is on dialysis, what is the estimated GFR for this patient?
Ma'am, estimated GFR will be ma'am, approximate 10 to 15 ml per minute per 1.73 meter square body surface area, ma'am.
So it should be less than 20 ml per kg per 1.73 kg per meter square. Okay, so only when it is less than 20 do you initiate dialysis or any form of renal replacement therapy. Okay, because you do not hurry to start dialysis because dialysis itself has a lot of complications. Right. In fact, if the patient has been on regular follow-up and is aware of the situation of his disease, it is sometimes advisable that the patient undergoes a renal transplant before going on to dialysis, because it prevents all the complications of dialysis. And in fact, the graft outcome becomes so much better without initiation of dialysis. But this is not very possible in our setting. So most often when these patients come to us for renal transplant surgery, they are often on dialysis, which is long term. So already the complications of dialysis have set in, which kind of reduces the graft survival later on. Okay, so the earlier you get a renal transplant, the better. Okay. Yeah. So this patient has come to you, you know the history and the examination. So what kind of investigations would you like to know as an anesthetist?
Okay. Ma'am, I will like to ma'am complete that count of the patient, which will include ma'am hemoglobin, total leukocyte count, and platelet count. Ma'am, blood urea, ma'am nitrogen level, ma'am serum creatinine level, ma'am serum electrolytes will include potassium, calcium, magnesium, phosphate levels, and ma'am sodium levels. And ma'am, then I will like ma'am LFT in liver function test, ma'am especially serum protein levels. Ma'am, then I'll go for ma'am urine analysis of the patient, ma'am, coagulation profile.
By urine analysis?
Ma'am, urine analysis, ma'am, I have to look for any microalbumin urea, protein urea.
How will that help you as an anesthetist? This patient who is on dialysis, it's very unlikely that the patient will have a significant urine output. Okay, most often, even if they have, it's about 100 to 200 ml of urine only. They are oliguric or anuric most of the times. So how will you get a urine analysis done? See, urine analysis is done in the initial workup of CKD, where mostly to establish the diagnosis, right? At this level, when the patient has come to you for renal transplant, urine analysis is not important, right?
Okay.
By now, the cause of kidney disease has already been established and the patient is on dialysis, right?
Yeah, okay. Yes. Ma'am, ma'am, arterial blood gas, ma'am.
I would advise you, I mean, I as an examiner, like a candidate, it's different for everybody, that everybody knows, but as an examiner, I would like to know from you the investigations which are useful to us as anesthesiologists. Okay, so I would prefer for you not to say the routine rattle of all the investigations, because they are of no use to you as an anesthesiologist. Okay, so urine analysis is already done and dealt with. So we come to the investigations which will help you plan your anesthesia. Always remember, all the investigations which will help you tailor your anesthetics is the one that are required, right?
Okay, ma'am.
Okay, go on.
Ma'am, then that will include, ma'am, again, complete that count. Ma'am, kidney function test and and ma'am, LFT, which will include serum, ma'am, protein levels,
Yeah.
ma'am, coagulation profile, arterial blood gas.
So what coagulation profile are you looking at?
Ma'am, mostly, ma'am, I will look at, ma'am, bleeding time and clotting time. And ma'am, in coagulation profile, ma'am, prothrombin time and INR, ma'am.
Prothrombin time and INR. Why do you expect prothrombin time to be deranged in these patients?
Ma'am, it will not be deranged, ma'am, but I want to look for, ma'am, INR. So, ma'am, because my patient have increased risk of bleeding, so the INR should be in the normal range, ma'am, so that they will be intraoperatively.
No, Asta. Why will it be deranged? Unless the patient has an underlying coagulopathy or the patient has liver disease, why should the INR be deranged? You will get it, all right. But
ma'am, that I will, ma'am, this is. Ma'am, I will get it, ma'am, because it is my institutional protocol as well, ma'am. And
So listen. So what I'm trying to ask you is that what are the abnormal coagulation parameters that you expect in these kind of patients?
Ma'am, it will be, ma'am, abnormal bleeding time or clotting time, ma'am.
Because of what?
That can be.
Because of what? What does the bleeding time and clotting time tell you?
Ma'am, ma'am, because of the, ma'am, because of the qualitative function, ma'am.
Let me reframe my question. How does kidney failure or kidney disease affect the hematological system?
Ma'am, it will cause, ma'am, anemia, ma'am.
Right. Very good. What else? That is because of what?
Ma'am, because of the deficiency of erythropoietin.
That is one.
And ma'am, and the life. Yes, ma'am. Ma'am, second, ma'am, the lifespan of RBC will be reduced, ma'am, because of uramic toxins. Ma'am, that is the another cause.
Okay.
Ma'am, thirdly, ma'am, this patient might have, ma'am, nutritional deficiencies also, ma'am.
Because they don't have good appetite, so that is also right. What else?
Yes, ma'am. Ma'am, because of the, ma'am, if there is uramic gastropathy, the patient will have risk of GI bleeding, ma'am.
Correct. Very good. So these are the reasons why these patients can present with anemia. Okay.
Yes, ma'am.
Okay. One is anemia. What else?
Ma'am, patient will have increased risk of infection, ma'am. So might be they will raise TLC count, ma'am, in this patient.
Okay.
Okay. Ma'am, platelet count will be normal, ma'am. Mostly it is normal in this patient. Ma'am, in this patient, there will be, ma'am, deficiency of von Willebrand factor and the factor 8 complex, ma'am. And ma'am, and there will, ma'am, qualitative platelet dysfunction is there in this patient, ma'am.
So these patients will often have thrombocytopathy, right?
Yes,
Not
ma'am.
they may or may not have thrombocytopenia, but they can have thrombocytopathy, right? Okay.
Yes.
What else?
Ma'am, qualitative. Ma'am, in hematology.
No, so fine. This is the kind of coagulation abnormalities that you're going to expecting to see in these patients. So what tests are you going to do to detect these?
Ma'am, I can, ma'am, that first to, ma'am, bleeding time, clotting time, ma'am, I can go for, ma'am, thromboelastography, ma'am, to evaluate for the platelet function, ma'am.
Okay. What else? What else?
Ma'am,
and the
there's
platelet count also, because sometimes severe uremia can also cause decreased levels of platelets also. So platelet count and like you said, BTCT, although the information that it gives out is not very accurate, but most institutes do practice that, doing a BTCT. Okay. What else? Okay, fine. What else now? Besides, what other investigations will you do? And one more thing that we've skipped is that what about the heparin that is used during dialysis? That can also lead to coagulopathy.
Coagulopathy, yes, ma'am.
Yeah, so we should always remember if the patient has had a recent dialysis, that also with heparin. In most of the cases, if the patient needs a dialysis within 24 hours, it is done heparin free. But if the heparin has been used for some reason, then the patient can have a coagulopathy, right? What is the half-life of heparin?
Ma'am, 5 to 6 hours, ma'am.
Half-life.
Ma'am,
Half-life
is
that has been used about 50 units per kg. That is
2 to 3 hours, ma'am, and it is
about 2 to 2.5 hours, 90 minutes. Okay. So okay, go on then.
Ma'am, about other investigations.
Yeah.
Ma'am, other investigation, ma'am, it will include, ma'am, ECG. Ma'am,
So what are you looking for in ECG specifically?
Ma'am, specifically, I will look for, ma'am, any electrolyte disbalance, which arrhythmias, ma'am, and ST changes, ma'am. That
so arrhythmias. What kind of arrhythmias are you looking for specifically in these patients? The patient can have any arrhythmia, but what are the common arrhythmias that you're looking for here?
Ma'am, because of the hyperkalemia, ma'am, this patient will.
No, hyperkalemia, the patient will not come to you if the patient is having such a severe hyperkalemia and having arrhythmias because of that. Okay, the patient is too sick then. You can see evidence of hyperkalemia by looking at what changes in the ECG.
Ma'am, T wave changes, ma'am.
What T wave changes?
Ma'am, tall T waves will be there, ma'am.
Okay, what else?
Or ma'am, might be prolonged PR interval, or ma'am, a widened QRS complex. Later, ma'am, flattened P waves, and there will be sine wave pattern, ma'am, and which can progress to.
Fine. One is changes of electrolyte abnormalities, and
yes,
in which there is hyperkalemia, you said. Okay, what else?
Ma'am, left ventricular hypertrophy might be there, ma'am.
Okay, fine. What else?
Ma'am, ma'am, if there will be ischemia, ma'am, ischemic heart disease, so I can see, ma'am, ST changes, ma'am.
Evidence of underlying coronary artery disease. Okay, could be so many things. Okay, what else? Arrhythmias. What arrhythmia is most common in these patients? So atrial fibrillation, Asta. Okay, atrial fibrillation is something that you see commonly in these patients, and you need to rule that out. Okay, so underlying coronary artery disease, atrial arrhythmias, then electrolyte abnormalities, and what else?
LVH changes, ma'am, left ventricular hypertrophy changes.
Okay.
And
good. Okay, fine. So ECG you've done, and we go on to the next investigation. What else will you see get done?
Ma'am, next will be ma'am, chest X-ray. I will look.
Chest X-ray. You will look out for.
Ma'am, pleural effusion, ma'am, if presence of pleural effusion, or ma'am, cardiomegaly, ma'am. That can.
So cardiomegaly will always be there in most of these patients because of LVH or presence of pericardial effusion. Both of these things. What else?
Ma'am, pleural effusion.
Again, signs of any pneumonia or consolidation on the chest X-ray. That needs to be ruled. Okay. What else? Okay, fine. Chest X-ray. What other investigation do you need?
Ma'am, 2D echocardiography, ma'am.
So what are you looking for? Very good. That is very essential in all patients. That is mandatory. Okay. So what information are you looking for? So the cardiologist has written a detailed report on the findings on echocardiography. So what are you going to look at, and how will you decipher it?
Ma'am, I can look for the ma'am chamber size, ma'am.
Okay.
And
so what chamber size are you looking for specifically?
Ma'am, left ventricular, ma'am, there can be left ventricular hypertrophy in this patient.
That's already there. Most patients will have, majority of patients will have LVH. Okay. So what specifically, what chamber and the size of which chamber is most important?
Ma'am, Ma'am, in this patient, ma'am, right, ma'am, ma'am,
Left
there will
atrium.
congestion.
Left atrium. Why? Why left atrium?
Because my
Because
ma'am,
these patients have left ventricular hypertrophy, and the most common cardiac dysfunction associated with left ventricular hypertrophy is a diastolic dysfunction. And if they do have a heart failure, it is a heart failure with preserved ejection fraction, which means the ejection fraction will be normal, more than 40%, but will be associated with a diastolic dysfunction. And diastolic dysfunction means that the left ventricle is less compliant. It is more stiff because of the hypertrophy and because of the fibrosis, which is initiated to some extent because of the CKD, and majority of these patients, because they are on dialysis, the dialysis itself induces myocardial fibrosis. Both of these things together can lead to a very stiff, non-compliant LV, which leads to a back pressure change to the left atrium. And that is why the left atrium enlarges, the volume increases. Okay, so that is what you are looking for in the echocardiography, the size of the left atrium. So there are a lot of modalities to diagnose diastolic dysfunction, which can range from grade 1 to grade 3. Okay, so you don't need to know the details of that at your level, but you can only say that we are looking out for diastolic dysfunction, right? And the grade of diastolic dysfunction. Okay, fine.
Okay.
What else are you going to look for in the echocardiography?
Ma'am, pericardial effusion.
Correct. Okay, and one more thing, which I mentioned earlier also.
Ma'am, mitral regurgitation. Yes, ma'am.
Tricuspid regurgitation. Okay. How will you know the patient tricuspid regurgitation? I already explained to you, because of to rule out pulmonary hypertension. You can also know the PA pressures, but PR is an indirect indicator of pulmonary hypertension. Okay, and you also have to look out for signs of coronary artery disease, which could manifest as regional wall motion abnormalities, right? So that can be evident on the echocardiography, right?
Okay.
And what kind of if you're suspecting the patient has underlying coronary artery disease, would you like to modify this echocardiography?
Ma'am, I can go from a Doppler, ma'am.
No, you can go in if the patient has risk factors for coronary artery disease, which are, what are the risk factors for coronary artery disease?
Ma'am, hypertension, ma'am, hypertriglyceridemia.
Correct, very good.
And ma'am, smoking, if patient have, ma'am, history of smoking.
Yeah.
Lifestyle, ma'am, sedentary lifestyle will be there, ma'am. And
diabetes.
Diabetes.
Right. Diabetes
Yes,
is also a very big risk factor for coronary artery disease. Okay, so if the patient has any of these more than 3 risk factors, you would like to go in for a non-invasive cardiac testing, right? So which is the one that you would prefer?
Ma'am, stress, ma'am, I'll go for stress ECG or stress echo, ma'am.
Stress echocardiography. And most often these patients are not a very good physical condition. They are often frail. So you would like to go in for a dobutamine stress echocardiography. If you're suspecting or the patient is at a high risk of coronary artery disease, right? If not, a plain 2D echocardiograph is normal, is all right. You don't need to go in for a dobutamine stress. Okay, so a dobutamine stress echocardiography will unveil the underlying coronary artery disease or regional wall motion abnormalities, which can be more evident, right? On a dobutamine stress.
Okay.
And you go with the dobutamine stress echocardiography only if you're suspecting a underlying coronary artery disease, or the patient has more than 3 risk factors for coronary artery disease, right? Okay. So echocardiography, you said. What else? Anything else that you would like the patient to get done before you plan your anesthetic?
Ma'am, that's all, ma'am.
That's all. Okay. Fine. I think that is about all. Okay. So this patient, the investigations are all normal. Okay.
Yes, ma'am.
So what is the preoperative instructions that you will give and the pre-operative medication.
Okay, ma'am. Pre-op, ma'am, instruction, ma'am. First, ma'am, firstly, I will, ma'am, I will ask my patient to continue all antihypertensive medication, ma'am, for optimization of BP, ma'am. Ma'am, I will optimize the serum potassium level of this patient. Ma'am, I will
how will you optimize the serum potassium? And what serum potassium are you targeting?
Ma'am, it should be less than 5.5 milliequivalents per liter, ma'am.
Okay.
Serum potassium.
And how will you optimize?
Ma'am, if serum potassium is more than that, ma'am, then I can give injection calcium gluconate to the patient, ma'am. That is 10 ml of 10% of the calcium gluconate over 10 minutes. Ma'am, I can give insulin injection insulin, ma'am, in 50.
Wait, Asta. So you are telling me the treatment of hyperkalemia.
Yes, ma'am.
So if this patient comes to you with a serum potassium of 6.5, would you take him up for surgery?
No, ma'am. I will advise my patient for nephrology opinion and for pre-op dialysis, ma'am.
Correct. So this patient is for elective surgery. You will administer all these medications to treat hyperkalemia only if the patient is for emergency surgery, right? If the patient is for a non-emergent elective surgery, obviously the treatment of choice is dialysis, right?
Dialysis.
There is no other way to treat the hyperkalemia, and it is not safe to administer anesthesia in these conditions, right? So, so the most important instruction that you're going to give to these patients, which is often kind of decided by the nephrologist, but which you should be aware of, is the timing of the dialysis, right?
Yes, ma'am.
So the dialysis should be, when should the patient undergo a dialysis?
Ma'am, ideally within 24 hours, ma'am, before surgery, ma'am.
Okay. So this varies between institutions. Some institutions say that within 24 hours it should not be done because of the residual effects of heparin, and plus because of the associated fluid shifts that can occur because of dialysis. But in our institute also, I think it is done just one day prior to surgery. And what is the considerations for doing a dialysis before the surgery? What things do you have to be careful about for dialysis?
Ma'am, I have to take care of because there will be significant fluid shift, ma'am. So my patient might land up into hypotension, ma'am, like intraoperatively, ma'am. Ma'am, that I have to take care of, ma'am.
What instructions do you have to give? For the dialysis, there are certain instructions that you have to give for the dialysis per se.
Ma'am, the amount of the ultrafiltrate, that is, ma'am, that is ultrafiltration, ma'am, that should be in the range so that my patient hemodynamics should be stable, ma'am.
So what happens is that if you put it in such a way in terms of the dry weight. So what is the dry weight of the patient?
Ma'am, it is the ma'am, the dry weight means, ma'am, after ma'am, the volume of fluid that we are removing through dialysis, ma'am, the weight gain, ma'am, dialysis weight gain.
Dry weight is the weight of the patient after a successful dialysis is the dry weight, okay? The routine dialysis. So in this patient, just before undergoing surgery, one should either do just a dialysis without ultrafiltrate if the patient's dry weight is not too much, or just keep it about 1 kg more than the dry weight if you want to prevent hypertension. So what you have to see on the morning of the surgery is, the first thing that you have to see is how much ultrafiltrate has been removed, because that the nephrologist decides based on the patient's weight. If the patient is obviously much higher than the dry weight, they will have to remove fluid, because again, that will cause problems intraoperatively. But by and large, it should be about 1 kg more than the dry weight. It should not be absolute dry weight, because that can lead to hypotension intraoperatively and hemodynamic instability, right?
Okay.
And the second thing is heparin-free dialysis. Okay, so these two things that you have to ensure that the patient has the dialysis for the dialysis that is done just pre-operatively. Okay.
Okay, ma'am.
Okay. What else?
Ma'am, then I will ask, ma'am, I will order for ma'am anti-aspiration prophylaxis for my patient, ma'am, angiolysis, ma'am, and ma'am, for written informed consent and high-risk consent before surgery, ma'am. Then I will, ma'am, I will look for the site of AV fistula and mark it properly, ma'am, so protect.
Very good.
Yes,
Very
ma'am.
good. Yeah.
And ma'am, I will ask for to arrange blood and blood products also.
Fine. Okay. So that is all. The very important thing that you mentioned is to identify the site of the AV fistula or the dialysis catheter if the patient does not have a AV fistula. And as far as possible, try and not to use the dialysis catheter for your intraoperative use. Okay. Fine. What else? Now the patient has you give, and as far as possible, I'm not going to go into the detail of that because I don't think we have time. But as far as possible, whenever you are answering questions in the exam, when you're saying anxiolytic, it is always better to say what anxiolytic and what dose, and
Yes,
what anti-aspiration prophylaxis and the correct dose, right? So this goes for all the cases, not just this one, right? Okay, fine. So now you have to tell me the intraoperative anesthetic technique, the monitoring, the drugs that you're going to use, and the post-operative pain relief.
Ma'am, ma'am, my choice of anesthesia will be ma'am general anesthesia with controlled ventilation, ma'am. Ma'am,
so the next question the examiner is going to ask is, can you use regional anesthesia for these patients?
Yes, ma'am. Ma'am, we can use regional anesthesia. Ma'am, but ma'am, this patient have increased risk of bleeding, ma'am. So I have to assess properly the probability coagulation profile of the patient before going for regional anesthesia, ma'am.
So is it widely used?
No, ma'am. No, ma'am. It's not widely used. No, ma'am.
Why?
Ma'am, because because ma'am, this patient might have the peripheral neuropathy also, ma'am. So ma'am, with regional anesthesia, it will interfere with regional anesthesia, ma'am. And ma'am, that because of the coagulation disorder also, ma'am, and because of the duration of surgery, ma'am, duration and the nature of surgery as well, ma'am.
So regional anesthesia has been used. It has been used by a lot of people, but it has not been found to have an extra advantage over general anesthesia. And plus, with the kind of hemodynamic perturbations that occurred intraoperatively, they are very well managed with general anesthesia than with regional anesthesia. Sometimes you have no control. I mean, you have more control with general anesthesia, and the patient comfort is much more in general anesthesia, right? So that is why general anesthesia is preferred. And like you rightly said, sometimes the surgery can be prolonged. So the patient gets very uncomfortable with regional anesthesia alone. Okay. So, so what are your preparations going to be in the OT, your monitoring, and the anesthetic technique?
Okay. Ma'am, on the day of surgery, ma'am, I will reconfirm the fasting status of my patient, and I will check for all the ma'am. I will check for if patient has taken the antihypertensive dose in the morning and recheck the AV fistula site. I will pad it properly, ma'am, and then I will shift the patient to the OT table, ma'am. And I will attach all standard monitors that will include ma'am pulse oximetry and ma'am ECG and ma'am non-invasive BP that will be on the opposite limb of the AV fistula. And ma'am, the other non-invasive monitoring, that is capnography and temperature monitoring, I will do post-induction. Ma'am, I will like to do ma'am CVP monitoring and invasive arterial invasive BP monitoring also in this patient, that I will do post-induction, ma'am.
Okay.
And ma'am, I will then secure a wide bore cannula of 16 or 18 gauge on the limb opposite of the AV fistula. And ma'am, then I will start with my induction. Ma'am, I will pre-oxygenate my patient with 100% oxygen for 3 to 5 minutes. And I will pre-medicate my patient with injection midazolam 1 mg and injection fentanyl, ma'am, 100 120 mics, which I already calculated according to patient weight, ma'am. And after that, ma'am, I will start with the induction dose. I will give injection propofol to my patient, ma'am, 100 mg in a slow and titrated dose. And I will check for the ma'am, loss of verbal response, ma'am. Ma'am, and to blunt the hemodynamic response of laryngoscopy and intubation, ma'am, I will give injection lignocaine to my patient, ma'am. That will be, ma'am, 60 mg, 3 ml injection lignocaine, 90 seconds prior to laryngoscopy. When after injection propofol, ma'am, I will check ventilate the patient, and then I will give muscle relaxant. That I will prefer in my injection etracurium 30 mg.
So when you answer the choice of induction agents, you're right. Propofol is the most commonly drug used, but it's always good to say that I will look at the blood pressure. Okay, sometimes these patients come with a lower blood pressure. If the systolic is 100, if you use propofol, the patient is going to crash immediately. So if the patient has a borderline blood pressure, especially these patients who are on multiple antihypertensives, so in those patients, etomidate would be a better choice than propofol, right? So remember, for any anesthetic technique, the basal hemodynamics is very important to determine the choice of your anesthetic agent, induction agent. Okay, fine. So you've successfully intubated the patient. Then what?
Then, ma'am, after intubation, ma'am, I will do the ventilator settings. Ma'am, I will
go on. We don't have much time. Devang, am I right? We don't have much time. I have to give him some time for his presentation also.
Ma'am, I will maintain
so much of hard work. Okay.
Ma'am, I will maintain the depth of anesthesia with, ma'am, a mixture of injection, mixture of oxygen and nitric oxide 50%. With I will like to use isoflurane in this patient.
So here,
and ma'am, an intermittent bolus of atracurium.
Asta, when you're saying talking about the maintenance, you said oxygen, nitrous oxide, and isoflurane, right?
Yes, ma'am.
So when you say that, it is always good to say that if the patient has underlying pulmonary hypertension, I will not use nitrous oxide. I will use air. But otherwise, I will like to use nitrous oxide because why?
Ma'am, because adequate, ma'am, because it decreases the requirement of volatile anesthetics as well.
Okay, what else?
Yes, ma'am. And ma'am, to maintain MAC, ma'am. And
the same thing, no?
Ma'am, it decreases the dose of muscle relaxant.
It has an additional analgesic use. Okay, it provides analgesia as well. So that's an additional advantage, right?
Yes.
So this is the reason why we use nitrous oxide in these patients. And sometimes because of the hemodynamic instability, you're not able to use very high concentrations of inhalational agents, especially during unclamping, where there is the renal allograft is getting perfused. So you want a good pressure head. So if we use high concentrations of inhalation agents, the BP drops and the pressure head is not maintained, right? So nitrous oxide comes in handy during those times, right? Okay, fine. Then what else? Before putting in a CVC, any central venous catheter, any precautions that you would like to do? Specifically for these patients?
Ma'am, I will do it by with a sterile technique, ma'am. So that I will
for all patients. So you would like to do an ultrasound guided technique, and you will also do a preliminary examination of the vessels before attempting the catheterization to look out for thrombosis. Because these patients often have dialysis catheters in their large veins. Okay, so you look for presence of thrombosis in all these large veins and identify the vein which is thrombus free so that you can use it for your catheterization, right?
Yes, ma'am.
Okay, and as far as possible, prevent the CVC catheterization in the limb on the side where the AV fistula is. Okay, so that is, it is not impossible, but try and avoid it. If nothing is available on the other side, then you may use it. But as far as possible, try and avoid it. Okay, so you will put in a CVC, you will put in an arterial catheter, right? Okay, what else?
Ma'am, urine output monitoring.
Okay,
Ma'am,
and temperature, right? Anything else that you missed? One more thing.
temperature, yes.
One more thing that you missed. Neuromuscular monitoring, okay?
Yes, ma'am, yes, ma'am.
That is important to titrate the dose of your atropine.
Muscle relaxants.
Yeah, atropine. So if you don't have, between atrocurium and cis atrocurium, which one will you prefer? If you have choice for both.
Ma'am, then I'll prefer ma'am cis atrocurium in this patient. Ma'am, because this atrocurium, ma'am, it's metabolite ladonicin, ma'am. Atrocurium makes more metabolite than cis atrocurium, and this ladonicin, ma'am, it's excreted through kidney.
Okay,
And
okay, fine. That is one. What else? What is the advantage?
Ma'am, second, ma'am, histamine release, ma'am.
Yes. So there is no histamine release with cis atrocurium. So if you have both, prefer cis atrocurium. If you don't have both, which is the next neuromuscular agent that you would, blocking agent that you would like to use? If you don't have atrocurium or cis atrocurium.
Ma'am, then I can use ma'am vacuronium also, ma'am, in this patient.
Why?
Ma'am, because ma'am, vacuronium, ma'am, only 30% of the vacuronium is eliminated through kidney, ma'am. So I can use with the proper neuromuscular monitoring.
Yeah, correct. Very good. That is very well answered. So with the use of neuromuscular monitoring, you can use vacuronium, but only if you have neuromuscular monitoring and very, very titrated doses. Atrocurium, you don't have to worry because it undergoes Hoffman's degradation. It is not dependent on any organ for its elimination, right?
Yes.
Okay, fine. What else?
Ma'am, then ma'am, intraoperatively, ma'am,
so intraoperatively, the next thing that we come in management is fluids. What fluids are you going to give and how much?
Ma'am, I would like to give ma'am a 0.9% normal saline to this patient. Ma'am, in the beginning, ma'am, before before the anastomosis, ma'am, I will restrict the fluid fluid, ma'am, and I will maintain and I will give ma'am CVP guided fluid, ma'am. So
I would advise you to say that I will give goal directed fluid therapy. Okay. So when the examiner asks you what goal, then you can specify. If you have a CVP, you will direct it towards the CVP and keep it at what level? What is your goal?
Ma'am, 9 to 10 centimeter of water.
8 to 12 millimeters of mercury. Okay. So that is your goal. Okay. Preferably more than 10. Okay. And when the reperfusion of the allograft is it's time for reperfusion, then you keep it around 15. Okay. Right. So that is your goal. What can be the other goals? What are the other parameters that you can monitor to target your fluid therapy? Because the examiner is going to counter question you that CVP is not reliable, especially if you have cardiac dysfunction. So CVP may not be a very reliable indicator of your fluid therapy or fluid responsiveness. So what are the other things that you can use?
Ma'am, we can use my urine output, but as my patient, yes, ma'am. Yes, ma'am, we can use in this case.
What is the thing that you can use?
Ma'am, hemodynamics, ma'am, according to patient beat, ma'am.
Have you heard of respiratory variation because of fluid deprivation? Pulse pressure variation, stroke volume variation, systolic pressure variation. Have you read about all these things?
Yes, ma'am.
Do you have a flow track monitor, Vigilio with flow track? Do you have it in your institute? So that tells you about stroke volume variation. Okay, that is the variation in the blood pressure because of changes in respiration. So what happens during inspiration is that in a controlled ventilation, during inspiration, there is increase in intrathoracic pressure. Okay, so there is fall of the venous return. Whereas during expiration, there is decrease in intrathoracic pressure. So there is rise. So when you look at the arterial waveform, you will see variation in different phases of respiration. So that tells you if there is a lot of variation of more than 10 millimeters of mercury, that means the patient is fluid deprived and needs fluid. Okay, so this can be measured either with stroke pressure, systolic pressure variation, pulse pressure variation, or stroke volume variation, which is measured by a Vigilio monitor using a flow track transducer. Okay, so remember to say that this is true for any major surgery, and especially true for these kind of patients where you need to regulate the fluid intake very carefully. Okay, then choice of fluid, you said sodium chloride. Any disadvantages of using sodium chloride?
Yes, ma'am. Ma'am, it can lead to ma'am hyperchloremic acidosis with sodium chloride, ma'am, and which again, ma'am, which can increase potassium level and can lead to hyperkalemia also, ma'am.
So it would be safer for you to say that I will use a balanced salt solution in the form of ringalactate or ringer acetate, okay, or plasmalite. Any of these can be used, okay, and it's not associated with the complications of normal saline, especially when it is given in large volumes, right? And normal saline per se also causes renal vasoconstriction and can lead to acute kidney injury. So it is always better, since you have a lot of choices nowadays. Previously, we did not have too much of choice. We had to use sodium chloride. Although the studies are not very clear that these balanced salt solutions are superior to normal saline, but still it is better since we have easy availability of balanced salt solutions. It's better, advisable to use these solutions and also to say it in the exam. Okay.
Okay.
Okay, fine. What else? Okay, fine. So we've done this. So what precautions do you take during reperfusion? What are the complications that can happen and what precautions? Quickly.
Ma'am, I will avoid hypoperfusion to the grafted kidney, ma'am.
How?
So,
How?
Ma'am, for that, ma'am, I will maintain the CVP. Before ma'am opening of the clamp, ma'am, and there to 14 to 16. And ma'am, I will maintain the BP of the patient, ma'am, blood pressure. It should be, ma'am, mean arterial pressure should be more than 90, ma'am.
Correct.
And 80 to 90, ma'am.
Yeah.
Yes, ma'am. And ma'am, so because for that, ma'am, I will preload my patient. Ma'am, preload my patient with ma'am 0.9% with the balanced salt solution with 0.9% normal saline, ma'am.
Okay. Fine. So that is the reason why you need to have a large bore IV cannula. One, to give these fluids quickly, and secondly, sometimes you can have bleeding also during this surgery. So if you have bleeding, you have provision to replace the blood loss. Okay, so these are the two reasons why you need to have a large bore IV cannula in place. Okay, so what about regional anesthetic techniques that you can use post-operatively to provide analgesia in the patients? Any other besides the neuraxial techniques, any other techniques that you can use for post-operative analgesia?
Ma'am, I can use ma'am tab block, ma'am.
Okay, good.
For post-operative.
Have you given in these patients?
Ma'am, not in our institute.
Okay, but you given tab block to other patients?
Yes,
okay.
ma'am.
So what agent will you use? What is the volume? What drug will you use?
Ma'am, we can use ma'am bupivacaine, ma'am. 0.25% bupivacaine. Ma'am, volume of ma'am 20 to 30 ml of ma'am 0.25% bupivacaine.
Okay, fine. So will you give it pre-operatively or post-operatively?
Ma'am, post-operatively.
I mean, pre-incision or after surgery? What I meant was post-induction.
After surgery, ma'am.
Why?
Ma'am, because ma'am, before surgery, ma'am, already we are giving ma'am multimodal analgesia to the patient, ma'am. Intraoperatively, I'm giving ma'am, we already gave fentanyl, and intraoperatively also we are giving boluses of fentanyl to the patient. Injection paracetamol we are using, and inhalation agents are also ma'am there, ma'am.
Okay, fine. So besides this, what are the other modalities of post-operative analgesia?
Ma'am, Ma'am, I will continue, ma'am, that, ma'am, boluses of opioids, ma'am, that should be with caution, post-operatively. And we can use, maybe we can continue injection paracetamol, ma'am, with the patient. And
again, you have to be very specific. What is the dose of paracetamol at what interval?
okay, ma'am, we can, ma'am, dose of, ma'am, 15 mg per kg paracetamol, or ma'am, it is adult patient, we can give 1 gram paracetamol, ma'am, TDS, ma'am,
Not adult
size.
patient. If the patient is weighing more than 50 kg, it is 1 gram 6 hourly. If it is less than 50 kg, 15 milligram per kg 6 hourly. Okay, be very clear about that. Okay. So besides PCM, what else?
Ma'am, opioids, ma'am, we can give, ma'am, but
How will
with
you
caution.
give? What is the
Ma'am,
ideal way to give? Why precaution? What
I-
opiate you use fentanyl? Okay.
Yes, ma'am.
So what if you want to use fentanyl in the post-op period? How can you optimize it to patient's comfort?
Ma'am, we can, ma'am, by, ma'am, patient-controlled analgesia.
Correct, correct. So preoperatively, you have to explain to the patient that how a PCA pump works. Okay, what is the setting of the PCA pump for fentanyl?
Ma'am, it is 20. Ma'am, it is, ma'am, 2 mics per kg per hour, ma'am, according to that, ma'am.
So that is an infusion, bache. That is an infusion. What is the setting of PCA pump? So go back and read it. This is very important. Be very clear about all opioid PCA pump settings. This can be one of the modalities of postoperative anesthesia for any kind of surgery. So be very clear about it. Okay.
Yes.
And extubation. What are the precautions during extubation? I forgot the extubation. See, both intubation and extubation can be stormy. Okay. So you told us about the intubation. You're going to give xylocaine. What about extubation?
Ma'am, for extubation also, ma'am, I don't ma'am, I will extubate my patient if my patient is hemodynamically stable, ma'am, at the end of the surgery. And if ma'am, if the CVP is maintained between, ma'am, 12 to 14.
No, you're not getting my point. How do you prevent the extubation response? Just like that, you have an intubation response. You similarly, you also have an intubation response, right? Sorry, extubation response. So how do you prevent the extubation response? Last question. Time's up.
Ma'am, I will. Ma'am, I will extubate.
So you've never used any drug for preventing extubation response. What happens during extubation? There is tachycardia and hypertension.
Yes, ma'am.
So you don't want that to happen in this patient, right?
Ma'am, again, we can use, ma'am, lignocaine or injection esmolol.
Correct. So esmolol is a good drug, especially if the patient has tachycardia. Okay. So give boluses.
Okay. Ma'am, 0.5 mg per.
So that should be given to
5
control
mg,
the hemodynamic.
per kg, ma'am, bolus of esmolol.
Always remember that.
Yes,
Don't forget the extubation, especially in these high risk patients. Okay. Okay. Thank you, Astha. Did very well. Again, like the previous candidate, you were not prepared with any questions. I did not give you any questions. So you answered very well. Good. I think all your teachers have also prepared you very well. They've worked with you very hard, right, Devang?
Yes, ma'am.
And doctor and your head of the department, I think, has been really, really diligent with all your training. I think you had multiple sessions of presentations and, getting you to answer all the questions correctly. So that is why you did a very good job.
Thank you, ma'am.
Devang, the stage is all yours now.
Thank you so much, ma'am. I think you have already extensively covered the topic. I'll just briefly summarize it, ma'am.
Okay.
Good morning, everyone. I'll just briefly say the topic: renal failure and transplant. So chronic renal failure or chronic kidney disease is a progressive and irreversible deterioration of renal function. It corresponds to evidence of kidney damage or to an estimated GFR of less than 60 ml per minute per 1.73 meters square for 3 or more months. And end-stage renal disease or ESRD is a renal dysfunction which would be fatal without renal replacement therapy. And it usually corresponds to an estimated GFR level of less than 10 ml per minute per 1.73 meters square. CRF presents with a varied etiology, including various glomerulopathies like primary glomerular disease and membranous nephropathy, glomerulopathies associated with diabetes mellitus, SLE, amyloidosis, and post-infection. Various tubulointerstitial diseases like analgesic nephropathy, reflux nephropathy, and sarcoidosis. Hereditary diseases like polycystic kidney disease and Alport syndrome. And other causes like systemic hypertension, renal vascular disease, and obstructive nephropathy. Of these, diabetes mellitus is the most common cause and accounts for almost 45% of all cases of CRF, and it is closely followed by systemic hypertension. The basic pathogenesis of renal failure includes 3 changes at the level of glomerulus. One is glomerular hypertension, other is glomerular hyperfiltration, and both these changes lead to increased permeability of the glomerular vessels, known as glomerulosclerosis. These changes are mediated by genetic factors in association with environmental factors like hypertension and diabetes. All these changes eventually lead to irreversible damage to glomerular capillaries and cause CRF. CRF or CKD can be classified on the basis of estimated GFR levels into 5 stages. Stage 1 corresponds to an estimated GFR level of 90 ml per minute per 1.73 meters square or more. Stage 2 corresponds to 60 to 89. Stage 3 has been divided into A and B, with stage 3A corresponding to 45 to 59, while 3B corresponding to 30 to 44. Stage 4 corresponds to 15 to 29. And stage 5 corresponds to less than 15 ml per minute per 1.73 meters square of estimated GFR, and it is also known as end-stage renal disease. CRF affects all the major body systems, and in CNS, it is manifested as generalized symptoms like altered mentation, fatigue, malaise, irritability. It also presents as distal symmetrical mixed peripheral polyneuropathy, autonomic neuropathy, and uremic encephalitis. In endocrine system, it presents as glucose intolerance, secondary hyperparathyroidism, hypertriglyceridemia, and infertility. In CVS, systemic hypertension and LVH are seen, along with diastolic dysfunction. Various kinds of conduction blocks, arrhythmias, especially atrial fibrillation, are seen. Fluid overload might lead to congestive cardiac failure. There is accelerated atherosclerosis, which may present as coronary artery disease and cerebrovascular accidents. And uremic pericarditis and pericardial effusion might also be seen. In respiratory system, there is interstitial and alveolar edema and pleural effusions. In GI system, there are signs and symptoms of anorexia, nausea, vomiting, acid peptic disease. There is delayed gastric emptying. There might be incidences of GI hemorrhages. Various metabolic features associated with CRF are hyperkalemia, hypermagnesemia, hyperphosphatemia, hypocalcemia, hypoalbuminemia, and high anion gap metabolic acidosis. Hematological system, normochromic, normocytic anemia is mostly seen, along with leukocyte and platelet dysfunction, and also coagulopathies. In musculoskeletal system, renal osteodystrophy is seen, as well as periarticular calcification might be seen. And hyperpigmentation, pruritus, and ecchymosis might be seen in skin. Various complications are also associated with CRF. Uremic syndrome is a common complication, and it is a constellation of signs and symptoms that reflect kidney's progressive inability to perform excretory, secretory, and regulatory functions. The signs and symptoms of uric syndrome are anorexia, nausea, vomiting, anemia, pruritus, fatigue, and coagulopathy. The severity of these symptoms correlates well with the blood urea nitrogen levels and not with serum creatinine levels. Another complication is renal osteodystrophy. It is a complex interaction of secondary hyperparathyroidism and decreased vitamin D production by kidneys, and it leads to severe bone resorption. Basically, renal dysfunction leads to raised serum phosphate levels because the excretion of phosphate is reduced, as well as decreased vitamin D3 levels because again its production is reduced. Both these changes lead to decrease in the serum calcium levels, which causes an increase in the secretion of parathyroid hormone, and it eventually leads to bone resorption. The treatment of condition includes dietary restriction of phosphate and avoidance of use of antacids, as well as calcium and vitamin D supplementation. For very severe cases, subtotal parathyroidectomy might be employed. Another complication is uremic bleed, and it's caused by platelet dysfunction as well as coagulopathy. Diagnosis is by raised bleeding time and abnormal platelet function tests. Treatment of the condition includes administration of cryoprecipitate, conjugated desmopressin, erythropoietin, von Willebrand factor, and for very severe cases, blood transfusion. Although blood transfusion in patients of CRF should be avoided, as it might lead to HLA sensitization, and which would lead to graft failure at later stage. Another important complication is normocytic normochromic anemia, and it is very common in CRF patients. It is multifactorial in nature, with causes ranging from decreased erythropoietin production to absolute iron deficiency caused by malnutrition and poor absorption. Coagulopathy leads to increased blood loss that also might lead to anemia. Then there is bone marrow suppression caused by uremia. There's decreased RBC lifespan because of uremia, and many more factors. Treatment of this condition is dietary supplementation of iron and folic acid, intermittent parenteral iron injections, recombinant erythropoietin therapy, and again, if it's anemia is very severe, blood transfusion. Treatment of CRF is basically optimal BP control in the patient, although BP is very difficult to control in these patients, and a combination of 3 or more antihypertensive agents might be required. ACE inhibitors and angiotensin receptor blockers are the preferred agents. Then there should be optimal blood glucose levels should be maintained with a goal of HbA1c of less than 7%. Optimal HB levels should be maintained. Target HB should be 13 gram per deciliter and 12 gram per deciliter in males and females respectively. And diet should be modified to ensure moderate protein restriction, limited to a 0.6 milligram per kg per day of protein administration. Renal replacement therapy forms the mainstay of treatment of CRF, and it refers to all available approaches that replace the normal blood filtering function of the kidneys. Indications include hyperazotemia, clinical signs of uremic toxicity, NSRC or severe fluid overload, severe metabolic acidosis, severe hyperkalemia which is not responding to treatment, and severe dysnatremia. The basic principle of renal replacement therapy is that blood flows through semi-permeable membrane and exchange of molecules occurs through diffusion as well as convection. Techniques are intermittent and continuous. As the name suggests, intermittent means there are intermittent sessions of hemodialysis. This is the most commonly used technique. And in this technique, blood and dialysate are circulated in a counter current manner without any direct contact. While in continuous technique, the dialysate is instilled inside the abdomen through a catheter, and blood circulating through the capillaries of peritoneal membrane is exposed to the dialysate, and dialysis takes place. Anticoagulation is frequently employed for renal replacement therapy in the form of unfractioned heparin, low molecular weight heparin, and citrate. RRT is also associated with various complications, most common being hypotension during hemodialysis. Others are hypersensitivity reactions, dialysis dementia, peritonitis, systemic anticoagulation, as well as dialysis disequilibrium syndrome. Renal transplant, again, is the absolute treatment for the condition of CRF. Early attempts were made at human kidney transplantations in 1930s, but it still remained an experimental treatment until breakthrough in tissue typing and immunosuppression led to improved graft survival by 1960s. Today, kidney transplant is the most common organ transplant surgery performed. And in fact, the focus, as ma'am said, is now on preemptive kidney transplant, that is going for a transplant even before dialysis is initiated or dialysis related to complication setting. It has been shown to result in improved graft survival. There are various contraindications to renal transplant as well, like a critically ill patient, if there is any active systemic infection or sepsis, if there is any active malignancy, there is active substance abuse, or maybe the cause of renal failure is reversible. In that case, it is contraindicated. Then if the patient is suffering from any uncontrollable or uncontrolled psychiatric illness, if there is a document of active and ongoing treatment non-adherence, and if the patient has significantly shortened life expectancy. Then to decrease the incidence of graft rejection, immunosuppressive therapy is employed. Basically, 4 classes of drugs are used for this purpose: corticosteroids, CNIs or calcineurin inhibitors like cyclosporin and tacrolimus, antimetabolites like mycophenolate and azathioprine, and TOR inhibitors like sirolimus. Usually, a combination of 2 or 3 different classes of drugs is started in the immediate preoperative period and is continued for the lifetime of the recipient. There are increased risk of infection and malignancy associated with the long-term use of these drugs, especially corticosteroids and CNIs. That is why now corticosteroids and CNI sparing protocols have gained popularity. Now, anesthesia for renal transplant. Preoperative evaluation of these patients would include history, examination, investigations. In history, salient features would be to know about cause and duration of CRF, the duration of treatment, fluid restriction and daily urine output, blood volume status and details of dialysis sessions, and any comorbidities patient is suffering from and the treatment patient is taking for these comorbidities. Examination would include BP in both sitting and standing position, so as to also look for autonomic neuropathy, if any flow murmurs, pericardial rub, chest crepitations, and especially ankle and sacral edema might be evaluated. Various investigations would include complete blood counts, especially the hemoglobin, TLC levels, platelet count, all these would be required. Renal function tests, including blood urea nitrogen, serum creatinine, and creatinine clearance. Serum electrolyte levels, especially of sodium, potassium, calcium, and magnesium. Liver function tests, including serum protein levels, blood glucose, bleeding and clotting time, platelet function studies, ABG study, chest X-ray, ECG, 2D echo, as ma'am said, is very important in these patients, and stress testing if indicated. For preoperative optimization, basically BP should be optimized in the preoperative level. All antihypertensive should be continued till the morning of surgery, although ACE inhibitors and ARBs might be stopped 24 hours prior to the surgery. Blood glucose levels need to be optimized, and if needed, patient should be shifted to insulin in the preoperative period. Then hemoglobin levels should also be optimized. Serum electrolytes abnormalities, if any, should be corrected. Adequate fasting time should be ensured for these patients, as there might be delayed gastric emptying in these patients. Then informed consent should be taken. Anxiolysis in the form of low-dose alprazolam or midazolam might be used. Aspiration prophylaxis should be administered. Blood should be sent for typing and cross-matching. Then a nephrologist should be consulted in the preoperative process for palliative dialysis. Dialysis, if indicated, should finish preferably 24 hours before in the preoperative period, or at the very least, at least 4 to 6 hours, so as to allow time for fluid shift. The hemodialysis sessions, ideally, this last session should ideally be anticoagulant free. And post-dialysis, CBC, renal function tests, serum electrolytes, and coagulation studies might be repeated. Monitoring in these patients would consist of pulse oximetry, ECG, non-invasive blood pressure or invasive blood pressure, but certainly not in the limb with AV fistula, and tidal capnography, temperature monitoring, CVP monitoring, urine output monitoring, neuromuscular monitoring is especially important, blood glucose monitoring, and serial ABG monitoring. The perioperative goals of anesthetic management include maintenance of the renal blood flow, avoiding nephrotoxic drugs, maintaining optimal fluid balance, avoiding any electrolyte or acid-base imbalance, and AV fistula care. Some important considerations in these patients would be: one, they have a difficult IV access, then strict asepsis needs to be maintained. If blood transfusion is indicated, then leukocyte depleted blood should be used. AV fistula and all the joints should be well padded, and patient should be kept warm by using patient warmers and warm fluids. Pre-medication in the form of midazolam and fentanyl might be employed. Prior to induction, patient should be adequately pre-oxygenated with 100% oxygen for 3 to 5 minutes. RSI may be employed if it is indicated. And induction agents should be administered in a slow and titrated manner. Atracurium and cisatracurium, as ma'am said, are the preferred muscle relaxants, especially cisatracurium. And if indicated, succinylcholine choline might be used in these cases if serum potassium level is less than 5.5 milliequivalents per liter. Stress response to laryngoscopy and intubation should be planted. The anesthesia should be maintained on nitrous oxide, isoflurane or desflurane. And again, nitrous oxide should be used if there is no evidence of pulmonary artery hypertension. The use of sevoflurane might be avoided because it might lead to formation of an nephrotoxic compound A. Fentanyl, remifentanil, and paracetamol may be used for analgesia. Morphine because of its prolonged action, meperidine because of its potential of causing seizures, and NSAIDs because they're nephrotoxic, their use should be avoided. And preferably the ventilation should be controlled so as to avoid any incidence of hypercarbia. The fluid management should be goal-directed and CVP guided. Traditionally, normal saline was the fluid of choice, but many centers are now shifting to balanced salt solutions like Ringer's lactate. Starch-containing solutions, although, should be avoided. Hypotension, if any, should be promptly treated with fluid administration. And to facilitate reperfusion of the graft and adequate urine output, mannitol, furosemide, and liberal fluids are administered after unclamping of the iliac vessels in the recipient. In ischemia time, it is the duration of the blood. It is the duration for which the blood supply to the organ is interrupted. It is divided into warm and cold ischemia time. Warm ischemia time is further divided into donor and recipient warm ischemia time. With donor warm ischemia time is the time from clamping of aorta or renal artery of the donor to the time kidneys flush with cold preservative solution. While recipient warm ischemia time is the time from which kidney is taken out from the cold preservative solution to the time it is reperfused with the recipient's blood. Cold ischemia time is the time for which kidney stays perfused and submerged in the cold preservative solution. At the time of reversal, stress response associated with extubation should be attenuated. Reversal agents should be administered in a slow manner. These patients are prone to inadequate reversal of neuromuscular blockage and weak urerization. That is why they should be extubated only when patient is fully awake and they are obeying commands. Intensive monitoring should continue in the postoperative period, especially ECG to detect any cardiac dysrhythmias which might indicate hyperkalemia or other electrolyte abnormalities, and urine output to detect early graft rejection. Adequate analgesia should be ensured in the postoperative period. It can be employed in the form of tap block or by using IV PCA pumps. And supplemental oxygen and immunosuppressant therapy should also continue in the postoperative period. Thank you.
Devang, thank you. That was nice. I would like to answer the few questions that are here in the chat box. The one from Dr. Santosh, how relevant is it to go in detail evaluation of diagnosing a disease when more often diagnosis is already made by surgeon? I completely agree with you, Dr. Santosh. Our job as anesthesiologists is not to diagnose, but to provide anesthesia to patients with all the comorbidities that the patient has and to tailor make our anesthetic technique. So personally, as an examiner, I do not like to go into the details of the history in terms to, like you rightly said, for diagnosing a disease. What I'm trying to extract from the examinee is whether that person is able to understand the consequences of that disease in form of the history or in the examination so that they can alter their anesthetic technique. So I am not looking for them to diagnose the disease, and I completely agree with you. But it depends from examiner to examiner, so I cannot comment on that. And then the next question from the same person is, do we need to decrease the lignocaine dose by 20% even for blunting laryngoscope response? No, we do not. So the dose remains the same, 1 to 1.5 milligram per kg. Since it's not a huge dose, we do not need to alter it. So it remains the same, and which is unlike the large doses that are administered during a regional anesthetic technique, okay, say for a block. So that is why we don't need to alter it. And then the last question is from Dr. Sunalika, who says, if patient has borderline blood pressure, can ketamine be also used? So, so you have a point here, Sonalika. So, like I said, if the patient has normal hemodynamics, then propofol is the drug of choice. If the patient has borderline or low blood pressure, in the exam, it would be preferable if you say etomidate because it's hemodynamically stable. But if you're asking from a practical point of view, a lot of hospitals may not have ready availability of etomidate. So then in those cases, titrated doses of ketamine can be used. And sometimes I have even used a mixture of ketamine and propofol, okay, ketofol. So as anesthesiologists, we all know, and the panelists would probably concur with me, that as long as you understand the pharmacokinetics and pharmacodynamics of a drug, you can use it safely. So there is no contraindication for it. There is no absolute contraindication of using ketamine in this circumstance. It can be used as long as you understand what it does to the peripheral vascular resistance, what it does to the heart. So if you're using it carefully, you can use it to provide anesthesia. But in the exam, if you're a trainee, I would like to suggest that you keep propofol and etomidate as your answers. I hope that answers your question. Yes,
thank you so much, ma'am, for such an extensive case discussion. It was indeed a very detailed and very beneficial. I am sure students must have benefited from this detailed case discussion. Thank you so much, ma'am.
No problem.
One point I
always
can...
a pleasure. Always a pleasure.
Thank you, Dr. Vimmi. Thank you so much. I would like to make one comment that besides being the anesthetist, the knowledge of the entire medicine related to the case is very important. That is why, though rightly said, time doesn't allow us to find out how to diagnose the case. But, behind the, successful anesthesia delivery, we have the knowledge of medicine, then only we can be conducting the case very well. That's why, we go while practicing the cases in PG assembly, we, have to emphasize on the medicine part and also how to diagnose, like in every case, so that the PG students know the detail of the disease when they are tackling the anesthesia part of it. That's why, I feel this is important. And every examiner is, going into the detail of the medicine related to this. Why the negative in a history has to be ruled out is so important. Either they don't tell us the negative history or they don't know why they are taking this negative history. So, the basically examiner wants to check the knowledge of the examinee. So that's why I think the holistic presentation would include everything regarding the diagnosis also, in addition to the successful conduct of anesthesia. And Dr. Vimmi, thank you so much for making it so elucidative. And
Dr. Mondi, can I make a small comment? I absolutely agree with you. And that is why we are known as perioperative physicians.
Yes.
Because we need to know everything. But what point I was trying to make is that what happens most commonly is that the more of the time is spent on the history and examination and these kind of things, and very little time is then left for us to discuss the anesthetic technique. So as long as we are distributing the time evenly, I don't think, obviously, without the knowledge, underlying knowledge of the pathophysiology of the disease and the effect it causes on the various organs, we cannot tailor make our anesthetic technique. I absolutely agree with you. In fact, I feel as anesthesiologists, we have the maximum knowledge about everything. And the trainee also needs to know that. But the only thing is how to divide that half an hour or 1 hour that we have for the long case effectively, so that at least 50% of the time is also spent on evaluating the trainee's knowledge on the anesthesia. So that is the only thing. As long as we are taking care of it, absolutely no problem.
Yes, yes. Thank you so much. I think they've got a good rehearsal of the case. That's up to them. You have made them grill into it.
No, all credit goes to you and your team, I think, for their excellent preparation. The PGs are really, really well prepared with all the answers.
Thank you so much.
Okay. Thank you. Bye-bye.
Bye.
Thank you, ma'am.
Asta, thank you.
Thank you, ma'am.
Okay. Bye-bye.
Thank you, MD ma'am, for your kind words. Thank you, Dr. Devang. Thank you, Asta. It is a matter of great pride that Director General of Health Services, Dr. Sunil Kumar, he has shared his thoughts and blessings virtually with us in this platform. So I would like to telecast his video message on behalf of our HOD ma'am, Dr. MD Kaur ma'am. So.
Good morning all, dear friends. It gives me immense pleasure to inaugurate this annual postgraduate pre-examination course 2022 being conducted by the Department of Anesthesia in Atal Bihari Vajpayee Institute of Medical Sciences associated with Dr. Ram Manohar Lohia Hospital in New Delhi. It is an extensive 7 days online program. I congratulate Dr. MD Kaur, the head of the Department of Anesthesia, and her team for conceptualizing and implementing this course. These kind of programs can only be done after a lot of hard and sincere work. This program includes long and short cases, viva voce, practice for table viva, didactic lectures by the eminent faculty, not only from the India but also from UK and Singapore. The Department of Anesthesia today serves as the backbone of any hospital. The role of anesthesiologists extends beyond the operating room in providing the emergency resuscitation services, management in ICUs, running the pain clinics, providing hyperbaric services, etc. I wish a grand success for the program and to the department this year also, and hope that the students will get immensely benefited from it and will shine in their examinations. I convey my best wishes to all of you as well as the students. Thank you very much. Jai Hind.
Thank you, sir, for your kind words. I would like to just announce that we are pleased to announce that our director and MS, AB WIMS and Dr. RML Hospital, Dr. BL Sherwal, he has shared his blessings and thoughts with us through a video message. So I would like to telecast it on behalf of our HOD ma'am, Dr. MD Kaur.
Department of Anesthesia in any institute is really a backbone, whether it is running the normal operation theatres, whether it is ICUs, whether it is pain clinic, and we are also having services like hyperbaric oxygen. The RML have more than 30 faculty, and every year we are admitting 31 postgraduate students. The department of RML under Dr. Mohandeep Kaur is involved in various training activity like advanced trauma life support, emergency life support, and also I feel proud that Department of Anesthesia RML is nodal center for comprehensive resuscitation training center from the current year. Among the pandemic, when we say if any specialist or any doctor or any branch has been highlighted or saves the human, it is definitely, I'll say, anesthesia department. We understand that how critical patients was handled by the anesthesia team in most of the hospital, but I feel proud that anesthesia department of our department of RML was really really very actively involved in treatment and management of the COVID during the pandemic. The students of this institute, or I'm hopeful that students who will be going and attending the courses and the training for the next 7-8 days, they will be of use and will be definitely helpful in the teaching and training of the various anesthesia courses. My faculty under the leadership of Dr. Mohandeep Kaur is really working very hard, and everyone is contributing to make this feat a success. From my side, I will congratulate you as a team, and I am hopeful that the function which is being organized, it will be of great help to the students at large. I wish the program all the very best and hopeful that it will be very much successful. Thank you.
Thank you so much, sir, for your encouraging words. Let us now proceed to our next session that will be chaired by Dr. Qazi Ehsan Ali. Sir is Professor and Chairman in the Department of Anesthesia and Critical Care in Jawaharlal Nehru Medical College, Aligarh Muslim University, Aligarh, India. He has more than 25 years of teaching experience, and he is trained in trauma resuscitation from Jai Prakash Narayan Appec Trauma Center, AIIMS. And he is recipient of Fellowship of National Fellowship of Indian Medical Scientists. 2 of his published papers have been rated among the world's top 20 articles in the domain of airway management. And 2 of his publications have been cited in ASA Difficult Airway Management Guidelines 2022. He has more than 59 publications, and he has been invited 57 invited lectures and conference and CMEs. I welcome you, sir. Over to you, sir. So you have to unmute yourself. So we cannot hear you. You need to unmute.
I have done it.
Yeah. Yes, sir. Now you
Am I audible?
Welcome. Yes, sir. Welcome, sir.
Oh, thank you. Thank you.
Over to you, sir.
I first of all invite the first participant who is going to speak on this topic of, say, the circuits and all. Who is the first participant? Dr. Akhilesh Gupta. I invite Professor Akhilesh Gupta to deliver his lecture. Akhilesh Gupta, please.
Good afternoon, everyone.
Yeah,
I'm Dr. Akhilesh, working at ABVIMS, Dr. RML Hospital. This is the hospital where I work, and this is what I do. And I'm talking about breathing circuits. What is breathing circuit? When we talk about breathing circuit, there are n number of circuits. So when we talk about a breathing circuits, we first need to know what is ideal breathing circuit. What all we expect from a breathing circuit. It should have low resistance to gas flow. The gas should flow easily. Minimum rebreathing of the preceding alveolar expirate. I'll be talking about this. What is rebreathing? What is alveolar air? And what is expirate? Removal of carbon dioxide at the rate at which it is produced. So all the carbon dioxide should get absorbed, and it should not come as a part of a rebreathing gas. Rapid changes in delivery gas composition when required. See what happens if we increase or decrease the rate of inhalational agent. It takes some time to adjust. So it should be rapid. We should get warm, humidified oxygen or gases, and we should have safe disposal of waste gases. So this is what ideal is. Now let's talk about what breathing circuit we may have. So every breathing circuit has few components. First is connection to the patient airway to the breathing circuits. Whether you intubate a patient or put in a supraglottic device, you attach the circuit to it. So that's a connection part. Second is breathing circuits, which you use. Third thing is valves to permit directional flow. So there are unidirectional valves which move in one direction. So I'll be talking about it. Reservoir bag, which is very important, not per se for the clinical part, but very important for the exam also. And fresh gas must be supplied to the circuit and excessive gas must be allowed to escape. So fresh gas to the circuit, excessive gas out, breathing circuits, valves, and reservoir bag. I'll be not talking about endotracheal intubation, supraglottic, whatever it has been put, there's an adapter, and then comes the role of breathing tubes. Breathing tubes are usually 1 meter in length and they are large, 22 mm diameter. They have corrugations or spiral enforcement so that it doesn't get kink. An internal volume is around 400 to 500 ml per meter of length. So we have talked about breathing circuits. Now let's talk about unidirectional valve. What is the prerequisite of a unidirectional valve? When we say that this is okay, see, it should have low resistance and high competence. Low resistance means that whenever the valve is there, it should not offer a resistance. The valves must open widely with little pressure. See, this is a valve. This is the valve. So it should open with a little pressure only. And it should close down effectively. So that is what we are talking about. Valves must open widely with little pressure and must close rapidly and completely with essentially no backflow. So these are the inspiratory valves. It opens on inspiration whenever patient is inspiring. So it opens on inspiration. This is from where the fresh gas flow is coming. It opens up and goes to the patient. And it closed during expiration. Whenever patient expires, this valve got closed. So the importance of one directional or unidirectional valve is opens on inspiration, closes on expiration. These both two are the schematic diagrams of a valve, which inspiratory valve, which opens in inspiration and closes on expiration. Similar valve occurs in expiratory valve, which has a opposite mechanism. It opens on expiration and closed on inspiration. And these valves must be placed between patient and reservoir bag in each limb. So what does that mean? I'll be covering now. Another thing is respiratory valves. So we talked about unidirectional valves, and these are the respiratory valves which are located or incorporated either into carbon dioxide absorber site. We will talk about carbon. So I'll be touching upon few slides, basic things, and then we'll talk about circuits where there is a use of these things. Then these valves are attached to the fresh gas inflow site and excess gas. So there are three things: carbon dioxide canister, fresh gas inflow, and excess gas or pop-off. The important thing is these valves should be hydrophobic. They should not get decomposed or damaged with the moisture. The disc in unidirectional valve can be lifted with a circuit pressure of 0.31 centimeter of water. So we have talked about that it should get activated with a little pressure only. Another important thing which is asked in the exam and nobody teaches it, it's a reservoir bag. You are given a reservoir bag and asked what all it can do. So let's recollect what all it can do. It can help in breathing. It can help in giving manual breaths. You can feel the inspired air or expired air through this bag. Okay. You can tell about somehow that there is a bronchospasm or there is a lot of secretions. Besides that, it usually doesn't answer in the exam. So it serves as a reservoir for anesthetic gas, provide a means for visual assessment and rough estimate. They serve as a means of manual ventilation. Now the important thing is that they maintain inspiratory flow rate. Now, how does that maintain? And this is the most important part of bag. The bag are usually 3 liter in size and they are made up of latex rubber. So the important thing is that they maintain the peak inspiratory flow. Now understand this thing. Suppose a patient is breathing at a tidal volume of 500 ml and respiratory rate of 20 breaths per minute. Simple thing. So minute volume comes out to be 10 liter per minute. Fine. There is IE ratio 1:2. So 20 breaths per minute. This means each breath is for 3 seconds. So tidal volume of 500 ml is inspired in 1 second. 3 seconds total breath, IE ratio 1:2. So 500 ml is inspired in 1 second. Fine. So average inspiratory flow is 30 liters per minute. Getting a point? So average inspiratory flow is 30 liters per minute, and we are only getting 10 liters per minute. So where those 20 liters per minute are coming? So those 20 liters per minute are there in the reservoir bag and acts as a reservoir. So that's a very important thing and very important thing to understand. Now coming on to the rebreathing part, we have talked about rebreathing. What is rebreathing? Rebreathing is taking enough expired air. Okay, so there are various factors which affect the rebreathing. One is fresh gas flow, apparatus, dead space, and breathing system design. We'll be talking about it slowly. Now, what is apparatus or mechanical dead space? Apparatus or mechanical dead space is a space where there is a mixture of inspiratory and expiratory gases. So it is occupied by the gases that are rebreathed without any change in composition. Or in simple terms, they are the distance from the patient mouthpiece to the time there is diversion of inspiratory and expiratory flow. So it should be as close to the patient as much possible, because that's a dead space. And if you want to minimize this dead space, the diversion of inspiratory and expiratory should be as close as possible. So this is apparatus dead space or mechanical dead space. Remember the name. This is apparatus or mechanical dead space. Coming on to the physiological dead space. So we have talked about apparatus or mechanical. Now let's talk about physiological dead space. Physiological dead space again include two things: anatomical dead space and alveolar dead space. We talked about apparatus. Now we are talking about anatomical dead space. So what is anatomical dead space? The space which consists of patient's conducting airway down the alveoli. The air which is from the mouth to the alveoli, that's not gone to the alveoli. It's an anatomical dead space, and it contains inspired air. Fine. There is certain called alveolar dead space. It is a volume of air, volume of alveoli ventilated, volume of air from the alveoli which are ventilated but not perfused. So it contains air which is less in oxygen and more of carbon dioxide. So the important thing is that if the patient is inhaling or rebreathing anatomical dead space, it won't be a problem. But if the patient is rebreathing alveolar dead space, then the patient without a reservoir, without a CO2 absorber in a circuit, this means that the patient is rebreathing more of carbon dioxide. So let's start with the classification of breathing circuit. There's the open system with no reservoir, no rebreathing, semi-closed reservoir, no breathing, semi-open reservoir, no breathing, semi-closed reservoir, partial breathing, closed reservoir, complete breathing. So we won't be, this is more of a formality kinds. The another breathing system classification which was given by Miller and modified, it is breathing system without CO2 absorption, breathing system with CO2 absorption. When we talk about breathing system with CO2 absorption, that normal systems, circle systems, which have a CO2 absorber in the form of a soda lime canister. So there are breathing systems without CO2 absorption. There are breathing systems with CO2 absorption. So when we talk about breathing systems with without CO2 absorption, there are further two types: unidirectional and bidirectional. We will be coming on. Let's think of few assumptions. When we are talking about breathing circuits, there are few assumptions which we take. And unless we take that assumptions, we cannot describe the breathing circuit. The first and the foremost assumption is gases move unblock, and they maintain their identity as fresh gas, dead space gas, and alveolar gas. There is no mixing of these gases. See, whenever a person inhales and exhales, so there is always a mixing. You cannot say that this is an anatomical dead space, this is the dead space, alveolar dead space, this is the fresh gas. So we talk about this when we are describing a circuit. But as far as when we talk about the circuit, we assume that the gases move en bloc, and they maintain their identity as fresh gas, dead space gas, and alveolar gas. And the reservoir bag continues to fill up without offering any resistance till it is full. So first the reservoir bag is filled. Then once the reservoir bag is full, then the expiratory valves open. When the reservoir bag is full, then expiratory valves open, and the valve remains open throughout the expiratory phase, and it closes at the start of next inspiration. So we need to know these assumptions because we will be discussing on these only. So first assumption is that the gases move, unblock, and maintain their identity. The reservoir bag fills first. Once the reservoir bag fills, then the expiratory valves open. And then when the valve open, it remains open throughout the expiratory phase, and then the valve closed during inspiration. Clear? Fine. So now coming on to the first group, breathing system without CO2 absorption. Fine. There is no soda lime here. So they are further divided into two parts, unidirectional and bidirectional. Unidirectional is non-rebreathing system and the circle system. In these systems, the gas flows in a single direction. It doesn't go here and there, here and there. It flow in a single direction. Let's see how it does. See, this is a non-rebreathing system. There is no rebreathing in it. See what happens. This is a one-way valve. The patient takes fresh gas flow. It goes inside. This one-way valve closes from this side, and it goes here. See, you can see the two red things. There are one-way valve and a small black thing. That's a valve. So it goes when the patient inspires, all the fresh gas flow goes there. When the patient expires, this valve gets closed and this valve gets open, and the patient expires. See, you can see here. This is fresh gas flow. When the patient inspires, this moves and patient inspire. When the patient want to expires from here, this valve closes, and from here it can expire. He can expire. So this is a unidirectional one-way valve kind of a thing. There are no different directions of a gas. It's a unidirectional one-way valve. Fine. Coming on to the circle system. So we have talked about unidirectional two things, direct one-way valve. We talked about unidirectional rebreathing system, and then circle system. What happens in a circle system? The patient inhales. There are the two limbs, inspiratory limb and expiratory limb. It's quite simple. And there are two valves, inspiratory valve and expiratory valve. They do not mix with each other. You press the bag here, the gases move, opens the inspiratory valve and goes to the patient. When the patient expires, it goes from the respiratory valve, opens the respiratory valve and goes out. If the patient tries to expirate, then you can always ask, then when the patient is expirating, how can he decide that the expirated gas goes from this here? They can go from there also. So if they go from there, the valve closes. The valve opens only when the inspiratory gases comes from that direction. Clear? So here also, if the inspiratory gas obviously can go from this side, from this side. So if the inspiratory gas goes from this side, this valve again get closed because that's a unidirectional valve. So we can assume that this is the inspiratory limb and this is the expiratory limb. Clear? So we have talked about unidirectional flow, non-rebreathing circles system and circle system. Clear? Clear till now? Now we'll talk about bidirectional flow. There is a unidirectional flow and there is a bidirectional flow. In the bidirectional flow, the gases move from one place to another and another place to one place. Fine. So they are classified into four groups: efferent reservoir, enclosed efferent reservoir, efferent reservoir, and combined system. So let's look at them one by one. Efferent reservoir. What we mean by efferent reservoir? There is an efferent limb. What is that efferent limb? That contains the fresh gas from the machine to the patient. This is the fresh gas flow from the machine. This is to the patient. So this is the efferent limb. So efferent limb is that limb from where fresh gas flows from the machine to the patient. Fair enough. Now, there are three types of this. If the fresh gas flow is placed here, reservoir bag is placed here. Fresh gas flow is coming from here and reservoir bag is beyond the corrugated tubing. So this is Mapleson A. We'll be talking about Mapleson A in detail. Suppose the reservoir bag is at the end of the efferent. See, in all the efferent reservoir system, the reservoir bag is at the end of the efferent. A-F-F-E-R-E-N-T. So here it is efferent system, here it is efferent system, here it is efferent limb. So in all the situations, reservoir bag is the end of the efferent limb. But a fresh gas flow can vary. So here the fresh gas flow comes from this side, here the fresh gas flow comes from this side, and here the fresh gas flow comes from this side. So We have to think two things. One is the reservoir bag is at the end of the afferent limb. Second, you can see that APL valve, this APL valve is always close to the patient. So if you get, sometimes what happens that you ask to assemble the circuit and ask them, your examiner ask them, okay, these are the parts assembled. So APL valve is at the patient end, and the reservoir bag is at the end of the corrugated tubing. This is Mapleson ABC. Clear? Now, there is something called enclosed efferent reservoir system. In this, the Mapleson, it is like a Mapleson A only, but it is enclosed in a non-distensible structure. So I may not be talking about this, is more of a theoretical thing. Coming on to the breathing system without CO2 absorption, we talked about bidirectional, we talked about efferent reservoir system, enclosed efferent reservoir system. So now let's talk about the efferent reservoir system. Clear? So what is efferent reservoir system? In the efferent reservoir system, it has 6 millimeter tube as a efferent limb that supplies fresh gas flow to the machine. So this is the efferent limb and which supplies fresh gas flow. So then this becomes the efferent limb. Okay. So efferent limb is a wide bore corrugated tube to which the reservoir bag is attached. Clear? So reservoir bag is here in all the things, all the parts. But reservoir bag is attached to the efferent limb. And here the fresh gas flows. And the APL valve, you will notice that it is away from the patient end. Okay. So fresh gas flow near the patient end. You see, fresh gas flow was near the patient end. Just remember this. Fresh gas flow was near the patient end in Mapleson B also. Reservoir bag at this place also. But APL valve was close to the patient. So as soon as the patient expires, it goes out. So this contains the fresh gas flow. This is an efferent reservoir system. When we talk about efferent reservoir system, the fresh gas flow, and there's no APL valve at the end of the system. So then that becomes the efferent system. Gases go from here to here to get expired. So, so then this becomes the part of where there is an expired air. So then they become the part of efferent system. So when the efferent system, reservoir bag is attached to the efferent system, it is efferent reservoir system. And the fresh gas flows from these things. And the APL valve is away from the patient end. Fine. Coming on to the first circuit, that's a Mapleson A circuit. We also call it as Megill circuit. Good. So fresh gas flow is farthest from the patient. We have talked about the fresh gas flow is away. APL valve is closer to the patient. Reservoir bag is at the efferent limb close to fresh gas flow. See, this is the fresh gas flow. Reservoir is at the near the fresh gas flow. And this is the APL valve, which is closer. Reservoir bag is in the efferent limb. Corrugated tubing is there, which separates bag and valve. So this is the corrugated tubing, which separates bag and valve. Fine, clear? Right. So what happens when the patient is inspiring? When there's an inspiration, first I will be talking about spontaneous breathing, and next I will be talking about controlled ventilation. So when we talk about spontaneous breathing, what happens? The circle is filled, system is filled with the fresh gas before connecting to the patients. This whole is fresh gas flow. We start, patient inspires, so the fresh gas flow here from here, patient inspires from the machine and reservoir bag and flow to the patient. Reservoir bag, again, I've talked about 40 liters and 10 liter per minute. So you understand that reservoir bag holds the gases. So when the patient inspires, the fresh gas flows from the machine to reservoir bag, from that machine and reservoir bag, and flows to the patient, and reservoir bag collapses. Now what happens? During early expiration, patient has inspired, now patient has to expire. When the patient expired, the first gas which comes out is anatomical dead space. Gas in the anatomical dead space, which has same composition of air. Right? And then comes out the alveolar dead space. See, this is the anatomical dead space. We said that gases move en bloc. We assumed that. So this is the anatomical dead space. This is the alveolar dead space. And this is the fresh gas. So when the patient expires, during the early expiration, the fresh gas is coming. So fresh gas is putting a resistance from there, and the alveolar gas is pushing the resistance from there. So the reservoir still is filled with fresh gas, and the tubing still has fresh gas. So fresh gas continue to fill in the system and fill the reservoir back. The expired gas, which was initially a part of dead space gas, we have talked about dead space gas, pushes the fresh gas backward and in the backward, and so that the reservoir fills up. So here the expired gas is pushing it backward, here it is pushing it forward. Right? So, but still reservoir bag contains only fresh gas flow. As soon as the reservoir bag is full, so from one end, the patient is pushing the expired gas, and at the other end, fresh gas flow is pushing the fresh gas. So there is a tussle. So during that tussle, it's the APL valve which opens up, and then all the expired gases goes out. Fine. So this is how the system works. So as soon as the reservoir bag is full, the expiratory valves open and the alveolar gas is vented to the atmosphere. Now there is an expiratory pause. So if when all the gases are expired to the atmosphere, now again the system is filled with fresh gas flow. So during the expiratory pause, alveolar gas had come out the perimeter, pushed out to the fresh gas, pushed out to the APL valve, and this circuit is filled up with fresh gas flow. So again, when the patient breathes in this anatomical dead space, and then with the fresh air gas. So that's how it works. So here there are three things. If the here for a spontaneous breathing, fresh gas flow should be equal to the minute ventilation. If the system is filled only with fresh gas flow and the dead space gas at the start of next breathing. So this should happen. System has to be filled with fresh gas flow and dead space before the next cycle starts. So this happens when the fresh gas flow is equal to minute ventilation. Suppose fresh gas flow is more than minute ventilation. Okay. So what happened? When the fresh gas flow is more than minute ventilation, then alveolar gas will also go out from the APL valve, and the fresh gas flow will also go out from the APL valve. That's the wastage of fresh gases. Right. And suppose fresh gas is less than minute volume, then the alveolar gases remain in the system and lead to rebreathing. So for a continuous, for a spontaneous breathing, the Magel system or the Mapleson A is the best system. Just see this. The patient inspires, the fresh gas flow inside. The patient expires, it goes inside, but then it is pushed by and then APL valves open. See, so now clear Mapleson A. Now coming on to the controlled ventilation. So whenever there is a spontaneous ventilation, the efferent limb has the reservoir bag, and the reservoir bag is never filled with the alveolar gas. It is filled only with the fresh gas, and it goes at the rate of fresh gas flow is equal to minute ventilation. Clear enough? Coming on that we try to give the controlled ventilation through the Magel circuit. So expiratory valve has to be partially closed. There we kept the expiratory valve open. Open in the sense that whenever the fresh gas flows, it gets closed, and whenever there is an increase in alveolar gases, so it opens up. Here it is kept partially open because there are a lot of pressure which is coming by the pressing of back. So there has to be some venting out. So it is kept partially open. During the inspiration, the patient get ventilated with the fresh gas. So this is a fresh gas being moved. And part of fresh gas is vented out from the APL valve. Clear? So one thing is that we are wasting fresh gas. Now what happened? When the patient breathes in, see, we have collapsed the reservoir bag. So it become more empty. So it will fill up more. We have seen in the spontaneous respiration that we are not collapsing the reservoir bag. It is expanding only by the fresh gas. Now here when we collapse the reservoir bag, it will expand more, and when it expands more, it will get more of alveolar air. Clear? So when it expands more, it will get the alveolar air, it will get the dead space air also. So besides getting the fresh gas flow, it will have all the three components. Right? So during expiration, the fresh gas from the machine flows into the reservoir bag and all the expired gas flows back into the corrugated tubing till the system is full. So the system needs very high fresh gas flows so that this bag remains filled easily, gets up filled easily and not by the fresh gas only, not by the alveolar gas. Clear? So that's the reason why it is not good as a controlled ventilation circuit. Clear? So we have seen that the reservoir bag get filled up with the alveolar gas also. So when we press it again, the whole mixture goes, the fresh gas also goes out from the APL valve, the alveolar gas are also rebuilt. So little haywire kind of things occur. So that's the reason why it says that for spontaneous respiration, Magel's system or Mapleson A system is the best. For controlled ventilation, it is not good. Disadvantage, it has considerable rebreathing. APL valve is close to the patient, so scavenging. Suppose there's a oral surgery which is going on, so APL valve is very near to the patient. So it will be difficult scavenging and difficult access and excessive waste of fresh gas. So to summarize, the Magel system is efficient. I'll be repeating not many times. The Magel system is efficient for spontaneous ventilation and it has fresh gas flow which is equal to minute ventilation. The Magel system is insufficient for controlled ventilation. There you require fresh gas flow, which is 3 to 4 times the minute ventilation. The APL is at the patient end, and this is certainly not suitable for pediatric age group. Clear? So seeing all this, Mr. Lack came out with the Lack's modification. So Lack's modification and Bain's modification both have coaxial circuits. So there is 1.8 meter length coaxial tubing, tube inside the tube. See, there's a tube inside a tube. The fresh gas is through the outside tube and exhaled gas flows through the inside tube. Remember this thing because when we talk about Bain's circuit, it becomes opposite. The fresh gas flow is from the outside tube. This is fresh gas flow. So this is from the outside tube and the expired gases is from the inside tube. Clear? So fresh gas flow moves from the outside tube and inhaled gases flow through the inside tube. The inside tube is wide in diameter of 14 mm to reduce resistance to expiration. The outer tube diameter is 30 mm. So inside tube diameter is 14 mm, which carries the exhaled gases, and the outer tube diameter is 30 mm, which carries the fresh gas flow. Clear? The reservoir bag is mounted at the machine end and APL valve is mounted at the machine end. APL valve has to be mounted in the machine end. Okay, so this is the machine end. Here the APL valve is mounted and the bag is also mounted. Clear? So what happens when the patient inspires? It goes to the patient. When the patient expires, it goes back and goes through the expiratory limb and also comes in the fresh gas flow limb. So this is how it all works. The disadvantage of Lack system is similar to Magel system. It is good for fresh gas flow, but not good for spontaneous breathing, but not good for controlled ventilation. Coming on to Mapleson B, not much to know about it. It was made to reduce rebreathing. The important thing is fresh gas flow is near the patient end. APL valve has to be near the patient end in Mapleson A, B, and C, but here the fresh gas flow is also near the patient end. Coming on to the fresh gas flow near the patient end, there is no corrugated tubing. So that comes with the Mapleson C. Now comes the important part. So two circuits are important, Mapleson A and Mapleson D. What happens in Mapleson D? The fresh gas flow is close to the patient. We have talked about it. Reservoir bag is farthest to the patient. See, fresh gas flow is close to the patient. Reservoir bag is farthest to the patient and APL valve is also farthest to the patient. Clear? So the APL valve is farthest to the patient. Okay. So corrugated tube is between valve and fresh gas flow. Okay. So when we talk about the spontaneous ventilation, see, Bain circuit is good for controlled ventilation, but not good for spontaneous ventilation. So we'll see it how. The patient exhaled gases are channeled back. The patient exhaled gases, these are the exhaled gases, are channeled back. Okay, so it will again go into the reservoir bag. See, when the reservoir bag contains the expired gases, that is not good. Right? So it will again come to the reservoir bag and then it goes out to the pop-off valve. And since the fresh gas flow is near the patient end, so patient will receive fresh gas flow, but the patient, all the gases will go out from the APL valve and also go on the breathing bag, reservoir bag. So the fresh gas flow required to prevent breathing is actually 1.5 to 2 times the minute volume. Clear? Here at the lax or Mapleson A, the fresh gas flow has to be equal to minute volume for spontaneous breathing. And for controlled breathing, it has to be 3 to 4 times the minute volume. When we talk about Mapleson D, the fresh gas flow to prevent rebreathing is 1.5 to 2 times, and flow rate of 150 to 200 ml per kg per minute. So this is a good amount which is required. So we have seen. Now come to the Mapleson D, which is usually used as a controlled breathing measure. So it's a more efficient system for controlled ventilation. A flow of 70 to 100 ml per kg per minute is required. There the flow of 150 to 200 ml per kg per minute is required. But here the flow of 70 to 100 ml per kg per minute is required. Coming on to another interesting thing is the Bain circuit. It has a length of coaxial tubing of 180 centimeter. Fine. The most important part is that you can increase the tubing length as much as possible. So it can be supplied at 270 centimeter, the tubing, coaxial tubing. It will be like in oral surgeries and where the tubing is to be away. And it can be as far away as 540 centimeters, because whenever you are in a MRI suit, so you sit outside or in a CT room, you sit outside and connect the ventilator, connect the patient to the breathing circuit. So the length of the corrugated tube can be extended. So normally it is 180 centimeter, but it can be 270 centimeter and 540 centimeter. Now the outer tubing is 22 mm and inner tubing is 7 mm. Remember from the lax system, the outer tubing was 40 mm and inner tubing was 14 mm. Now here the outer tubing is 22. So this means that this is not as bulky as the Magel system is. So outer tubing is 20. These are the small figures you should know for the exam. So there's nothing much to learn from it, but you should know this from the exam point of view, because usually asked. You can get a short note on Bain circuit. You can ask by the examiner on the equipment station that, okay, this is the Bain circuit, tell us. So increasing the length of the tubing. The important thing is increasing the length of the tubing does not affect the physical properties of breathing system. So you can increase it to as long as possible. Okay. Another few facts: fresh gas flow during spontaneous is required as 150 to 200 ml per kg per minute. We have talked about it. But for a controlled ventilation, it requires a 70 to 100 ml per kg per minute. This means that the Bain circuit is good for controlled ventilation, but this is not good for a spontaneous ventilation. Fine. There was something like a few years back, but when I learned the anesthesia, what happened? They used to put in the Bain circuit at the time of extubation, and they feel that when you put in the Bain circuit at the time of extubation, you bypassing the soda lime and the inhalational agent which are in the soda lime are not going to the patient. But no, when the patient is spontaneously recovering, this circuit is bad. So don't use this circuit when the patient is coming out of anesthesia. When you are extubating a patient, do not put this circuit, because this is not good for the spontaneous ventilation. Or if you have to use, then increase the fresh gas flows. You can use, but increase. Then suppose you are using 3 liters or 5 liters fresh gas flow during the whole anesthesia, and when you are using it for the reversal, so then increase the fresh gas flow to the extent of 150 to 200 ml per kg per minute. Okay, the fresh gas flows through the inner tube. See, listen to it carefully. Fresh gas flows through the inner tube, and exhaled gases come out to the outside tube. Right? See, here, the fresh gas flows through the inner tube in the Bain circuit. Fresh gas flows through the inner tube, and expired gas come out to the outer tube. This is what we have seen in the legs. The fresh gas flows through the outer tube and expired gases come on the inner tube. This is totally opposite. Clear? Sometimes you get a question on right differences between lag circuit and vein circuit. Fine. So advantages of vein circuit is it is low dead space, low resistance, lightweight. It's a long tubing. You can take it as far as possible. Easy for scavenging, fine, because APL valve is far away. Heat and moisture retention because the expired air is from the outer tubing. Inspired air is from the inner tubing. So when the expired air goes from the outer tubing, the inspired air gets a heat of expired air during movement. Okay, and they are disposable. Now there are certain disadvantages of using vein circuit. One is that it cannot be used for spontaneous ventilation. The other disadvantage is kinking of internal tube. Suppose the inner tube gets kinked. Inner tube is with a fresh gas flow, or the inner tube, there is a leak in the inner tube, then the whole system becomes a dead space, which result in hypoxemia and hypercapnia. So we always check the integrity of the inner tube. I'll be talking about the few tests by which we check the integrity of inner tube. So inner tube can become disconnected at the machine end, or it can be kinked. So in that case, the whole system becomes the dead space and patient goes into hypoxemia and hypercapnia. Movement of reservoir bag during spontaneous is not an indicator. Fine. So this is fresh gas flow. This is expired. Suppose there is a leak somewhere here. So then the whole system becomes the dead space. This is what we have talked comparison of legs. So now coming on to the checking of vein circuit, because it's very important. You first do the inspection. There is no obvious leakage point. Then you start to take the fluid flow rate of 2 liters per minute, and take a plunger or small syringe and press on the inner tube. If inner tube has fresh gas flow, so if when you press the plunger in the inner tube, the flow meter should come down. So they should have a downward trend, then they will go up. But when you are putting in the syringe, so you are occluding the fresh gas flow so little bit, so the flow meter or bobbin comes down. Fine. The other test which is usually asked, and that's a pass-fail kind of a question, you should know this. It is Appec test. But how do we do Appec test? The patient port must be open to the atmosphere. Right. APL valve is closed. Okay, oxygen flush valve is activated, closed. High gas flow through the inner tubing. Okay, so you push high gas by using the oxygen flush. The high gas flows through the inner tubing. When the high gas flows to the inner tubing, it creates a Venturi principle. Now, what is the Venturi principle? Venturi principle says that once a gas moves from a narrow tubing, it creates a negative space outside. There is one other equipment you use where the Venturi principle occurs, right? It is in the Ventimask. So high gas flow moves through the inner tube will produce a Venturi effect, which lowers the pressure in the outer tube. And when it creates a pressure in the outer tube, if there is no issues with the inner tube, the bag will deflate. Okay. So whenever the bag you first use the switch off the APL valve and make it open to atmosphere, the patient port, and then you use oxygen flush. And if you, by using oxygen flush, if you see that the bag is collapsing, this means that the vein circuit inner tubing is patent. Right. Coming on to the Mapelsoni, not much. It's like a T-piece. T-piece has 3 ends, fresh gas flow from the anesthesia machine, patient mask or tracheal tube is here, and reservoir tubing is here. Usually they do not put a reservoir bag in this, but once they put in the reservoir bag, then that becomes Mapelson F. The similar system, it's a open-ended, so one can see the respiration pattern by using this. So this was modified by Jackson-Rees. So sometimes it is known as modification of Jackson-Rees is Mapelson F. Fine. So till now we have talked about breathing systems without CO2 absorption. Now I'll be talking about breathing systems with CO2 absorption. There is a unidirectional flow which is in the circle system. This is the circle system. Same we have seen in the circle system, but now the difference is there is a reservoir bag. Right. So here the fresh gas flows goes inside. This is a ventilator. So this thing had been taught to you in the last session. So the fresh gas flows here, then goes inside the patient, and here the expired gas goes, and then it goes through the soda line, and the CO2 gets absorbed, and then here it comes as another fresh gas flow, or the expired CO2 gases minus the CO2. Fine. So circle system, as we have talked about, it's similar. The only thing is now there is a soda lime canister, the fresh gas flow, inspiratory limb. The same thing is there: inspiratory limb, expiratory limb, inspiratory unidirectional valve, expiratory unidirectional valve, the reservoir bag. The only difference is canister, soda lime canister. So two unidirectional valves on either side. The APL valve should be positioned in the expiratory limb. The fresh gas flow should enter the system proximal to the inspiratory limb. So this is proximal part. So fresh gas flow should enter the system proximally, and the expired gases fill up the reservoir bag, and it goes to the canister, soda lime canister, and then it becomes carbon dioxide free or decreased carbon dioxide, and then it goes towards the patient. So checking of how to check the circle system: keep all the gas flow zero, close the APL valve, and then pressurize the system at 30 centimeter of water by using the flush. And when the system get pressurized to 30 centimeter of water, it should remain pressurized for at least 10 seconds. So if the bag remains inflated for 10 seconds, this means that the circle is okay. Coming on to the few small things, soda lime, it's again not big thing to know. Soda lime consists of 94% calcium hydroxide, 5% sodium hydroxide, less than 1% potassium hydroxide. It has silica to harden the absorbents and reduce powder formation, and it contains zeolite, which maintain pH. The pH of the system is 13.5, moisture content is 14 to 19%. Then there are soda lime granules. We talk about soda lime granules in the mesh system, which means that the mesh system of 4 to 8 means that it can stain the 4 and 8. It has 4 and 8 openings per inch. So higher the mesh number, smaller the particles are, because suppose the mesh number is 12, then it will have 12 openings. So diameter of each opening further reduces, so the smaller the particles are. Recently produced soda lime make our uniform shapes of 3 to 4 mm spheres, which allow even more flow of gases. This is one thing I like to tell. This is the fresh soda lime. So this is the patient end, and first the side soda lime gets exhausted, then at this side, and after the whole soda lime get exhausted, then almost whole soda lime get exhausted. So there are few soda lime indicators: phenolphthalein, which converts white to pink; the mimosa Z, which we use, that converts red to white. You must be seeing the soda lime in your institute. It is red in color and it converts to white. So good luck to you. All the best, and be proud of being an anesthesiologist. All the best for your exams. Thank you.
Well, Dr. Akhilesh.
Thank you, sir.
I went through all the entire lecture, and I very precisely heard about each and every word delivered by you. It was a very impressive, very informative, very nice lecture, and very lucid lecture given by you. In addition, it was very beneficial for all the students who are going to appear in the exams, because we have covered most of the components which need to be covered by the trainers to their examinees, isn't it? For example, you very nicely talked about the respiratory valves, their positions, their suitability. For example, it should be hydrophobic. This should be emphasized. That's what you did, isn't it? Similarly, you talked about the dead space, factors affecting the rebreathing. These are very important. They will definitely be asked in the exams. The boys, the examinees cannot escape without undergoing all these things. Similarly, you made a very nice point like lax modification, isn't it? So all these things are definitely going to help all my students. And of course, there's nothing left to add, Dr. Akhilesh. And one more thing, the difference, we even told about the difference in lax system and the Bain system. How do they differ? Similarly, in the last, you talked about the soda lime constituents and soda lime indicators. This was the last. I think from A to Z, you covered everything. And I believe hardly there is anything left which you could not cover. In the chat box, I could see one question.
There is one question.
I could not understand what the lady wanted to know about afferent and accidents B system. What is the difference?
I think they want to know afferent and efferent system.
But they could not write that.
Yeah, yes. I think the basic difference they should know is in the afferent system, the APL valve is near the patient, so that the gases went out from that APL valve, and from throughout the system, the fresh gas flows. Vis-a-vis, when we talk about efferent system, the fresh gas, APL valve is near the bag, so that the whole gas traverses to the limb and then goes out, efferent gas. So that is why it's known as a efferent system.
I think the candidate's doubt might be clear. I believe so. Thank you, Dr. Akhilesh. It was a very nice, useful lecture. I once again congratulate you for a nice, decent lecture.
Thank you. Thank you, sir. Thank you.
Well, I now welcome the second speaker, who is Nisha Kachru. Nisha Kachru, she is a professor and affiliated to ABVIM RML Hospital, Delhi. Her area of interest is pediatric anesthesia and transplant anesthesia. So one of her interest topic is the transplant anesthesia. She will now be delivering a lecture on transplant anesthesia and will cover all aspects which might be asked, which need to be asked in the EGPG exams. Welcome.
Good afternoon, everyone. I will be discussing cirrhosis and portal hypertension. Now, what is cirrhosis? Cirrhosis is the pathological endpoint of chronic inflammatory liver disease of any cause. The various causes, most common is fatty liver disease, alcoholic or non-alcoholic. Viral infections are again common, hepatitis B, C, and D, autoimmune diseases, chronic biliary diseases, cardiovascular diseases, certain storage diseases, and there are rare causes such as drugs and porphyria. Now, what happens when any chronic injury takes place, which includes all these various causes that I've given you? There is an inflammatory response. Parenchymal cell death occurs, is matrix deposition and angiogenesis. All of this leads to fibrosis. As the disease progresses, there is loss of function of the liver. But apart from that, the normal architecture is disrupted because of the increasing fibrosis. There is aberrant hepatocyte regeneration, leading to formation of micronodules and ultimately cirrhosis. Now, at any stage, this disease can regress because of removal of the underlying therapy or treatment. However, in case that does not happen, the patient proceeds to portal hypertension and liver failure, both of which can again progress to hepatocellular carcinoma, and the ultimate treatment is a liver transplant. Now, the patients who present to us for surgery or in the ICU may have any stage of liver damage. They may just have a chronic liver disease with a basically normal underlying liver. Excuse me. There may be an early fibrosis, late cirrhosis, or cirrhosis along with portal hypertension. What is portal hypertension? Portal hypertension is basically a resistance to the flow of blood in the portal system. Normally, there is a hepatic venous pressure gradient, which is 1 to 5 millimeters of mercury, and this is required for movement of blood in the portal system. However, as I said, in cirrhosis, there is an increased fibrosis and formation and distortion of the liver architecture. This leads to increased pressure in the portal system. Apart from that, there is an altered local vasoconstrictor and dilator imbalance, which further increases this portal hypertension. Now, as I said, the normal portal pressure is 1 to 5 millimeters of mercury. Between 5 to 10, it's called mild portal hypertension, and beyond 10, it becomes clinically significant with the formation of collaterals. So as chronic liver disease progresses and portal pressures increase, there is an initially a compensated cirrhosis where the patient may be asymptomatic and usually does not have varices, or they may be undiagnosed. As the portal pressure goes on, increases, and cirrhosis becomes decompensated, there are chances of variceal hemorrhages, ascites, encephalopathy, or jaundice, and with further increase, it is a more severe manifestation of this decompensated cirrhosis with recurrent hemorrhages and refractory ascites and other systemic involvement. Now, cirrhosis is important because it involves not just the liver, but every system of the human body. Each of this is important for us as anesthetists to know, so I'll proceed one by one. patients develop anemia. This is not only because of chronic illness, but also because of malnutrition due to lack of appetite, this blood loss, hypersplenism, and bone marrow depression. Another very important finding is the coagulopathy seen in these patients. Liver is the site for synthesis of all the clotting factors except for 3, 4, and 8. It is the site for synthesis of the anticoagulant factors, protein C, S, and antithrombin 3, and it is also responsible for clearance of activated factors. All of these get affected by cirrhosis. Apart from that, there is a thrombocytopenia due to the splenomegaly and bone marrow depression. There is vitamin K deficiency, and deranged liver function also leads to dysfibrinogenemia and accelerated fibrinolysis. All of these together lead to a coagulopathy in these patients. Patients also develop cardiac manifestations. They have in the form of a hyperdynamic circulation because of a low systemic vascular resistance with a high cardiac output. Patients have a bounding pulse, but the blood pressure is generally low due to this low systemic vascular resistance. In the pulmonary circulation, the pulmonary vascular resistance is normal, but the pulmonary artery pressure is raised. There is a cirrhotic cardiomyopathy, which involves systolic dysfunction with impaired ventricular response to stress and catecholamines, and a diastolic dysfunction due to which there is a delay in the left ventricular filling. ECG abnormalities are present in the form of prolonged QT interval, and many patients have underlying coronary artery disease, which may not be manifested because of the low blood pressure. Renal changes are especially important for us. Patients have hypotension, as I already said. This leads to renal hypoperfusion and a fall in the glomerular filtration rate. There is also a secondary hyperaldosteronism with activation of the renin-angiotensin-aldosterone system and vasopressin release. With these lead to sodium and water retention and peripheral edema along with ascites. Although there is sodium retention, however, there is dilutional hyponatremia which is seen in these patients. Potassium may be raised or lowered depending on if the patient is on diuretics and other factors. Patients also very often have coexisting diseases such as diabetes, other nephropathies, and amyloidosis, all of which impact the renal function in these patients. The metabolic changes which are seen are that there is a reduction in the protein synthesis, obviously, since the liver is the site for protein synthesis. So because of that, the patient has muscle wasting and is cachexic. And these patients are also prone to hypoglycemia because of derangement of the glucose metabolism and decreased glycogen stores. Now, as the renal disease progresses, many of the patients can eventually end up with a hepatorenal syndrome. Hepatorenal syndrome is basically a functional renal failure with no renal pathology. And this is seen in patients with cirrhosis when the serum creatinine goes above 1.5 milligram per deciliter. These patients often present with ascites, edema, azotemia, oliguria, or an electrolyte imbalance. The hepatorenal syndrome is important for us because it can get precipitated in the perioperative period due to the pre or intraoperative hypovolemia, use of diuretics, drugs which may be nephrotoxic, and an increase in the intra-abdominal pressure, which can be preoperatively due to ascites or intraoperatively due to the surgery that is being performed. The hepatorenal syndrome generally seen in the perioperative period is of type 1. It is rapid in onset. There is a precipitating cause like, as I said, surgical stress or GI bleeding. Other causes include spontaneous bacterial peritonitis or a large volume paracentesis in the ascitic patients. It has a poor prognosis and survival is only 2 to 4 weeks. Some patients may also have a type 2 type of hepatorenal syndrome, which is more gradual in onset and has a better prognosis with a slightly longer survival. This hepatorenal syndrome thus has to be prevented and managed if it occurs. How do you do that? So it is important for us to maintain renal perfusion in these patients. They should be given intravenous fluids and adequate volume expansion with albumin may be done. Renal perfusion pressures can also be increased with use of octreotide, terlipressin, or norepinephrine infusions. Nephrotoxic drugs such as NSAIDs, aminoglycosides, and some antihypertensives need to be avoided. and ultimately the patient may have to go in for a dialysis. Pulmonary complications in cirrhotic patients are of two types. They may be either mechanical because of the ascites or the pleural effusion which develops, or they may be because of vascular changes. I'll come to the vascular changes first. Patients can develop hepatopulmonary syndrome, which is a triad of portal hypertension, hypoxia with an alveolar arterial oxygen gradient of more than 15 millimeters of mercury, and intrapulmonary vasodilatation. All of these lead to hypoxia and an impaired hypoxic pulmonary vasoconstrictor response. The patients present with platypnea and orthodexia. Platypnea is shortness of breath in the erect position and relieved by lying down. And orthodexia is also similar in the sense that there is a fall in the PaO2 by 4 millimeters of mercury or 5% in the standing position as compared to the supine position. The patients who develop hepatopulmonary syndrome need supplemental oxygen to manage the hypoxia. Some patients may develop portopulmonary hypertension. This is pulmonary artery hypertension in a known case of liver disease with no other apparent cause. It is diagnosed on echocardiography by right heart catheterization, and the pulmonary artery pressure is greater than 25 millimeters of mercury with a pulmonary vascular resistance of greater than 240 dynes per second per centimeter, and the pulmonary artery wedge pressure is usually less than 15 millimeters of mercury. The patients may again be graded into mild, moderate, or severe according to the severity of the pulmonary artery hypertension, with patients having pulmonary artery pressures of more than 45 millimeters of mercury being contraindications for liver transplant. Reversible type of encephalopathy is seen in patients with cirrhosis called hepatic encephalopathy. It is precipitated by the gut toxins, neurotoxins like and ammonia, which instead of being metabolized by the liver, bypass, cross the blood-brain barrier and produce neuropsychiatric or neuromuscular manifestations. Hepatic encephalopathy is precipitated by use of general anesthesia, sedative, infections, GI bleeding, presence of portosystemic shunts, diuretic overdose, and high protein diet. So we have to be vigilant in all patients, especially those who are given general anesthesia and sedatives. This encephalopathy is divided into 4 categories according to the grade, ranging from a trivial lack of awareness and disordered sleep to coma in stage 4. And this classification is important when we have to assess the prognosis of patients after surgery. Hepatic encephalopathy can be avoided, as I said, can be precipitated by use of general anesthesia, sedatives, and opioids. So as far as possible in severe cases, it needs to be avoided. The precipitating cause has to be eliminated. There is restriction of protein intake, and treatment consists of oral lactulose or neomycin or rifaximin. In patients who are comatose, the airway also needs to be protected. Patients develop gastrointestinal symptoms in the form of ascites, gastroesophageal varices, or splenomegaly. Ascites occurs due to the activation of the renin-angiotensin-aldosterone system with sodium and water retention. It is further increased because of hypoalbuminemia and decreased oncotic pressure and increase in the portal hydrostatic pressure. The effect of ascites is mainly to cause diaphragmatic splinting. There is a reduction in the functional residual capacity and the pulmonary compliance, and patients are prone to atelectasis. This is worsened in those patients who also develop a pulmonary effusion. Pleural effusion, which occurs because of passage of the ascitic fluid through spaces in the diaphragm, and also precipitated further because of the hypoalbuminemia. Ascites also decreases the renal perfusion pressure. It predisposes the patients to aspiration, and patients themselves are more prone to spontaneous bacterial peritonitis. They may also have a falsely high CVP, and in the post-operative period, there may be abdominal wound dehiscence or herniation. Ascites in the preoperative period needs to be managed before the patient is taken up for surgery. Patients are given a salt-restricted diet, use of diuretics like spironolactone or furosemide is done, and patients who have a portal hypertension are put on non-specific beta blockers. In case the ascites is refractory to this treatment, medication such as midodrine is used and paracentesis is often done. In case patients need large volume paracentesis, that means drainage of more than 5 liters of ascitic fluid, albumin at 8 grams per liter should be given as a substitute. Otherwise, they tend to have hemodynamic collapse. Some patients may also require TIPS, that is transjugular intrahepatic portosystemic shunt placements. Many of these patients, as I already said, have portal hypertension due to which they develop portosystemic collaterals to bypass the blood flow from the liver. And these varices are formed most commonly at the lower esophageal and stomach junction. The risk is there of spontaneous rupture and bleeding. There can be massive hemorrhage from these bleedings. And they are often put on non-selective beta blockers, as I already mentioned, and patients may be taken up for endoscopic ligation and sclerotherapy. In case called upon to manage a case of acute variceal bleeding, the anesthetist may need to protect the airway. Volume resuscitation has to be done to maintain an adequate volume status and urine output. Any coagulopathy has to be corrected. Varices are managed with the use of vasoconstrictors such as octreotide, terlipressin, etc. Patients are put on antibiotics. Some of these patients may have a balloon tamponade done, which may make intubation and ventilation difficult. And the anesthetist may also be called in case the patients need endoscopy or have to be taken up for TIPS. Now, coming specifically to management of patients with cirrhosis of the anesthetic management of a patient with cirrhosis of the liver. I have taken a hypothetical case of a 55-year-old female who is a known case of cirrhotic liver disease and has presented with carcinoma endometrium of the uterus. Now, further treatment will depend not on the stage of her carcinoma, and obviously we have to manage her medical problem also. Now, what does the pre-anesthetic assessment involve? We need to know the extent of liver dysfunction, other systemic involvement, and the patient has to be optimized before she's taken up for surgery. When the history is taken in such a patient, the duration of onset of symptoms is seen to be usually gradual. So when you take these history, you also have to ask patient for any symptoms. Many of these patients are asymptomatic, or they may have non-specific symptoms such as loss of appetite, malaise, fatigue, disrupted sleep, or cognitive decline. Take history for any use of alcohol, medical drugs or recreational drugs, past history of blood transfusion, previous history of jaundice, any GI bleeds, abdominal distension, and altered coloration of urine and stool. Family history of genetic disease can be taken to diagnose the cause of cirrhosis. Examination of the patient should involve a general physical examination. These patients may be cachexic with muscle wasting, or there may be edema. There may be clubbing in case the patient has developed a hepatopulmonary syndrome. Patients may be icteric. Petechiae may be present because of thrombocytopenia. As I said already, various systemic involvements have to be checked. Central nervous system examination to rule out encephalopathy. Look for any drowsiness, confusion, tremors, asterixes. Chest examination for ruling out presence of pleural effusions. Abdominal examination to look for ascites, size of the liver, any splenomegaly, and any signs of liver failure such as caput medusae or spider nevi. What are the investigations you will ask for? Every patient needs a baseline CBC. As I said earlier, the patients may be anemic and they may have thrombocytopenia and TLC to rule out any infection in these patients. Blood glucose has to be checked. Patients may be hypoglycemic or there may be a coexisting diabetes mellitus. Kidney function tests in the form of urea and serum creatinine. Electrolyte imbalance is often seen not only in terms of hyponatremia, hypo and hyperkalemia, but magnesium and phosphate levels may also be deranged. Liver function tests have, of course, to be done. Coagulopathy is assessed by measuring the PT-INR levels. Chest X-ray and ultrasound to look for pleural effusion. ECG, echo, or stress echo for checking for cirrhotic cardiomyopathy or any underlying coronary artery disease. Patients in whom there is pulmonary involvement will need ABG and PFT, and of course, vital markers in case of hepatitis B or C being present in these patients. Now, before the patient is taken up for surgery, we have to do a risk evaluation. The risk in these patients depends on either the surgical factors or patient factors. Now, this patient who is coming for hysterectomy is most probably coming for an elective surgery. The risk is higher in case the patient has to be taken up on an emergency basis. For example, if there is an increased bleeding from the uterus. Also, the nature of surgery. Certain surgeries increase the risk of mortality in the postoperative period, and any laparotomy also is a high-risk procedure. Patient factors will obviously involve be determined by the extent of liver disease and the presence of any comorbidities. Now, how do we assess the extent of liver disease? There are various scoring systems. One is the Child Turcotte Book scoring system, which considers any history or presence of encephalopathy, the degree of ascites, level of bilirubin, level of serum albumin, and the INR in these patients. So there are these 5 factors which are taken into consideration, and there is a scoring system whereby 1, 2, or 3 points are given according to the scoring. The total score is 3 to 15. Patients who fall under CTP class A have a score of at the most 5 to 6, and they are at mild risk for surgery with a 2 to 10% mortality. Class B patients are moderate risk with up to 30% mortality, and patients with a CTP score of greater than 10 are high risk, are poor risk, and the mortality for surgery is up to 80%, and so they are a contraindication for elective surgery and need to be optimized preoperatively, and these values need to be corrected. Another scoring system is the MELD, or model for end-stage liver disease. This scoring system not only tells us the perioperative mortality, but is also used to decide the organ allocation in case the patient is waiting for a liver transplant, and it also tells us about the 3-month mortality of patients with liver failure. This score is based on measuring the INR, serum creatinine, and serum bilirubin. These are entered into this formula, and the MELD score is calculated. A MELD score of less than 10 corresponds to a CTP score of A, but that is mild risk. 10 to 14 is CTP-B, moderate risk, and greater than 14 is equivalent to CTP-C, that is, patient is a high risk for surgery. Now, how do we optimize these patients? In case there is time, nutritional status of the patient has to be improved. Low protein, high calorie diet is given. Patient should abstain from taking alcohol. Optimize the hydration, build up the intravascular volume. If the patient has a very low blood pressure, that also may need to be managed. Metabolic and electrolyte derangements have to be corrected. Any active infections need to be treated. Hypoglycemia has to be corrected. Ascites and hydrothorax should be minimized. Correction of coagulopathy is required in the form of blood component therapy, whether FFP or platelets or cryoprecipitate, and vitamin K, Trenexa, recombinant factors, etc. have also been given. The renal status and encephalopathy needs to be assessed and patient optimized, as already discussed previously. In case the patient is coming for major surgery, such as a Vadheim's hysterectomy, or even otherwise, certain precautions have to be taken and the OT has to be prepared accordingly. Universal precautions for hepatitis B and C have to be taken. For every case, we need a large bore IV access because they're at increased risk for bleeding, especially if they have a coagulopathy. Again, if they have a coagulopathy, we need to arrange all blood and blood products. And in case of massive expectation of massive bleeding, rapid infusion systems also can be made available. Patients are prone to hypothermia, so fluid and other warming devices should be available. Patients who are coming for major surgery will need invasive monitoring and ionotrope infusions, and strict asepsis should be maintained. What are the anesthetic concerns? In a patient with cirrhosis, it is very important to maintain hepatic blood flow and oxygenation to prevent decompensation and worsening of the liver disease. The factors which affect hepatic blood flow are hypoxia and hypercarbia, hemorrhage, any mesenteric traction or increase in the intra-abdominal pressure. Both general anesthesia and regional anesthesia cause a fall in the hepatic blood flow and oxygenation. So use of intravenous drugs, volatile anesthetics, IPPV and PEEP, all of them will impact the hepatic blood flow and any sepsis in these patients. So all these factors have to be taken care of, and so that we do not cause any deterioration in liver function and any precipitation of the decompensatory changes in the postoperative period. And as I said earlier, the patients who are decompensated are the ones, those who develop complications such as encephalopathy, worsening of jaundice, ascites, etc. Other anesthetic concerns include avoidance of IM injections in patients with coagulopathy, avoid nasal intubations, NG tubes, esophageal probes. Again, there is a risk of bleeding from varices in these kind of patients. We have to be aware that patients may be on beta blockers and diuretics, and they are hyporesponsive to vasopressors. So the blood pressure has to be maintained carefully. Another important thing to be considered in patients with liver disease is the alteration of the pharmacology and pharmacokinetics of various drugs that we used. There is an increased sensitivity to all the anesthetic drugs. These patients also have a large volume of distribution. And because of that, the initial dose of many drugs may need to be higher. There is increase in the free drug levels because of reduction in the serum albumin levels and reduced protein binding. There may be reduced hepatic clearance of drugs and prolonged duration of action, and there may be accumulation of active metabolites, which further prolong the duration of action of these drugs. Pre-medication, we need to avoid sedation because, as I said, it precipitates encephalopathy. All of the things that I am saying here will depend on the CTP score of the patient. The higher the CTP score, the more the chances of seeing all these problems, and they have to be managed accordingly. So patients with CTPA might be given sedation. Lorazepam and oxazepam are safer. Diazepam, midazolam should be avoided. We have to keep in mind that the dose needs to be reduced and the duration of action may be prolonged. Patients with ascites will also need proton pump inhibitors because they are prone to aspiration. When IV induction agents are used, we need to remember that the dose has to be reduced because they are increasingly sensitive to the CNS depressant action of the drugs. Propofol will be the agent of choice. It maintains the hepatic arterial buffer response, which means it maintains the blood flow to the liver and the oxygenation. The liver has a buffer response in the sense that the blood supply to the liver comes from the hepatic artery and the portal vein. And in case the flow through one of these is reduced, the flow through the other increases to compensate for that and maintain oxygenation. This is the hepatic arterial buffer response. Propofol maintains this response, so it is a good agent to be used. It also has less intrahepatic, it also has some extrahepatic metabolism and has less chances of producing encephalopathy and patients may make a normal recovery. Thiopentone may be used, but it should be used in low doses because the binding to albumin is reduced and free drug levels are high. All volatile agents reduce the mean arterial pressure and cardiac output, causing a fall in the hepatic blood flow. Halothane and enflurane should be avoided. The buffer response is best preserved with isoflurane, sevoflurane, desflurane, and all of these can be used. However, out of these, desflurane is the safest because it undergoes less hepatic metabolism, causes a less fall in cardiac output and hepatic blood flow, and there is rapid emergence from anesthesia. Nitrous oxide can also be avoided because it also has an impact on the hepatic blood flow. Of the opioids, morphine is best avoided because the free drug levels are increased, the action is prolonged, and the patients are more prone to hepatic encephalopathy in the postoperative period. Out of all the opioids available to us, fentanyl is safe. However, we can have to keep in mind that large doses or infusions can accumulate and action may be prolonged. And so it is the opioid of choice in these patients. Scoline can be used especially in patients who need rapid sequence induction, like those with ascites. However, the duration of action is prolonged because of the lower levels of pseudocholinesterase. Among the non-depolarizing agents, Atracurium and cis-atracurium are safe because they do not undergo hepatic metabolism. Vecuronium and rocuronium have the maximal hepatic metabolism. However, for all the actions, it needs to be remembered that there is a slower onset of action due to a large volume of distribution, and the duration of action is prolonged because of these changes in the metabolism. Neostigmine is usually unaffected. Now, what are the monitors we will use in the patient? Standard monitoring in the form of ECG, SpO2, NIBP, and end-tidal CO2 should be done. It is advisable to do temperature, urine output monitoring, and neuromuscular monitoring in all the patients. Blood loss has to be monitored in cases of major surgery and in patients with coagulopathy. Major surgeries, again, the patient may need invasive monitoring in the form of CVP or arterial pressure monitoring. So if your patient is coming, and all these monitoring also depends on the preoperative condition of the patient. As I said earlier, if they are CTPA, you may not need to do an invasive monitoring. However, in patients with CTPC, it should definitely be done. Intraoperatively, certain biochemical and hematological monitoring will be also required. Monitoring of blood glucose to watch out for hypoglycemia, electrolytes, hematocrit, calcium. Patients with pulmonary involvement will need ABG monitoring. Cardiac involvement, patients may need a TE. However, the probe should not be placed in patients who have esophageal varices. And coagulopathy is monitored using TEG or thromboelastometry. Neuraxial anesthesia may be given to these patients. However, as I said earlier, we have to keep in mind they can cause hypotension and reduction in hepatic blood flow. And also the hypotension which is produced may be non-responsive to catecholamines, and hence a high neuraxial block should be avoided. The most important thing to keep in mind when placing epidural catheters is the presence of coagulopathy or thrombocytopenia, and it should be avoided in these patients. If the patient has come for a hepatic resection, then there may, even though there may be no coagulopathy in the preoperative period because it might have been corrected, there is a chance of coagulopathy in the postoperative period due to the hepatic resection, and that should be kept in mind. The dose of local anesthesia for blocks in these patients is usually reduced. Postoperatively, patients who are CTP B or C should be managed in the ICU and should be watched for signs of decompensation. As I said, development of any encephalopathy, worsening of jaundice or ascites. For analgesia, epidural catheters to be avoided in case of coagulopathy, especially. Regional analgesia can be given in the form of various blocks. However, one should be careful. There may be hematoma formation in case of coagulopathy. Fentanyl can be continued to be used in the postoperative period in the form of PCAs. NSAIDs are not recommended to avoid deterioration of the kidney function. Acetaminophen, paracetamol can be given up to 2 grams per day, and tramadol can also be used in low doses. Just to briefly complete the topic, some of these patients may come for TIPS, which is a transjugular intrahepatic portosystemic shunt. This may be done in the preoperative period in case patients have massive ascites, variceal hemorrhages, and to reduce the pressure gradient in the portal system. So this shunt is created between the portal vein and the systemic circulation through the liver parenchyma. It is an interventional radiological procedure, and the anesthetist may be called upon for this procedure. One has to be aware that it is contraindicated in patients with cardiac failure, severe TR, moderate to severe pulmonary hypertension or sepsis, and complications include vascular injury, dysrhythmias, hemorrhage, etc. What are the anesthetic concerns in these patients? Obviously, we have to evaluate and optimize them. These procedures are carried out in a radiological suite, so it is a remote location. Access to the patient may be hampered because of the positioning and the placement of the shunt. The procedure can be done either under local anesthesia, sedation, or GA. However, GA, as I said earlier, sedation and GA in severe cases is avoided in case the encephalopathy can get precipitated. However, if the patient is already in encephalopathy or is not able to lie supine or needs airway protection and has a compromised ventilation, general anesthesia may be required in these patients. Last but not the least, cases with cirrhosis and liver failure will present for liver transplantation. That is an entire topic altogether, and the management of these cases Depends on their preoperative condition, obviously, and on the various stages of surgery, the management varies. Basically, it involves management of the hemodynamic system, managing the metabolic and electrolyte function, and any kind of basically managing all these kind of things. And that is the topic that can be covered separately at some other time. Thank you.
Hello.
Sir, you are not audible. So till now, there are no questions, ma'am, in the chat box. I think some network issue is there. And sir is not audible.
Yeah, I cannot hear.
Yeah, so connection has been lost, I think. So it was a very detailed and very nice presentation, ma'am. Thank you so much. So there are no questions. So shall we wait for sir for? So I'll proceed with the first quiz of the day, and I'll just tell the answers. So first question was the paravertebral block is given between. Answer is A, superior costotransverse ligament and the pleura. And for the second question, following statement is correct regarding pec block. Answer is D. The lateral pectoral nerve and the medial pectoral nerve are the main branches of the brachial plexus that innervates pectoral muscles. And the winner for this quiz is Dr. Ayushi Pawan Kumar Singla from Shri Krishna Hospital, Karamsad Medical College, Karamsad. Congratulations, Dr. Ayushi. So I would like to now show the second quiz of the day. First question is, which of the following is not used to calculate MEL score? A, serum bilirubin, B, serum albumin, C, serum creatinine, and D, INR. Second question is, which of the following is a contraindication for liver transplant surgery? A, grade 4 hepatic encephalopathy, B, hepatorenal syndrome, C, hepatopulmonary syndrome, D, severe portopulmonary hypertension. So this is fastest finger first. So whoever answer first and correct, he will get the prize. He or she will get the prize. So let us now proceed for a quick lunch break, and we will be back exactly at 2 o'clock with a very interesting case presentation. So let's take a break, lunch break. Thank you. Welcome back, everyone. So that was due to paucity of time. We gave very short lunch break, but let us now proceed to a very interesting case presentation. For that, external is Dr. Rakesh Garg. He's additional professor in Department of Onco-Anesthesiology and Palliative Medicine, Dr. BRA IRCH, All India Institute of Medical Sciences, New Delhi. And his areas of special interest are onco-anesthesia, airway, research, cancer pain, and palliative medicine. Moderator for this case is Dr. Aditi Suri. She's assistant professor in anesthesia in Department of Anesthesia, ABVIMS, and Dr. RML Hospital, New Delhi. Her areas of special interest are onco-anesthesia, pain, and palliative medicine. The case will be presented by Dr. Nitisha. She's a postgraduate student in ABVIMS and Dr. RML Hospital. Sir, over to you, sir. Welcome, sir.
Thank you so much, Dr. Shivpriya, for this nice introduction. And I was just listening to the last session. I think Appec is doing great. Nice sessions of high quality. So thank you to all the team of your hospital, including Dr. Amrikor and all your team. Congratulations. Let's move to the next session of the obstructive jaundice. I think to begin with, Aditi will agree that this is almost a disclosure of the long case. The obstructive jaundice is definitely a long case in all the exams at all the institutes. So there is no option not to have this case for your case presentation. It will definitely be there as a long case. And I feel that this is one of the simplest case also because the management, the understanding is quite straightforward. So there is not much confusion, though there have been certain updates in the last couple of years. New technologies has infringed into the management, perioperative management of these patients who come with obstructive jaundice, whether they are benign or malignant. But the management is quite crystal clear. But yes, there are so many things to understand. And I'm sure Nitisha will take us forward with the long case. Over to you, Aditi.
Good afternoon, everyone. I would like to thank MD Kaur ma'am for giving me this opportunity. And sir is absolutely right. This is a very important long case. And I think we can go ahead with the case presentation. Nitisha will start her screen sharing, sir. She'll start the case presentation followed by the Viva.
Good afternoon, sir, and good afternoon, everyone. No. A 58-year-old male patient, Mr. Shiv Kumar, who is a driver by occupation, presented with the chief complaint of yellowish discoloration of the eyes and skin since 1 month and generalized itching since 1 month. Patient was apparently well 1 month back when he developed yellowish discoloration of the eyes, which was insidious in onset, gradually progressive, associated with large bulky clay-colored stool, dark color urine, and it was not associated with vaccine and vanning. He also had the chief complaint of generalized itching since 1 month back, which was gradual in onset, progressive in nature, generalized in extent, and disturbs his sleep, and it was relieved on medication. He also gives the history of weight loss of 6 kgs in 3 months and history of loss of appetite since 3 months. No history of nausea and vomiting, abdominal pain, no history of bloating, bletching, or abdominal distension, sensation of fullness following meals, no history of high-grade fever with chills or rigor, no history of coffee ground vomitus, black tarry stools or bleeding from nose, no history of frequent bruising, decreased vision, bone pain, no history of blood transfusion prior to the onset of jaundice, not a non-IV drug user, prone to tattooing, or does not have multiple sexual partners, no history of long-term medication. Past history, not a non-case of diabetes mellitus, hypertension, tuberculosis, COPD, and coronary artery disease. No history of any jaundice in the past. No history of previous surgery with anesthesia exposure. No history of blood transfusion. No history of any drug allergy. Personal history, he gives a history of loss of appetite since 3 months. He is on mixed diet, regular bowel and bladder habits. His sleep is disturbed because of the pruritus. History of smoking 2 BDs per day since 20 years. History of alcohol intake occasionally. No history of any substance abuse. Family history, no significant family history. Treatment history, he is on tablet Udilip 150 mg BD since 1 month. Summary, 58-year-old male with chief complaint of yellowish discoloration of skin, dark colored urine, with history of loss of weight and loss of appetite.
Isha, till now, what do you think? What this gentleman has concerns with? What are your differential diagnosis based on the history and including the previous treatment and other family histories?
As my patient is having yellowish discoloration of skin and generalized itching, which was associated with clay-colored stools and dark-colored urine, and he also gives the history of loss of weight. So mostly towards the obstructive jaundice, it can be because of benign or malignant cause. As my patient is giving a loss of weight, significant weight loss, so it is more pointing towards the malignant etiology.
So how do you classify? You have taken some history from this patient in your history part. One is, what do you mean by significant weight loss? So when you asked to the patient, usually you said there is a weight loss of, you said around 4 kg or 5 kg in last?
6 kg, sir.
6 kg in last couple of months. So when you do, when do you say that this is a significant weight loss in a particular patient?
When a patient is having an unintentional weight loss of more than 10 kg over a duration of 6 months or more than 5% weight loss over a duration of 1 month.
Right, perfect. And you have taken some negative history. Can you just classify that? What is the significance of these history? You said you talked about the appetite, right? And you talked about the nausea, vomiting. You also talked about the pain. So you have taken certain history. You can share your slides. Can you just tell me one point that why that history is significant for you as a part of your perioperative management for these patients? You said bruising, I think, yes, vision you mentioned, your constipation you mentioned. Yeah, same slide. So with each starting from up, weight loss we have said. What do you mean by less of appetite, significance, nausea, significance, pain, significance? And just say me a significance and impact in the perioperative period.
Sir, history of nausea and vomiting, it rules out gallbladder disease. In gallbladder disease, it will be associated with nausea and vomiting, as well as colicky pain will be there. No history of abdominal pain also rules out that. And history of bloating, belching, and abdominal distension and sensation of fullness following meal is also gallbladder diseases. And history of high-grade fever with.
So what does it signify to you as an anesthesiologist? Maybe for surgeons, they want to build it up. So what significance do you have?
Involvement of the gallbladder, sir. If patient is having nausea and vomiting, there will be involvement of the gallbladder, and it can lead to, if there is increased nausea and vomiting, there will be this electrolytemia also.
Okay, so one is, say, distended gallbladder is, it is nothing like a distended bowel. That would lead to the increased chance of nausea, vomiting, or aspiration during the airway management. So distended gallbladder is usually say around 150 or 200 ml, not more than that. So they will not be of much significance as such, but a sequelae is, right? One you said, if you say the vomiting aspect, then probably patient will have risk of aspiration for whatever reasons. What else?
Then, sir, high-grade fever with chills and rigor to rule out cholangitis.
So how does it matter to us?
Sir, if there is associated cholangitis, patient's postoperative morbidity and mortality will increase, and the postoperative outcome is less in this kind of patients.
Anything that you will plan preoperatively to optimize this patient, and any change in the intraoperative period? Whatever we discuss will start from preoperative and then goes to intraoperative and then postoperative.
Sir, if patient is having cholangitis, then associated endotoxemia and chance of sepsis is there. So we have to give antibiotic prior, and in order to decrease the sepsis chance.
Okay, what else? So what is the concern to us? Say surgeon says that this is an emergency surgery. You take it up. Any change in the preoperative assessment, management, planning?
Sir, we'll give like a patient will be having the hemodynamic stability will be less in this kind of patients. So
what type of hemodynamic instability?
Sir, as a patient have sepsis, then it can lead to cardiovascular instability.
Okay, so how will you decide whether it is a localized cholangitis or whether it's a generalized sepsis based on history?
Patient will be having a fever with chills and rigor, sir, and patient BP. Patient will be having
chills and
hypotension.
Chills and rigor are very common phenomena of cholangitis, even if it is localized. So they are one of the very telltale sign of cholangitis in patients who have any obstructive lesion. Even in fact, if they don't have sepsis answer, generalized sepsis answer. So we may not be saying that presence of chills and rigor is an indicator of a generalized sepsis, but yes, we should be looking for the generalized sepsis parameters, right? If you have seen your recent surviving sepsis guidelines, there are certain parameters that you need to look for, whether it is sepsis or sometimes in these patients, they can present acutely with septic shock also. If it ruptures or something happens, the septic shock happens. So these patients sometimes are posted for emergency surgeries, or they are sometimes require critical care support in the preoperative period if in case this sequelae happens. So that is the reason you should just try to identify that whether it's a localized one, probably there will not be a much systemic effect. But if it's a systemic one, you should be cautious that patient may have cardiovascular changes because it's an obstructive jaundice. So it will come a little later what other body systems are affected because of the obstructive jaundice. But then you need to just differentiate between the two. Right. We can move forward. Dr. Aditi, you can add on in between also, whatever you want.
Okay, sir. Nitisha, you can continue with your slide sharing.
So meanwhile, she is sharing class slides for all the students who are attending this. So when you take a history or when you assess your patient in the preoperative anesthetic clinic prior to surgery, and you take a history, you should be able to reach a diagnosis, a differential diagnosis probably. And then when you start subsequent examining them, you should know that you are looking into this direction. Like Nitisha mentioned, we are looking for whether the patient is having jaundice, which type of jaundice, whether it's having localized infection or whether it's generalized infection as a sequelae of the obstruction and its rupture. So you should start from this summary itself of the history part. You should be able to identify that in physical examination, you should be looking for whether it's a bounding pulse or normal resting pulse. So this will differentiate a couple of cardiovascular changes that could happen in patients with such type of liver dysfunction in an obstructive disease. Yeah, yes, Nitisha.
General physical examination. Patient was examined in the sitting position. Patient was alert, conscious, cooperative, oriented to time, person, and place. Patient is sitting comfortably on bed, moderately built and nourished. Height is 165 centimeter. Weight is 51 kg. BMI is 18.7 kilogram per meter square. Sublingual mucosa. Skin is yellowish discoloration. Icterus is present. Cyanosis, clubbing, edema, lymphadenopathy is absent. No spider nevi, palmar erythema, or ecchymosis is present. Scratch mark is present all over the abdomen and peripheries. Vitals. Pulse is 62 beats per minute, regular, normal volume and character. No thickening of vessel wall, felt equally on all peripheral sides. No radial or radiofemoral delay. Blood pressure is 116 per 80 mm of Hg in the right upper arm in sitting position. Respiration is 16 per minute, regular, thoraco-abdominal. Temperature is 98.4 degree Fahrenheit. Neck veins are not encroached and spines are normal. Airway examination, no craniofacial deformities. Both nasal cavities are patent. Inter-incisor distance is 6 centimeter. Teeth, gums, palates are normal. No artificial denture. Malambati grade is 3. Lower jaw can be protruded ahead of the upper incisor. Temporomandibular joint is normal. Thyromental distance is 6.5 centimeter. Sternomental distance is 12 centimeter. No mass or scars. No external neck extension, flexion, and side-to-side movements are normal. On systemic examination, gastrointestinal system is examined. Patient is lying supine with arms to the side. On inspection, normal contour, flat abdomen with inverted umbilicus, and it is centrally placed. Yellowish discoloration of the skin is present and scratch marks are seen. All quadrants are moving normally with respiration. No scar, sinus, and venous engorgement is present. No visible swelling or lump. No pulsation or visible peristaltic waves are visible. Hernial sites are normal. On palpation, on superficial palpation, it felt soft, elastic, temperature is normal, mild tenderness in the epigastrium, and no guarding or rigidity. On deep palpation, liver is just palpable, 2-finger breadth below the right costal margin, and it is non-tender with smooth surface and sharp margin. No fluid thrill, spleen is not palpable, no palpable lymph nodes, hernial sites, no cuff impulse. Percussion, normal tympanic, not all over the abdomen, no shifting dullness. Upper border of the liver dullness at 5th intercostal on right midclavicular line. On auscultation, normal peristaltic sounds audible, no added sounds. CVS examination, on inspection, chest is normal in size, shape, and symmetry. Precordium is normal in shape. Apical impulses not appreciated, no engorgement of superficial veins, and carotid pulsations are visible. On palpation, apex beat present in the 5th intercostal space in mid-clavicular line. No parasternal heat, no appreciable thrill or pulsation in any area. On auscultation, normal S1 and S2 in intensity and character in mitral, aortic, and pulmonary area. Rate is 80 beats per minute, 80 per minute, regular, no missed beats. No pleural rub, no murmur or added sounds. On respiratory examination, on inspection, normal size, shape, symmetry of the chest, trachea is central, respiratory rate is 20 per minute, regular, abdominothoracic, and no accessory muscles are used. No visible dilatation of the veins, swellings, or supraclavicular bulge or hollowing. On palpation, trachea is central, chest circumference is 86 centimeter, normal chest expansion, and no local rise in temperature, no focal tenderness. On auscultation, vesicular breath sounds in all area of auscultation, no added sounds. Percussion, bilateral normal resonant percussion, cardiac borders were demarcated. CNS examination, a patient is conscious, well oriented, no signs of any confusion, lethargy, tremors, or asterixis. Cranial nerves and motor examinations are normal. Sir, my provisional diagnosis, a 58-year-old male with history of painless progressive jaundice associated with loss of weight and appetite, suggestive of obstructive jaundice, most likely of malignant etiology, came for further evaluation and management.
Okay, perfect. So now, based on this history, Nitisha, can you just take us through what all organ system would have been affected in this patient? You said there's a progressive jaundice with many symptom manifestation, which you have mentioned in the history and examination. So can you just summarize me that what could happen in very brief in a patient who presents with this type of symptomatology to other organs?
Sir, as my patient is having an obstructive jaundice, there will be backflow of the biliary salts and other salts, and this can cause to endotoxemia. And another thing is like there will be increased bile salts in the systemic circulation, and this can lead to the in CVS it can lead to bradycardia and negative inotropic effect. And
So
there will be
one is because of the obstruction, the normal metabolic products will not be released through the normal routine excretory route of the biliary tract, and they will be released into the back pressure changes and released into the body system, which they can lead to, you said just mentioned about the something what called systemic endotoxemia. What this endotoxemia will do?
Sir, it will in CVS, it can lead to decrease heart rate and decrease and increase in systemic vascular resistance, and therefore these patients are more prone for cardiovascular collapse.
So this means if you just answer in the exam
in kidney.
Yeah. So when you try to answer in the exam, try to divide them. That this systemic endotoxemia would have effect on multi organs, including the cardiovascular system, including the respiratory system, including the kidney system, based on your priority, and then try to elaborate in that in respiratory. You said just, for example, say in cardiovascular system, there will be changes. So you need to define those changes, whether there is some electrical conduction changes leading to bradycardia in these patients, what happens to the peripheral vascular resistance in these patients because of the toxemia and because of the high bilirubin levels. So you should just separate them and try to answer them one by one so that you're not missing anything. Perfect. So you talked about the cardiovascular system. You were talking about the renal system.
In a renal system, there is because of the endotoxemia, there will be vasoconstriction. This can lead to renal hypoperfusion, and kidney functions can be deranged because of this. And in GIT system, there will be decreased fat soluble absorption,
So
fat soluble vitamin absorption.
So
and
how will, Nitisha, how will it be manifested in patients with renal dysfunction? What will actually happen? What derangement will happen?
Sir, creatinine will increase and urea will be on the higher side.
So why this happens in a patient with the increased amount of bilirubin in the body and also increased amount of antitoxins in the body? Which part is affected, and how much does it lead to something called as acute renal failure in how much patients, and what precautions will you take?
It can cause acute renal failure, sir, and therefore adequate hydration of the patient have to be done, as well as we have to avoid nephrotoxic drugs, and we have to adequate hydration, and the mean arterial pressure have to be maintained throughout.
Okay, so how much is the percentage of these patients with obstructive jaundice, severe obstructive jaundice, they manifest as ARF in pre-operative period or in a peri-operative period, in fact?
Sir, almost 20 to 30% chance.
Almost 15 to 20% will manifest in case if you're not taking care of the hydration and other status. They can land up into acute renal failure, and acute tubular necrosis is another thing which can happen in these patients because of the precipitation of the bilirubin and other biliary salts in them, leading to acute tubular necrosis in these patients, leading to acute renal failure in these patients. And you rightly said that these patients then can manifest with electrolyte imbalance, and hence hydration is required. And this is a preventive strategy before the patients go into acute renal failure. Yeah. Any other organ?
Sir, GIT is also involved. In this, there is a decreased absorption of the fat-soluble vitamins, and especially vitamin K absorption is reduced, and this can lead to coagulopathies. As
so which are the
vitamin K helps in gamma. Yes, sir.
Continue.
Gamma carboxylation is getting affected, and the vitamin K dependent factors are affected, like 2, 7, 9, 10. So this can lead to coagulopathies.
Okay. Any other organ effect?
The immune system is also getting affected, as the liver, if obstructive jaundice is associated with liver dysfunction, this can lead to the dysfunction of the Kupffer cells, and the phagocytosis is also affect. Phagocytic action of the Kupffer cell is decreased, and the endotoxemia itself will cause T cell function derangement, as well as the neutrophilic action is also decreased. All this can lead to decreased immune immunity in a patient.
Very
And
good.
post-operative.
So this means when you make a provisional diagnosis and you reach a diagnosis that it appears to be an obstructive jaundice, probably a malignancy underlying, not appears to be a benign condition, then again you should just review it, that which are those conditions, clinical conditions that can affect your perioperative period. So what we have discussed, just to summarize what Nitisha has very nicely summarized it, that we need to look for the cardiovascular changes. There could be some effect on the electrical rhythms. There could be some effect on the peripheral vascular resistance, and hence the fluid status needs to be maintained. There could be some issues with the renal function leading to electrolyte imbalance, and hence needs to be monitored on history examination and subsequently on investigations. You should also be looking for the renal functions clinically, whether you may ask that whether the patient, just not the color of the urine, but you also need to ask whether, in spite of the normal hydration, whether there has been some change, recent change in the decrease in the urinary output. And that becomes very important, that this patient may be in a situation of pre-renal failure, and hence you need to be very aggressively hydrating them. As you rightly said, these patients are immunomodulated because of the various changes that happens because of hepatic dysfunction. And hence, whatever you do with the patient, all aseptic condition needs to be followed, even as simple as putting up IV cannula. Also, when we talk, these patients could have coagulopathy. So you should be looking for various signs and symptoms suggestive of coagulopathy, like skin changes, for example, say any blood in the urine or in the stool. So you should be looking for those things. And then you can have probable idea that probably when you say a risk stratification of these patients for the, that is the ASA physical status, accordingly you can decide that. Now, based on this, what all investigations, Nitisha, you will require preoperatively for these patients?
Sir, I will ask for complete blood count, which includes a hemoglobin, total leukocytic count, and platelet count. I'll ask for liver function test, which includes total bilirubin level, direct and indirect, and AST and ALT and ALP. And I'll ask for total protein and serum albumin level. Then I will ask for kidney function test, urea and creatinine. And I will ask for a coagulation profile, PT-INR, for these patients.
Okay. So can you just tell me the significance of each test that you mentioned, starting from the hemogram? And what abnormality could be expected in such a patient which you presented?
Sir, hemoglobin, there can be a chance of anemia in this patient. As this patient is having a as my patient will be in a malnutrition because of decreased absorption of the fat soluble vitamins, as well as the cancer itself is a condition which can lead to malnutrition, and the endotoxemia related hypersplenism. All these factors can lead to an anemic condition. And total leukocytic count I can, if there is an increased total leukocytic count, it points towards the cholangitis and associated infection. And the platelet count also can be decreased associated with the hypersplenism.
What happens to the bilirubin? Suppose you said this in obstructive jaundice. If there is some cholestatic jaundice, so how will you differentiate between different types of jaundice based on the level of various bilirubins?
Sir, in obstructive jaundice, the total, the conjugated bilirubin will be on the higher side, and in prehepatic causes, unconjugated bilirubin will be on the higher side. Then in obstructive jaundice, alkaline phosphatase will be markedly elevated compared to that of the hepatic causes. Right. Then the serum albumin levels will be lower in case of cholestatic jaundice, as well as the total protein level. Then another test like gamma glutamyl transaminase and 5' nucleotidase also increases in case of cholestatic jaundice.
Perfect. I think you summarized it nicely. So when you are looking for the LFT in these patients, we should look for that, which are the features which are suggestive of the various abnormalities in LFT, whether you are talking about the transaminases, we are talking about the bilirubin levels, direct, indirect levels, and also you are talking about the impact of the various metabolic and synthetic functions of the liver. And when we say synthetic, you are looking for the albumin levels, which may be lower. Metabolic, you are talking about the endotoxemia. So this will give you an overall clue how to manage these patients perioperatively. Can you show the investigation for this patient if you have?
Yes, sir. So these are the investigations. Hemoglobin 10.4, total count 9,400, and differential count 71, 24, 0, 2 and 3, and platelet count 1.93, and peripheral smear is normal, and PTNR is 13.5 and 1.19, and random blood sugar is 96, urea is 15, creatinine is 0.6, sodium is 134, and potassium is 4.4. And total bilirubin level is 8.6 with direct bilirubin of 5.3, indirect bilirubin is 3.3, and albumin is 2.8, and AST is elevated 80, and ALT is 92, alkaline phosphatase is 586.
All right. So you have already highlighted the abnormal investigations in these, and it will always be good when you speak in the exam, the unit should also be there. Whether you're talking about the milligram percent or you're talking about gram per deciliters. So it's always good that if you say it's albumin, you should always look for, what's the unit of albumin?
Sir, gram per DL.
Okay. So you should be mentioning all your records in exams. The units also, that's always very good. The unit of AST?
Sir, international unit.
Okay. Right. So will you like to see some imaging also? You said it's a malignant obstructive jaundice. So as an anesthesiologist, do you look for the imaging in these patients? Ultrasound is already there. So will you like to look for anything else? Any other imaging that you like to review?
Sir, CT scan also I would like to see.
Which type of CT scan is done for these patients? MCCT, CCT?
Sir,
no, there is nothing called normal CT, right? Either it is contrast enhanced CT or it is
contrast enhanced CT, sir.
What do you look for in this?
Sir, invasion of the tumor, whether it has been inverted to any other retroperitoneal or peritoneal extension, or how much extension it has been there. So from that.
Suppose this patient has come to you now, you have all the investigation with albumin of 2.8 gram per deciliter. So what do you think? Does the level of albumin preoperatively affect the perioperative care? If yes, how? And what are the evidence?
Sir, a decrease in albumin itself is and it is an indicator of postoperative outcomes, sir. If it is less than 3, then the free fraction drug, the drugs which we are giving, will be more, and the patient's nutrition status is poor. It is a synthetic function. Albumin is a predictor of a synthetic function of the liver. So all these point towards a poor postoperative outcomes.
So can you tell me a couple of important points that are albumin level of 2.8, which is much lower than normal level, how your anesthetic management will change? With regards to drug, the dose, the fluid, can you just tell me in brief?
Yes, sir. The albumin binding drugs like propofol, thiopentone, all these have increased free fraction when there is decrease in albumin count. So, so the toxicity can be more, and in this case, there will be increased volume of distribution also. So the action of these drugs can be prolonged also.
Right. So this means there are two aspects. One is when we talk about these investigations, we talk about various functions of the liver which are affected, metabolic versus synthetic. Both can have effect on our perioperative management, which Nitisha rightly mentioned that when we talk about albumin, many of the drugs are protein bound to a certain extent. So you should be aware of that, which drug is attached to which type of protein at what percentages. And hence the requirement of these drugs will go down. And moreover, the presence of, if the protein is low, the presence of free drugs are more, so the metabolism will also be enhanced, but the liver dysfunction is already there. So you should also be aware of that the drugs are metabolized as which component, right? Whether they are excreted, metabolized something in the blood, or they are metabolized into the liver and then excreted into the bile, or they are released from the kidneys. So this becomes important in these type of cases. The second thing, which probably maybe we don't have much time, we're not discussing it, but we discuss in brief that when you are looking for these patients, you should be very clear at what type of jaundice these patients have, whether the pre-hepatic jaundice or a stasis type of jaundice or an obstructive type jaundice, because the body changes will be little different in three. So you should, there is a nice table, I remember correctly, in Miller and other books. This is a very common thing. Even in Harrison, it is very nicely mentioned. Even in surgical book, it's nicely mentioned. So you can see from any of these books, the differences from the presentation, examination, and investigation in various type of jaundice and how the bilirubin, sometimes it comes as a long question, how the bilirubin metabolism happens and the excretion of various things happen. So that again is a question that you need to look for. Okay. So next question will be, Nitisha, for you, that this patient comes to you, he is posted for the PSC clinic, is posted for Whipple's procedure. So how will you try to optimize this patient before the surgical procedure?
Sir, I will ask the patient, I will rehabilitate the patient, sir, as this patient, and I will try to improve the nutritional status of the patient. And if there is any coagulation abnormality, I would like to optimize that also, sir. And and as my patient is giving smoking history, then I ask him to stop the smoking also, sir. Cessation of smoking.
Okay. So suppose surgery is tomorrow and patients, you say that stop smoking today. So what are the plus point and what are the minus point? Though it's not a respiratory case, so I'll not go into much detail. Just if you stop smoking 12 to 24 hours prior to surgery, what are the benefits and what is the disadvantage?
Sir, the nicotinin level will be decreased and the carboxyhemoglobin will be decreased in 12 hours. So the adverse effect of because of this can be decreased. And but the disadvantage is like mucociliary action will be decreased, and the increased secretion. The secretions will also be there. As
mucociliary actions will not decrease, they already decreased. It will take some time to recover. So maybe in 24 hours they will not be recovered back. Okay.
Okay.
Okay, I thought it's a Whipple surgery, so sir will not ask about the respiratory status. So this is a clue for the examiner. For the students, sometimes when you speak something, examiner can take you to the other case also. So be prepared for it. So don't be so focused that the viva will go into only obstructive jaundice with Whipple's procedure. Because next question would be, what is the hepatorenal syndrome, hepatopulmonary syndrome, and then we can go to the pulmonary. And you said stop smoking in the rehabilitation. So you should be clear that when you answer this question, it should be clear that when you stop smoking, what are the immediate effects which are corrected in 24 hours, which takes couple of days, couple of weeks, and couple of months. So there is a nice table. I must say that you must have read it in some of the respiratory book. So you should be aware of the recovery of the body functions once the smoking is stopped. You started with carboxyhemoglobin, perfectly right, but the other things can also happen. So be cautious. Your viva can be driven to the other aspect. If you try to take the examiner to some other system, it's fine. So next question is, what do you mean by hepatopulmonary syndrome, by the way?
Sir, because hepatopulmonary syndrome is mainly because of the pulmonary arteriolar dilatation. This can lead to decrease in the partial pressure of the oxygen in patient, and the patient will be complaining of the dyspnea because of the decrease in partial pressure of the oxygen. It is
okay.
Because
okay, fine. So I think everybody should be knowing about two syndromes which are very, very common: hepatorenal and hepatopulmonary syndrome, which has a good amount of implications in the perioperative care, because these patients can have chances of hypoxemia because of this syndrome intraoperatively. And also these patients can go into acute renal failure, which we have discussed earlier, and hence you should be clear about what is the mechanism, what are the risk factors that can precipitate or elicit this syndrome or this response, and how to manage it, right? So you said about something about the hydration. You said you preoperatively you will keep hydration so that the acute renal failure will not happen. So can you just tell me what's the role of drugs like mannitol or low dose dopamine? Should we start them so that good renal output, good urine output, less chances of acute tubular necrosis, and hence less chances of acute renal failure?
Sir, in previous studies, it was like mannitol can be used in order to maintain the urine output of 0.5 to 0.5 to 1 ml per kg per hour. But now in the newer studies, it is like there is no difference in using mannitol, and only thing is like we have to maintain the mean arterial pressure and adequate hydration for the patient to avoid the pre-renal injury.
What are the strategies that you will try to bring down the bilirubin to these to low levels in these patients preoperatively?
Sir, adequate hydration. So, like kidney can
Anything
excrete
else?
out.
So one is the hydration, no doubt. One is the good hydration so that kidneys are flushed. Probably ATM will not happen. But anything else that probably will try to bring the level of bilirubin, probably the direct bilirubin a little lower. You do some procedure preoperatively nowadays. I mean, not nowadays, for so many years now.
Sir, biliary drainage.
Good. So what are the options for biliary drainage? What they do?
Sir, endoscopic biliary drainage they can do, or percutaneous biliary drainage. But endoscopic biliary drainage is prepared over percutaneous.
Okay, so this patient was very restless. So they were doing endoscopic procedure for a biliary drainage, something called ERCP or MRCP, whatever you say. So they were doing ERCP and the patient was restless. They called you to give some sedation.
Yes.
How will you provide sedation to this patient? Same patient.
Sir, as this is like for sedation, I'll give injection midazolam and injection
How much?
fentanyl.
How much?
Injection,
You said I think the patient was around 50 kg, if I remember correctly.
Yes, sir.
Yeah. How much midazolam?
I'll give 1 to 2 mg, sir.
Patient is not sedated. What to do next?
Sir, I'll go for injection fentanyl, 2 mics per kg.
2 mics per kg.
100.
Okay.
1.5. As there in this patient, there is decreased fentanyl requirement is there, so I can give like 1 to 2 mics, 1.5 mics per kg.
Nice. You said 3 drugs, 1 to 2 mics and then 1.5. You tell me one dose ना आप कितना दोगे? 50 kg का patient है. Be specific. आपको देना है. You are only an anesthesiologist.
Sir, 75 mics.
75 micrograms. Okay. Patient has respiratory obstruction now. What will you do?
Sir, I'll intubate the patient, sir.
You will intubate the patient. Okay. Anything else you can do for this? So I just brought this scenario into your case discussion because patients of obstructive jaundice are kept for these type of procedures where you need to require them outside the operating room sedation for these patients, right? So I think I may not be able to take you much in detail about it, but all the students should be remembering that when you provide sedation to these patients, there are a couple of things that needs to be remembered. There's nothing called fixed dose. They require a variable amount of dose. You should be aware of when to give fentanyl, when to give midazolam. And now we have a newer drug, dexmedetomidine, how to give it and titrate it, right? So there's something called titration because there's nothing called a fixed dose in these patients. Also, you should be properly available with all the airway management gadgets. And now we have available of second generation devices, second generation supraglottic airway devices, which can also be used in these patients through which you can do endoscopic procedures like this, right? So if a patient is absolutely non-cooperative or a high risk or gets into obstruction, you can use those supraglottic airway devices also for managing the case. Can you just tell me 5 prehabilitation strategies that you will use for this patient? One, you said stop smoking. Second, you said good hydration.
Yes, sir.
Another 3.
Sir, nutrition. I'll provide good nutrition.
Very
with
good. What else?
protein rich diet.
Right. Okay. What else?
Then exercise training, sir.
Which type of exercise training?
Sir, aerobic exercise. Several programs are there for sir, to improve the functional capacity of the patient.
Which type of aerobic program?
Sir, CPET and 6-minute walk test and all can be.
Anything simpler. CPET तो सब जगह नहीं होगा और CPET aerobic वाली कंपोजिशन में नहीं आता, वो दूसरा होता है, वो कैटेगरी दूसरा है. So anything else? So let's see, you can do training exercises, but it's okay. Anything which should be routinely done? By the way, what is the full form of CPET?
Cardiopulmonary exercise testing, sir.
So what does it assess?
It assesses the aerobic capacity of the patient, sir.
Can you name me 5 important parameters that it gives some certain value to you, which are used for making some diagnosis with regards to cardiorespiratory disease of this patient? 5 important parameters that are on the reports of CPET.
Sir,
with full form and short form.
Sir, I don't know regarding.
Right. So try to avoid speaking CPET for training exercises because we are using it more for assessment purpose rather than training. But yes, you're right. We can use it for training. Perfectly. Okay. Any other exercise? Any other thing as a part of rehabilitation? Upper abdominal surgery. Do
Sir,
something.
incentive spirometry.
Good. Very good. Incentive spirometry. What else? Okay, in which ASA physical status will you put this patient now? Now we are proceeding for surgery.
Sir, ASA 3.
Can you just enumerate me that what will be your PAC orders? The patient is posted for surgery tomorrow at 8 a.m., right? And you are supposed to put PAC orders after this viva. So what will be your PAC orders? Just write, just speak whatever you want to write. Speak 1, 2, 3, 4, 5.
Sir, NPO status, NPO for 6 hours for solid and 2 hours for liquids. Then written informed consent to be obtained. Then post-op blood cross-matching and blood product, arranging of blood products. Then low molecular weight thromboprophylaxis can be given. Then tablet alprazolam 0.25 mg IV and tablet pantoprazole and tablet metoclopramide prior to surgery.
Why do you want to give alprazolam and pyrinom for this patient? Metoclopramide, not pyrinom. Okay. Why alprazolam and metoclopramide for this patient?
Sir, to decrease the anxiety, tablet alprazolam.
Does your patient have anxiety?
Sir, first I'll be explaining the patient, and even after that, patient is having anxiety, then I'll go for tablet alprazolam.
So you tell me 2 advantages of giving alprazolam and 2 disadvantages of giving alprazolam in elderly population or in any population. Why this is not the routine drug nowadays?
Sir, tablet alprazolam can cause respiratory depression, sir. So under proper monitoring.
Because the dose that you give 0.25 milligram or 0.5 milligram is not going to give a respiratory depression. Anything more significant, that's why the use of benzodiazepines preoperatively has been stopped as a routine. 10 years back, yes, it was a routine that all patients used to receive diazepam or alprazolam, or then subsequently even midazolam tablets were available, so they were also being given. But now if you see, you were talking about the recent literature and your guidelines, so I could ask you that why midazolam or any other benzodiazepines are not a routine pre-medicant for patients now? Especially like this patient who requires an extensive surgery, or a patient with patients who are elderly population.
Sir, sedation.
Sedation तो आप बहुत कम डोज देंगे ना नितिशा, तो sedation तो नहीं होगा इतना 0.5, 0.25 you can always give low dose in case high risk population. Okay, so I'll not take you much time. So there's something called delirium, which is a common phenomena, and delirium is one of the factors that can affect the morbidity of the patient postoperatively, especially elderly population, especially patients like this, and hence routine administration of benzodiazepines as a part of pre-medication a night before or morning of surgery is not suggested as a routine in all patients. Only those patients who, in spite of proper counseling and reassurance, still they have anxiety, then only you can give them some amount of these agents. Okay, so what would be your plan of anesthesia for this patient?
Sir, balanced general anesthesia with a endotracheal tube with controlled mechanical ventilation with mid-thoracic epidural, sir.
Okay, so how will you induce this patient? Induce the anesthesia for this patient?
Sir?
Your induction drugs, induction technique.
Okay. Sir, I'll pre-oxygenate the patient, and after that I'll give injection midazolam 1 mg. Then I'll give injection fentanyl 75 mics slowly, and after that I'll give graded dose of propofol 2 mg per kg, and after check ventilation I will give injection atracurium 0.5 mics per 0.5 mg per kg, and after that I'll intubate the patient with cuffed endotracheal tube, and I'll confirm the tube by auscultation and
right. So I think because I think time is not too much, but it should be clear that we have various induction agents, specifically like thiopentone, propofol, ketamine, and etomidate. There are 4 agents. So you should be very cautious that what happens to each agents in patients with obstructive jaundice, and what happens to the induction time, whether it is slow in patients or whether it is increased, and what precautions you should take. So you should be aware of those things. And also you should be aware of, she said about the pre-oxygenation. So there have been a lot of recent concepts in changes of the pre-oxygenation. People are using the word oxygenation and high flows. So probably we may not go into detail, but for the students, it is important that the oxygenating technique should be appropriate as per the recent changes in the guidelines. Okay. So what all monitors will you use for this patient?
Sir, I'll use ECG, non-invasive BP, and pulse oximetry, and central venous pressure monitoring, and urine output, temperature monitoring, temperature and urine output.
Okay,
and,
perfect. Good thing. So you mentioned about something about central venous pressure. So what is the indication, advantage, and limitation of using CVP lines in these type of surgical procedures, hepatic surgeries?
Sir, advantage is like CVP trends can be, it can be used for inotropic support if in-drop requirement is there. Then it can be used, CVP trends can be used for fluid therapy. Then disadvantage is like.
Do you think CVP guided fluid is a good option nowadays, and specifically in liver surgeries, malignant obstructive jaundice, probably where they will require some amount of liver resection? So do you think CVP is an appropriate guide for fluid replacement?
It is not an appropriate guide, sir, but it can help you out if the CVP, we can look the CVP trends.
So you have everything into your operating room. So can you tell me some monitor which is better than this, and or what all monitoring will you use that will guide you for fluid management in such type of patients?
Sir, pulse pressure variation I can see.
Okay, very good. What else? Then, one is pulse pressure variation, PPV. What else?
Then stroke volume variation.
Okay, stroke volume variation, SVV. So these are the good options. What other things will you look for good perfusion of the patient? as a part of your fluid management?
Sir, urine output.
Urine output, very good. Right. So we'll look for these agents. Probably the pulse contour analysis monitors are one of the acceptable monitors in these type of major surgical procedures for fluid management. CVP may not be a good option. Even the trends may not be a good option because they are handing near the liver. They do a lot of retraction there, and CVP will fluctuate. So may not be a good option. But yes, you can use it for giving some inotropes or vasopressors if required in these patients that are part of your monitoring. So I will just, I think Dr. Aditi wants to summarize. Just last question for you before Dr. Aditi takes over. What will be your technique of post-operative pain management in this patient?
Sir, epidural analgesia.
Epidural analgesia is a broader term. So when we ask a single case, you should be very clear that I will give epidural using ropivacaine 0.125% as a continuous infusion as a 6-hourly bolus. So when question is asked in the exam, be specific because this was a long case, right? So be specific for this particular patient, right? You should say, for this patient, I will start an infusion of ropivacaine with fentanyl, 0.125% ropivacaine with 2 mics per ml fentanyl as giving 4 ml of bolus followed by 4 to 5 ml of infusion for this patient. So be very specific. What else apart from epidural?
Apart from then local infiltration, as well as a tab block can also be given for this patient.
I am talking for this patient. Will you give everything? Epidural, tab block, local infiltration? No, for this patient.
Sir. These are the options.
I'm talking for this. I'm talking for this patient only. This is a long case.
Okay, sir. Then post-op opioids.
So in exam, when you speak, I think this is an important message which Nitisha has prompted me to speak. When you speak in exam for a long case, first of all, you say for this patient, my anesthetic technique is this, right? I will give the patient 1 microgram, or you will say specifically, suppose it's 50 kg, I will give 100 micrograms of fentanyl, followed by titrated dose of propofol, followed by say 30 milligram of atracurium, and then I will ventilate using. So you should be specific for a particular case when you talk about the long case. Similarly, whatever the questioner asks, you should look into the context of this case. So your management should be there. So I'll be using epidural analgesia using this modality. In addition, I will add, say, paracetamol. I will add, say, diclofenac to this patient. Yes or no? Will you add diclofenac to this patient, by the way, Nitisha?
No, sir.
Right?
I will not because there is chance of kidney dysfunction, sir. So
okay, very good. So this patient, because this patient has a high risk for renal damage, so be cautious about not using NSAIDs in this patient for anesthesia management. So this was in brief. So for students, I think let first Aditi, Dr. Aditi has made, she will guide us the summary for the day. So I will request Dr. Aditi to just brief us if you have missed something and she wants to add certain aspects. Over to you.
Thank you so much, sir, for this enlightening and extensive case presentation. I would like to share my screen now. Nitisha, if you would put down your screen, I'll start it. Thank you. Good afternoon, everyone. I'll just be briefly summarizing the topic of obstructive jaundice and anesthesia for Whipple surgery. The functions of liver can be categorized as metabolic functions that include protein, carbohydrate, lipid, and heme bilirubin metabolism, as well as metabolism of drugs. Among the synthetic factors include synthesis of albumin, clotting factors, and function of liver in the coagulation cascade, its antibacterial action, and its function as a blood reservoir. Now we know that the hepatic blood supply constitutes 25 to 30% of the cardiac output, and blood flow to the liver is composed of 25% of it is composed by hepatic artery, while 70 to 75% is composed by the portal vein. Now the liver function tests can be classified based upon the test assessing excretory capacity of the liver. For example, the serum bilirubin, urine bilirubin, urobilinogen, the test assessing injury to hepatocytes like aminotransferases, those assessing level of cholestasis, that is alkaline phosphatase, GGT, and 5' nucleotidase, test assessing the biosynthetic capacity like albumin, prothrombin time, alpha fetoprotein, and ceruloplasmin. Now, jaundice, as we know, can be broadly classified into pre-hepatic, hepatic, and post-hepatic causes. Now, the pre-hepatic causes include the presence of excess amount of bilirubin being presented to the liver due to excessive hemolysis. This is seen in hemolytic anemias, and here unconjugated bilirubin is mainly raised in the serum. Next comes a hepatic jaundice, where there is an impaired cellular uptake, defective conjugation, or an abnormal secretion of bilirubin by the liver cells. So here we find both conjugated and unconjugated bilirubin to be raised. This is seen in hepatitis, cirrhosis, Gilbert syndrome, Crigler-Najjar syndrome, etc. Post-hepatic jaundice is of our concern today, and this is associated with impaired excretion of bilirubin due to mechanical obstruction to the bile flow. So herein there we'll see an elevated level of conjugated bilirubin mainly, for example, as a result of gallstones, inflammation, and malignancies. So in hemolytic jaundice, as I said, we see mainly unconjugated bilirubin to be raised. Urobilinogen and stercobilin both are increased, while alkaline phosphatase and prothrombin both are seen to be normal. In hepatocellular jaundice, there may be a biphasic increase of both conjugated and unconjugated bilirubin. So depending on that, the urobilinogen may be either increased or decreased, and stercobilin is usually decreased. Both alkaline phosphatase and prothrombin time are prolonged, and to be noted is that prothrombin time in this case is not corrected by IV administration of vitamin K. Obstructive jaundice is associated with an increased levels of mainly conjugated bilirubin. Urobilinogen is absent, stercobilin will be decreased, and again, both ALP and prothrombin time will be raised. But in this case, the prothrombin time can be corrected by IV administration of vitamin K. Now, the causes of obstructive jaundice or cholestatic jaundice can be broadly classified as intrahepatic or extrahepatic. Intrahepatic causes may be either familial or hereditary, like Dubin-Johnson, Roter's cholestasis of pregnancy, or acquired, like alcoholic or drug-induced hepatitis, primary biliary cirrhosis, or primary sclerosing cholangitis, etc. Extrahepatic causes may be either benign or malignant. Benign like choledocholithiasis, chronic pancreatitis, strictures, and malignancies like cholangiocarcinoma, pancreatic, gallbladder, or ampullary malignancies may cause extrahepatic type of jaundice. Certain drugs are also can also be implicated in causing cholestasis, like anabolic steroids, estrogen, tamoxifen, erythromycin, azathioprine, to name a few. Now, there are various adverse effects on different organ systems, as we discussed in our case presentation. I'll briefly go through them again. The effects on cardiovascular system occurs because of the circulating bile salts. That leads to a negative inotropic and chronotropic effect. There is an impaired response to beta agonist drugs, and there is a decreased peripheral vascular resistance. This leads to what is popularly known as the bilirubin bradycardia or a jaundiced heart. So we have before us a hypotensive patient who is prone for cardiovascular collapse at induction. There is exaggerated hypotension response to bleeding, and these patients are prone to perioperative shock. Therefore, it is important to replace volume losses immediately. The effect on renal system occurs mainly because of the circulating bile salts, endotoxins, and inflammatory mediators. So the patient already has hypotension due to decreased cardiac function, and there is a refractoriness of renal tubules to ADH. The net result is that there is renal vasoconstriction, hypoperfusion, as well as activation of complement system, causing renal tubular and cortical necrosis. The immune system too is adversely affected, wherein there is a decreased function of reticuloendothelial system, that is Kapha cells. There is impaired T cell proliferation, impaired neutrophil chemotaxis, and a defective bacterial phagocytosis. This results in presence of cholangitis and escape of endotoxins from intestine into the portal blood and ultimately to the systemic circulation. The coagulation is deranged because of decreased synthesis of clotting factors and leading to a prolonged prothrombin time. There's a deficiency of vitamin K as well as other vitamin K dependent clotting factors, fat soluble vitamins, and there is presence of hypersplenism leading to thrombocytopenia. There's endotoxemia, which will lead to increased fibrinolysis, and a low-grade BIC may be present. Wound healing is delayed, and these patients pose a high risk of wound dehiscence in the post-operative period. There is also a defective synthesis of collagen. Now, the surgical resection for a periampullary malignancy, like in our case, includes the Whipple's procedure, which involves removal of the cancerous part of pancreas, duodenum, CBD, gallbladder, and distal stomach. And the anastomosis performed are pancreaticojejunostomy, gastrojejunostomy, and hepaticojejunostomy. So this pancreaticoduodenectomy procedure may either be a pylorus preserving pancreaticoduodenectomy or pylorus resecting pancreaticoduodenectomy. The concerns before an anesthesiologist are mainly due to, firstly, the liver dysfunction. These include presence of hypoproteinemia and reduced level of drug binding proteins. There is altered volume of distribution. There is presence of coagulopathy, altered drug metabolism and clearance, hypoglycemia, and electrolyte imbalance may be present. There may be anemia, leukopenia, and thrombocytopenia, and deficiency of fat-soluble vitamins. The concerns due to surgery include the fact that this is a major surgery. It's a long duration surgery associated with increased blood losses and fluid shifts. And the incision, which is an extensive incision called the rooftop incision, requires excellent postoperative analgesia. Now, the preoperative assessment and optimization of these patients begins with a detailed informed patient consent, considering that this is a procedure associated with high morbidity and mortality and increased risk of postoperative complications. So the patient may be included into a structured rehabilitation program, which includes adequate preoperative counseling and anxiolysis, assessment of nutritional status, and optimization, especially for patients who have a BMI of less than 18.5 and weight loss of more than 15%. Optimization of cardiac and pulmonary comorbidities, correction of coagulopathy and optimization of medications, cessation of smoking and alcohol consumption. Risk assessment can also be done, and stratification of risk can be performed using validated scores like POSSUM and Child-Pugh score. Now, studies have also shown that an age of more than 60 years, albumin level of less than 3 gram%, pre-existing preoperative renal dysfunction, and long-standing biliary obstruction leading to sepsis, as well as presence of significant weight loss, puts the patient at high risk of cardiovascular collapse and renal failure. So we know that this is the Child-Pugh score, which takes into account various parameters like encephalopathy, ascites, bilirubin, and albumin, as well as prothrombin time. The points will add up to categorize the patient into one of the 3 classes of A, B, and C. And these are associated with a mortality rate of 10, 30, and 80% respectively after a major abdominal surgery. Now, the perioperative care of these patients undergoing pancreaticoduodenectomy can be discussed under the heading of ERA's guidelines. The intraoperative plan includes a combined general and epidural anesthesia. We know that it is associated with decreased sympathetic activity and excellent pain relief, decreased postoperative pulmonary complications, decreased cardiac metabolic demands, and decreased risk of thromboembolic complications. Surgical site infections may be prevented by administering antimicrobial prophylaxis 30 to 60 minutes before skin incision. Skin preparation would be done by alcohol-based preparations, and normothermia as well as normoglycemia must be maintained throughout the entire intraoperative period. Patients may be induced with propofol, which increases the total hepatic blood flow due to splanchnic vasodilatation, and it would be wise to give a slow and titrated dose to avoid sudden hypotension. Anesthesia can be maintained using neuromuscular blocking agent like atracurium or cisatracurium, which is not dependent on liver for its metabolism or excretion. And inhalation agents like sevoflurane or isoflurane may be used, which are known to increase the hepatic arterial buffer response, which are known to Sevoflurane is known to preserve the hepatic arterial buffer response, and both of these increase the hepatic arterial blood flow. Lung protective ventilation strategies can be instituted, like administering a tidal volume of 6 to 8 ml per kg, PEEP of 5 to 10 ml per centimeters of water in order to prevent atelectasis, and administering recruitment maneuvers. Thromboprophylaxis is mandatory, which may be either mechanical or pharmacoprophylaxis. Mechanical prophylaxis in the form of compression stockings, pneumatic compression devices may be given, and low molecular weight heparin can also be started 2 to 12 hours prior to surgery. Now, intraoperative fluid management needs to be meticulous, and care must be taken to replace fluid deficits, blood loss, and third space fluid losses adequately. The recommended approach is to follow a goal-directed fluid therapy, and a balanced use of fluids, vasopressors, and inotropes is recommended. Coagulopathy can be tackled using preoperative administration of vitamin K. And it is important to avoid hypothermia at all times because it is known to worsen coagulopathy. Now, these patients may be managed post-operatively in an ICU or in an HDU. Considering that all of these are high-risk patients, they may be elderly and they have just undergone a major abdominal surgery. An extended hemodynamic monitoring may be continued in an ICU, and so could invasive or non-invasive ventilation. Pain relief, as we discussed, is extremely important for good post-operative outcome. So this can be done by using a thoracic epidural, and wherein you may administer local anesthetics or epidural opioids. A continuous IV fentanyl or a patient-controlled IV fentanyl may be given. Wound catheters with local anesthetic, as well as tab block or other options. So it is recommended to conduct an early ambulation for these patients in the post-operative period. So good pain relief would allow us to ambulate the patient early, as well as low molecular weight thromboprophylaxis, which can be continued well into the post-operative period with something called as the extended thromboprophylaxis, which means continuing the thromboprophylaxis for almost a month in the post-operative period. Respiratory rehabilitation can be performed using chest physiotherapy, incentive spirometry, and deep breathing exercises. And it is recommended that for perianastomotic drainage, the drains, the nasogastric tubes, and urinary catheters be removed early into the post-op period. Lastly, the take-home message is that obstructive jaundice is associated with multisystemic adverse consequences, and pancreaticoduodenectomy is a major abdominal surgery with high risk of morbidity and mortality, and therefore requires a meticulous anesthetist approach. So these are my references. You can go through these. Thank you all.
Thank you, Dr. Aditi. Do we have some questions also from the chat box, or do you want us to take a few more questions that will be useful to students as a part of long case?
So we can go through the questions if there are any in the chat box, I guess.
There are no questions. As of now, no questions are there.
Okay. So I think Aditi has covered it very nicely. The whatever things we said, it was a homework for the other students. So she has covered almost all aspects of it. On a couple of things that we should be cautious in these patients. Like for this patient who are malignant disease, and sometimes these patients could become inoperable intraoperatively. So this is the other question the examiner can ask if they open up the, that's why I asked about the imaging, and if they become inoperable. So I will come back to Nitisha. I can take advantage with the permission of Dr. Shivpriya. Another 5 minutes?
Sure, sir. It's our pleasure, sir. Please.
Right. Nitisha, suppose this patient becomes inoperable. Whipple's procedure could not be done, right? And patient is shifted to the post-operative ward after extubation. So what will you do with the patient now? Any counseling, anything that you will be required for the patient management, any things that you will inform him or her before the discharge?
Sir, I would like to counsel the patient regarding the complication as well as regarding maintaining the nutritional status also. I would like to ask him to take protein-rich food, then continue the exercises, then
Very good.
And
what else? This patient is inoperable. So what do you think how the patient
I
journey will be now onwards?
Sir, I can't hear you.
The patient is inoperable. So what do you think? Am I audible?
Yes, sir. Yes, sir.
So patient is inoperable. So you're absolutely right. You will counsel the patient, reassure, nutrition. You will help that continue doing exercises, whatever, so that you feel good. What else will you do for the patient?
Sir, if possible, if the bilirubin counts are raising, then we can go for biliary drainage also as per.
But that you have already done, madam. वो तो आपने प्री ऑपरेटिवली कर दिया था उसका, तो आप दोबारा ड्रेनेज कैसे करेंगे आप? वो तो इनऑपरेबल निकल गया.
Then chemotherapy.
चलो, okay, we'll refer to the medical oncologist for treatment. But जब आप डिस्चार्ज कर रहे थे उसको, क्योंकि आपने इतने अच्छे से एनाल्जेसिया दिया 3-4 दिन के अंदर, जब आपने 4th day 5th day डिस्चार्ज करे थे तो आपने उसको एपिडुरल कैथेटर निकाल दिया था, isn't it? You will remove it before procedure. Now patient says that he having a pain score of NRS of 7 on 10. What will you do?
Sir, pain.
On discharge on 5th day, the patient is having a pain score of 7 on 10. What will you do?
I will continue.
For how long will you continue epidural?
Sir, I can give this morphine tablets.
Very good, very good.
Then
for how long?
Sir, like 1 month to 2 months tak we can give, sir.
उसके बाद?
Sir,
okay, so this is one scenario. The patient is inoperable, right? So inoperable hoga to refer to the palliative care physicians, and there are many pain physicians at your center also. You can refer to them. They will take care of the pain management. So this patient inoperable will have pain. Okay. Second option is you did a nice surgery, and on 4th day of the surgery, this patient suddenly complained of abdominal distension with acute increase in the pain. What could have happened now? The procedure, the Whipple's procedure was successful.
Sir, there will be anastomotic leakage can happen.
How many anastomosis are done during Whipple's procedure? Can you just name them 1, 2, 3, something else?
Yes, sir. 3 anastomosis mainly. Pancreatogynostomy, pancreatohepatostomy, and hepatogynostomy and hepatogastrostomy. And
what is double duct sign? No idea. Okay, no issues. So what will you do now? This patient having leak, right? So what are your preoperative concerns? You said you did the surgery very nicely. You are the chief anesthesiologist for that particular patient. So surgeon wants that Nitisha should be the anesthesiologist again for this patient. So what are your preoperative concerns for this patient now? Dr. Aditi, whenever our time is over, just give me a full stop. We'll stop.
Sir, as the patient is having a distended stomach, I'll consider this patient as a full stomach patient. And I will go for a rapid sequence induction.
Okay. Any other concerns? One is full stomach. You will do rapid sequence induction and intubation for this patient. Anything else?
Regarding induction, sir.
For this patient management, 4th day, distended abdomen, acute pain, you said anastomotic leak. So आपने एक तो RSA ही किया. Any other issues? Okay, let me put forward straightforward.
Sir, it can be because of ascites or.
Why ascites on 4th day? Whipple's procedure तो हो गया अच्छे से उसका. Okay, I'll ask you a direct question now. So what are the post-operative complications that can happen to this patient? Can you just enumerate those 5-6 things that can happen to this patient? and let's think what could be the condition in this patient that needs to be taken care of. After Vipul's procedure, next 1 week, what all complications can happen?
Sir, pancreatic fistula.
Okay, good. One. What else?
Then postoperative hepatitis.
Okay, good. What else?
Then this anastomotic leak.
Anastomotic leak. Good. What else?
Then infection, sir. Sepsis. Surgical.
Very good. Sepsis is one. Next. Bolte raho.
Then
what happens to liver function? Can it derange?
Yes, sir. Liver
Can
function.
patient have liver failure, acute renal shutdown in the post-op period?
Yes, sir. Patient can have that.
Can patient have DVT?
Yes, sir. DVT.
Okay. Suppose उसका INR post-op में 2 था, right? Because liver dysfunction तो होगा थोड़ा बहुत पहले से भी था. So say INR is 2 on second post-operative day. And Dr. Aditi was very concerned कि हम उनको DVT prophylaxis देना चाहते हैं और आपने अभी बोला कि उस पर DVT भी हो सकता है. So will you give DVT prophylaxis to this patient and by what method? Whether it will be a pharmacological one or mechanical one or none?
Sir, I'll go for mechanical DVT profile, DVT thrombo.
So
Mechanical type. Sir.
So what are the conditions where you will not give pharmacological agents for DVT prophylaxis?
When patient bleeding, sir, and patient's INR is deranged, coagulation disorders.
So at what level you will give it? At what level of INR you will give pharmacological agent? At what level you will not give?
Sir, I can give when the INR is less than 1.5, I can give, sir.
Okay, perfect, right. So how do you see or screen DVT in the postoperative period?
Sir, we can look for the symptoms and the signs. Like if patient is complaining of calf pain, swelling, and investigation wise, we can look for Doppler scanning, sir.
Okay, so one is the clinical examination, symptoms, right? Calf tenderness, calf pain, patient is complaining of. If you do a physical examination, it will be stiff, it will be calf, more temperature would be increased, right?
Swelling.
Skin will be red, swelling will be there. And then on imaging, you said the venous Doppler can be done for this patient, right? Any other blood investigation that you do for this patient?
Sir, D dimer will be increased in this patient, sir.
Even without embolism?
Yes, sir.
Okay. Anything else apart from D dimer? It will be a homework for Nitisha, no issues. Okay. So can we take more time? Aditi, what do you say?
Sir, as you wish, sir. As you say, sir.
You have
Shivpriya ma'am would tell.
Yeah.
Yes.
8 minutes more, sir. We have till 3:30.
Oh, perfect. Thank you so much.
Okay,
I think then we can ask Nitisha a little more. She is giving good answers, so we can explore her more about those things. Right. Okay. So, Nitisha, suppose this patient intraoperatively is bleeding, right? And you have already arranged the blood products, right? You said you will arrange blood products. Which all blood products will you arrange for this patient, by the way?
Sir,
क्योंकि whole blood तो नहीं मिलता है, आजकल whole blood तो नहीं मिलता है ना?
Yes, sir. Packed cells I'll be ordering. Then fresh frozen plasma and platelet. Then cryoprecipitate.
Okay, good. So suppose this patient has blood almost around 1.5 to 2 liters intraoperatively, right? Patient is on some minor drop, and you did some ABZ. Then the blood bank was, which blood products do you want? So how will you decide which blood products out of 4 that you said? No blood, packed RBCs, FFPs, platelet, cryoprecipitates, or maybe some other drugs like tranexamic acid. So how do you decide which to use?
Sir, we can go, look for text to thromboelastic. with the help of the TEG, we can
Full form of TEG?
thromboelastography, sir.
Okay. Something called ROTEM also?
Ha, sir.
Full form of ROTEM?
Sir, rotational elasto.
थोड़ा ठीक है, 50% marks. Read it full, right? Okay. So this ROTEM or TEG, how do you decide? Do you know any values they use? Some R value or something? Can you just tell me in case if you know that?
Yes, sir.
If this is increased, if the angle is increased, if the duration is increased, I will give FFP, I will give cryoprecipitate, I will give nothing but wait for tranexamic acid. So if you know it well, if you don't, I think this is a distinction viva question, so don't worry. So if you answer it, you'll get distinction.
Sir, it have R value, then alpha angle, then lysis value is there, then maximum amplitude value is there. And if R value is increased, that means it is taking time for clotting. So we can give fresh frozen plasma. Then if maximum amplitude is less, then it is because of clot stabilization is not there. So it can be because of the platelet dysfunction. So we can give platelets for this patient. And if the lysis at 30 minutes and 60 minutes is there, if lysis at 30 minutes and 60 minutes is more, that means increased fibrinolysis is happening. So we can give tranexamic acid in this patient.
Okay, good, wonderful. I think you answered. I think we can ask little more questions. You are answering very well. So we'll take you next higher level now. Suppose on the post-operative day 7, this patient is now going to liver failure, right? And the surgery was, well, it was done absolutely good. Are you aware of any modality that can be used? Like, have you heard about dialysis?
Yes, sir.
So if the renal function is not being done, its dialysis is done. So any such replacement therapy for liver function also? Because when you do a liver surgeries, sometimes the acute liver failure can happen and it recovers of its own. So anything that we can do which can support the liver for some time, any therapy that you are aware of?
Sir, tips.
TIPS is an interventional procedure for some obstruction or something like this. So that you do pre-operatively, or you find some obstruction, then you do it. We are talking about something which can help the liver to give some time to the liver. It works. Like example, I show you. If the acute renal failure happen, you do a continuous renal replacement therapy. You do a hemodialysis, right? Isn't it? So anything not exactly similar, but something similar for the liver also. Something you have heard of Mars? Okay, this is just homework, because sometimes this can come as a short note. Or also there are certain therapies where the liver support system or liver replacement therapy is given, and this is something like an say molecular absorbent recirculating system, where they just support the liver for removing the toxins from the body, right? So this is just supporting the liver in these type of concerns, right? Okay. Do you think these type of surgical procedures are prone for hypothermia intraoperatively and postoperatively, and why?
Yes, sir. As these type of surgeries are long duration surgeries, is one of the reason, and there will be major fluid shift is another reason. And already my patient is in a malnutrition state, so the fat content is also less. And the surgeons used to give peritoneal wash also. With all these factors can lead to hypothermia, sir.
So what are the modalities that we will use in the post-operative period for management of hypothermia?
Sir, we can give warm IV fluids.
Okay.
Then we can give warm blankets.
What should be the temperature of IV fluids that you administer? You said warm. How much warm? 37, 39, 41, 45.
Sir, body temperature 36.
36. Body temperature is not 36, madam. Otherwise. So 37 is not correct.
Okay.
So आपने warm बोला ना? This means अगर हम बोले 37 is warm, so we're all are warm at every time.
No, sir. 40.
40. Are you sure 40? Okay, this is again a homework for you, for all the students who are learning, that what should be the temperature of the IV fluid that you are giving to this patient. Is it 37 or it should be somewhere 41 and 42 or it should be 45, right? This is the homework, because when you give these fluids to these patients, you are running them through tubings and it goes into the blood, and the temperature 37 may not be the only temperature, because the OT temperature is less than that and it will cool much faster. So what should be the optimal temperature of IV fluid that is being given to this patient? You should also be remembered. So thank you so much. Thank you, Dr. Aditi. Thank you, Dr. Nitisha, for giving such a nice answers. I am sure that you'll be getting distinctions in your coming exams. You have done very well. And thank you, RML team, Dr. Amri Kaur, Dr. Shivpriya, Dr. Akhilesh Gupta, and the whole, Dr. Neja Banerjee and whole team for conducting such a nice program for the postgraduate. In fact, it is learning process for me also. Aditi's session was really good. I learned a lot of from her slide also. Thank you so much. Over to you.
Thank you so much, sir, for such an extensive and such a elaborate case discussion. Students must have benefited, I'm sure. Thank you so much, sir, for your time. Thank you, Dr. Aditi.
Thank you, sir. Thank you, ma'am.
So now let's move on to our next session that will be chaired by Dr. Nivedita Pani. She is a professor and head of the Department of Anesthesiology and Critical Care, SCB Medical College, Cuttack. And her areas of special interest are pediatric anesthesia, critical care, and pain. I welcome you, ma'am. Over to you, ma'am. Ma'am, you have to unmute yourself. Please unmute yourself.
First of all, good afternoon and namaskar to everybody. It is really a wonderful program, because I was just observing just before this session, and it is really, really interesting. And I must thank all the organizers for giving me a wonderful opportunity to chair this session. Thank you.
Thank you so much, ma'am. Welcome.
Should I start?
Yes, ma'am.
So today's speaker is Dr. Manpreet Kaur. She is the associate professor affiliated to the AIIMS, New Delhi, and her area of interest is pediatric anesthesia, trauma anesthesia, and simulation. Dr. Kaur, please start your session.
Good afternoon. I'll be talking about how to read an arterial blood gas analysis. By the end of the lecture, the learner would be able to learn the indications and contraindications of arterial blood gas analysis, the technique of doing it, multiple clinical pores, assessment of oxygenation, ventilation, acid-base status, and the 6 steps of acid-base interpretation. Arterial blood gas analysis is indicated to assess the adequacy of ventilation, oxygenation, acid-base homeostasis, and also to rapidly assess the electrolytes. However, it's contraindicated when there is negative modified Allen's test. Modified Allen's test is done to check the overall blood supply to the hand. We locate the ulnar and the radial arteries, have the patient make a tight fist for about 30 seconds. Then we obstruct the blood flow, press down on the ulnar artery with 2 fingers. After that, the patient is asked to open the hand, and at that time, the palm should blanch. After that, we release the pressure of the ulnar artery, and if the hand flushes within 5 to 15 seconds, this shows that the hand has good flow, and the modified Allen's test is negative. Otherwise, the modified Allen's test is positive if there is no return of the blood. Blood sampling must be done during the steady state, whenever there is initiation or change in oxygen therapy or changes in ventilatory parameters with patients on mechanical ventilation. In the patients without any overt pulmonary disease, a steady state is reached in about 3 to 10 minutes. And in patients with chronic obstructive lung disease, it's reached in 20 to 30 minutes. So after 10 minutes, we can take an arterial blood gas after settling up with the ventilation and oxygenation in a healthy patient, while in a COPD patient, it takes around 20 to 30 minutes. The site in the preference order, with the radial artery being preferred the most, a sample of 2 to 4 ml is taken, and a glass syringe is preferred to the plastic syringe because plastic syringes are least affected by pH and PCO2 values. PO2 values drop more rapidly in plastic syringes. Other advantages of glass syringes are like there is minimum friction of barrel with the syringe, and usually there's no need to pull back the barrel. After taking a blood gas sample, a firm pressure is applied for at least 5 minutes, and the sample has to be vigorously rotated in between the palms for about 30 seconds so that there is mixing of heparin. So how frequently should we take the sample? It will depend upon the clinical status, and there is no arbitrary time or frequency for that. An arterial sample is distinguished by the presence of blood pulsating in the syringe, or the syringe plunger rises on its own, and SpO2 and SaO2 values, they correspond. The agreement between the arterial and venous PCO2 is too poor and unpredictable to be clinically useful, so it's preferred if we take an arterial sample. And we must remember that the color of the sample is not reliable. While looking into the documentation of an arterial blood gas analysis, whichever report we have had, we should always put in an inspired FiO2 concentration and the mode of supported ventilation. The factors which can affect the blood gas analysis are heparin, air bubble, delayed sampling, pain, and others. For heparinizing a syringe, we draw the heparin solution up to 2 cc mark and then completely evacuate it. So 0.025 cc of solution that remains to coat the syringe, which contains approximately around 125 international unit of heparin. For 2 ml sample of blood, it accounts to 60 international units per ml, and we need minimum of 10 international unit per ml of heparin. However, if we take more heparin, plasma electrolytes would decrease, but pH remains unchanged because of the vast buffering potential of oxyhemoglobin and plasma proteins. In case there is an air bubble in the syringe, the air bubble itself has a PO2 of 150 and PCO2 of 0. So in case the sample has a PO2 value more than 150, then the sample's PO2 will rise, whereas if the sample's PO2 is more than 150, then the PO2 value will fall. Because the blood is living tissue, oxygen is consumed and carbon dioxide is produced in the blood sample. The delay may affect the blood gas values, and it is prudent to do an arterial blood gas analysis as early as possible. How we can store the ABG syringe for 1 hour, up to 1 hour at 0 degree, and for 10 to 15 minutes at room temperature. In case there is pain during sampling, the patient can either breath hold or hyperventilate, which can alter the results. The 3 important aspects of arterial blood gas analysis are the ventilation, oxygenation. Oxygenation is determined by PO2, SO2, CaO2, FiO2, alveolar arterial gradient, and the acid-base balance. So which will tell us whether there is acidosis or alkalosis, respiratory or metabolic component, what are the electrolytes, what is the anion gap, and what is the lactate. So while we go into its detail, 3 important equations we must remember. First is PaCO2 value, which is used for alveolar ventilation. Second is alveolar gas equation, which will help in calculating the alveolar O2. And the third is oxygen content, which helps in evaluating the oxygen transfer at the tissue level. The alveolar ventilation is determined by PaCO2. So when we talk about ventilation, we talk about PaCO2. When we talk about oxygenation, we talk about PaO2. In case there is alveolar hypoventilation, the PaCO2 will rise and vice versa. The target of oxygenation is to provide oxygen delivery to the various tissues, and it is dependent upon multiple oxygen indices. First is PaO2, which reflects only the dissolved oxygen and not the bound one. So we need to know what is bound to the hemoglobin, which will be determined by the CaO2. Oxygen saturation, which is reported as an ABG, and it is determined by the oxygen dissociation curve, and it's not a measured value. Lastly is the alveolar arterial gradient, which is helpful and is used to classify the respiratory failure. So let's discuss this in detail. Out of these two patients, a patient with higher SaO2 but lower HB, and another patient with lower SaO2 but higher hemoglobin, which is more likely to be hypoxemic. So body needs oxygen molecules. So oxygen content, that is CaO2, takes the precedence over the partial pressure in determined degrees of hypoxemia. So calculating the oxygen content will be by multiplying the hemoglobin SaO2 with 1.34. So the total oxygen content here is 8.9. However, in the second, it will be more. So a patient with higher CO2 is likely to be lesser hypoxemic. So hemoglobin has a lot of effect on the oxygen content. So always check the CaO2. What if ABG shows SO2 75% and pulse oximeter shows 97%? Which one would you believe? So ABG is more reliable because it measures oxyhemoglobin separately, while on the pulse oximeter, any bound hemoglobin which is shown as saturated hemoglobin like carbon monoxide bound will also increase the SO2 in pulse oximeter. However, the patient might have lesser PaO2. So PaO2 will be more reliable value. The degree of hypoxemia can also be labeled depending upon the PaO2, and PaO2 is age dependent. So PaO2 is 109 minus 0.4 the age. Another important thing is alveolar arterial gradient. It's basically the difference between the partial pressure which is there in the alveolar oxygen and the arterial oxygen. It is going to represent the efficacy of gas transfer between the lungs. A small gradient of 25 to 25 is normal because physiological shunting of oxygenated bronchial blood will decrease the PO2. So for example, as we had taught about the alveolar gas equation, this is the inspired PO2, that is 21%. So 760 pressure minus 45 for water vapor into 21, that is 150. So this 150, when subtracted from the PaCO2 divided by respiratory coefficient, it can be derived into PiO2 minus 1.25 into PCO2. So 150 minus 50 will be 100. So this is the alveolar PO2 minus PaO2 which is 90. So if we subtract, it is 10. For a particular age group, for example, if we have to calculate the alveolar PaO2, is alveolar arterial difference. It's age divided by 4 plus 4. For example, for a 20 years old, it will be 20 divided by 4, that is 5 plus 4, that's 9. However, for a elderly patient like 80 years, 80 divided by 4 plus 4 will be 24. So it is determined by the age. This alveolar arterial difference should be always is a calculated derived value. So if we feed in FiO2 values to ABG, alveolar arterial difference gets calculated, and it also tells us about the disease progression. As we could see in the previous equation, that it is PiO2 is also determined by FiO2. So there is an increase of 5 to 7 mm for every 10% increase in FiO2. Another concept is PF ratio, which is normally 4 to 5. However, if the lung is compromised, it reduces to less than 300 or less than 200. And it also helps in calculating the shunt fraction. Lower the value, more is the shunt value. Less than 200 corresponds to 20% of the shunt. Coming to case scenario, a patient of SLE posted for appendectomy, his preoperative ABG is this, which is shown. Is it okay as an oxygenation? So if we go into the preoperative ABG, for oxygenation status, apparently the lungs look good with PaO2 of 90, but the washout is 50. So the expected PO2 should have been more. So alveolar oxygen PiO2 minus PaCO2 by respiratory coefficient 150 minus 18 is 132. And if we subtracted the value, we'll get a wide alveolar arterial gradient. So whenever we are talking about oxygenation, we must correlate PaO2 with FiO2 and also correlate with PaCO2. Another few examples out of these, a patient with low FiO2 and normal PaO2, if we calculate the alveolar arterial difference, we'll find in this that it is increased. Another patient with low FiO2 administered and high PaO2 has a alveolar arterial difference of 12, which is almost normal. And another patient who is requiring high FiO2 may have a higher PaO2. So alveolar, if we calculate, then we'll find that it is around increased. So despite a very high PaO2, which is shown in the figure, the lungs are not able to transfer normally. So we have covered ventilation, oxygenation. Coming to acid-base balance. We know pH is maintained over a very narrow range, and pH is really important because multiple enzymes function at a particular pH only. A range below 6.8 and more than 7.8 pH is incompatible with life. And pH is based upon a log scale. So even a small change in pH will be associated with large absolute changes of H ion. And H ion amount very small in comparison to the physiological cations. Like sodium is 140. However, it is 0.000004 H ion. And this is pH is based upon the interaction which is represented by Henderson-Hasselbalch equation. That is pH is equal to pK plus log bicarb over PCO2. As we know that bicarbonate is determined by the kidney and CO2 is determined by the lung, correspondingly to the metabolic and the respiratory portion. This equation has been reorganized so that H ions is equal to 24 into PCO2 divided by bicarbonate. And this is very important, which helps in the validity check, which is the first step in analyzing the arterial blood gas analysis. To know what is the H ion, we ought to know the pH. And the last two digits of the pH will help in calculating the H ions. For example, if the pH is 7.4, so 80 minus last two digits, that's 40, will help us calculate the H ions. This all arterial blood gas analysis is based upon the multiple lines of defense, which include the buffer system, that is bicarb, plasma proteins, hemoglobins, phosphate, the respiratory compensation, which occurs very rapidly, and the renal compensation, which is comparatively slower. The buffers in respiration are temporary mechanism, while the kidney can make a permanent adjustment. A few terminologies like acidemia is basically decrease in the blood pH. However, it is the process which is called the acidosis and the alkalosis respectively. While looking up into the ABG, we come across actual bicarbonate and standard bicarbonate. Actual bicarbonate is basically calculated from PaCO2 and pH by Henderson-Hasselbalch equation. However, standard bicarbonate is measure of bicarbonate concentration under standardized condition of, that is, if the bicarbonate concentration in plasma of fully oxygenated blood which has been equilibrated to PaCO2 40 at 37 degrees. So this actual bicarbonate is not actually a pure indicator of non-respiratory acid-base problem, since it increases in respiratory acid-base disturbance by virtue of its hydrolysis reaction. And the standard bicarbonate, this eliminates the hydrolysis effect. So it represents the buffering capacity of blood better, as it eliminates the respiratory component in the acid-base status. So whenever we're looking up into the ABG, we have to look up the standard bicarbonate and not the actual bicarbonate. Another is the base excess, which measures the quantity of acid or base in milliequivalents, and it is basically an indicator of metabolic quotient. This base excess measures all the bases and just not the bicarbonate. But however, for practical purposes, bicarbonate is greater part of the base buffer and much represents it. Even an ABG shows base excess of blood B and base excess of ECF. Base excess of ECS is more representative of in vivo component, so that is which is taken. Normally it ranges from +2 to -2. The important aspect is that if you're looking up into the ABG and you get in base excess towards the extreme -2 to +2, that is lesser than -2 or more than +2, it indicates that there is metabolic component also attached. We can also measure electrolytes through ABG, and a normal value may differ for one patient to other, as one site can't fit to all. For example, in a neonate, pH ranges from 7.2 to 7.4. In a geriatric, because of hypoventilation, the PO2 will be lesser. Pregnancy, because of hyperventilation, the PCO2 normal will be lesser. And in sleep, because of hypoventilation, the normal PCO2 will be more. Altitude would not alter the pH but reduce the other values. Acid-base disorder can be primarily metabolic or respiratory. A primary disorder not only changes the acid-base equilibrium directly, but also sets in a few compensatory mechanisms. These are the normal values which you must remember. So how to look up the ABG? First is what we do is validity check. As I've discussed Kessler-Blake equation, so H ions is what we calculate. And let's go into an example. For example, this pH is 7.30. So 80 minus 30 will be 50. So 50 should be the H ions. However, calculating the H ions will be determined by the equation 24 into the PCO2, that is 26, and bicarb 22. The calculation comes out to be 28.6, which is not like what we expected. So this is not a valid ABG. Next is to obtain a relevant clinical history. We should never comment without a relevant clinical history. For example, it can have a clue to the etiology of the acid-base disorder. A patient with renal failure is more likely to have metabolic acidosis. A patient who is having vomiting can be a case of metabolic alkalosis. A patient who is hypoventilating may have respiratory acidosis. A patient who has hepatic coma or pulmonary embolism may be hyperventilating to have and will have a picture of respiratory alkalosis. So always obtain a relevant history. Next, look for the oxygenation and ventilation, which we have already gone into detail. And thirdly, we look up the acid-base analysis. First step is whether the patient has acidic or alkylatic. Second step, we'll look up PCO2 and see whether they go in the direction of pH. Third is we look up into the compensation. In case it is metabolic acidosis, and an anion gap is looked for. And then the delta gap and urinary anion gap or osmolar gap is looked for. We'll one by one go into its detail. So as we know, the pH is 7.35 to 7.45. If it is less than 7.35, it's acidemia. Otherwise, if it's more than 7.45, it's alkalemia. So this is, now we know the primary disorder. It could be possible that the pH might be in the normal range because there is compensation, or there could be a mixed disorder which is present. So next steps will help us. Next step, we look up the direction of PCO2 and pH. If pH and PCO2 go in the opposite direction, it's a respiratory disorder. And if pH and PCO2 go in the same direction, it's a metabolic disorder. So like, for example, if the pH is decreasing and there is also concomitant fall in PCO2, it's a metabolic disorder. Since pH is decreased, it's a metabolic acidosis. Similarly for the other ones. Next step is to see the compensation. Now the body's homeostatic mechanism serve to return the bicarbonate to PCO2 values to a normal level so that they can normalize the pH. So in most of the compensatory mechanism, they might fail to fully return the pH to normal. So they could be partially compensated or uncompensated. So for example, in metabolic acidosis, both they are in the same direction, and PCO bicarbonate will also decrease. That is, bicarbonate will follow the carbon dioxide, as you can see in all the disorders. So that is how the compensation is going to take place. So in case there is a metabolic disorder, respiratory mechanism take into place, whereas it's a respiratory primary disorder, the metabolic component that causes the compensation. This is a slide which must be remembered by heart and will help in calculation of the compensation. This expected CO2 for metabolic acidosis is called the Winter's formula. And as you can see, metabolic alkalosis expected CO2 is 0.7 into bicarb plus 21. In case there is a respiratory acidosis, the bicarbonate calculated will be 24 plus 0.1 into change in CO2. And in chronic, it is 0.4 into change in CO2. So you can remember 1,4 in respiratory acidosis. And for respiratory alkalosis, you can remember 2,4. However, the value has to be subtracted. As you can see from the picture, the standard base excess is 0 in both the acute conditions, because base excess is what is related to the metabolic component. And in acute cases, there will be no time for compensation because renal metabolic compensation is going to take some time to occur. So let's talk about a few examples. In this case, pH is less, PCO2 is less. So by Winter's formula, 1.5 into bicarb plus 8 is, that is 1.5 into bicarb is 3 by 2 into 8. 15 plus 8 is 23. So it's metabolic acidosis, which also has some other component, that is respiratory acidosis. So you can see standard base excess is minus 20. 40 minus 20 is expected to be 20. How it's 28? So CO2 is more. So we have two disorders together. So it could be a DKA. In this, pH is high normal. PCO2 is also high, is in the opposite direction. So it's a respiratory disorder. And there is compensation because the pH is normalizing. So respiratory alkalosis with metabolic alkalosis and complete compensation. In this, pH is more, PCO2 is also on the higher side. So it's a metabolic alkalosis uncompensated. pH is more, PCO2 is less. It's metabolic, it's opposite direction. So it's a respiratory alkalosis. So, and the pH is not normalized, so there's no compensation. Here pH is more, PCO2 is also, pH is also normal, PCO2 is also normal, and bicarbonate is also normal. So remember that you could also have normal ABGs. After we have looked for metabolic acidosis, there comes the concept of anion gap. So as we know, to keep the membrane neutral, there are anions and cations. So the total number of cations and the total number of anions, which may include unmired or mired ones. So rearranging this, anion gap is the major cations, that is sodium, potassium, minus the major anions is equal to unmeasured anions minus unmeasured cations. Unmeasured cations are like calcium, magnesium, which are in very less amount, so won't make a lot of difference. Whereas unmeasured anions are like plasma protein. The value comes out to be 12 plus minus 4. However, if potassium is omitted, it comes to be 8 plus minus 4. The recent books stated as 7 plus minus 4 because they are automated for electrolyte measurements. And we must remember that anion gap is basically footprint of metabolic acidosis, and it also avoids the missed or concealed metabolic acidosis. So for example, if the pH may be normal, but if there is high anion gap, there could be metabolic acidosis. You can immediately also look at the basic CES picture to help you guide this. So in this picture, you can see the unmeasured cations include magnesium, calcium, whereas unmeasured anion mainly are formed by albumin and phosphate. So albumin is a principal unmeasured. So hypoalbuminemia will lower the anion gap. There is a adjusted anion gap, which is observed anion gap plus 2.5 into the delta albumin. So adjusted anion gap will be like, for example, if we have seen 10 anion gap, then plus 2.5 into as a value is a higher value is 4.5 minus 2. So this comes to be 16. So the corrected anion gap shows improved performance in critically ill and is a more accepted entity. So anion gap helps in identifying the etiology. So it could be high anion gap or normal anion gap. High anion gap you can remember with the mnemonic mud piles, methanol, uremia, decay, paraldehyde, infection, lactic acidosis, ethylene glycol, salicylate. I remember it with Kussmaul, ketoacidosis, uremia, salicylate, methanol, alcohol, lactate, as there is Kussmaul breathing in the metabolic acidosis, a few metabolic acidosis like ketoacidosis, decay. Can be normal anion gap metabolic acidosis. You can remember with the mnemonic Durham, diarrhea, uretrosigmoid fistula, RTA, hyperalimentation, acetazolamide, and miscellaneous ones. So once you've checked the anion gap, then check the change in bicarbonate. So this change in anion gap divided by the change in bicarbonate helps in calculating what is called the delta ratio. Now, in case there is metabolic acidosis of increased anion gap, the fall in bicarbonate is generally equal to the rise in anion gap. Now, with the help of this ratio, we can easily calculate. For example, now if there is a mixed disorder and there is high anion gap, the ratio will be higher. So change in bicarbonate will also be affected. However, if there is delta ratio which is more than 2, then high anion gap with metabolic alkalosis can be present. Next step is to measure these anion gap in urine. So we don't take into account bicarbonate in it, sodium plus potassium minus chloride, and normally it's 30 to 50. In hyperchloremic metabolic acidosis, the urinary anion gap becomes important, and it helps us to differentiate whether the gut is the source or the renal source is there. So in case gut is there, the source, kidney function will not be affected. So the renal acidification will not be affected. As a result, the ability to increase the ammonium excretion will be increased, which is excreted with the chloride. So chloride will increase in the urine and urinary net charge will be negative. So you can remember that the negative in diarrhea. So in case there is negative urinary anion gap, so it's diarrhea or the gut being source. In case it's positive, then with the help of pH, we can differentiate different type of renal tubular acidosis. Sixth step is to know the osmolar gap. Now, we know that the osmolarity is formed by twice sodium plus blood urea nitrogen divided by 2.8 and glucose in 18. Urea and sugar being one of the major sources of osmolarity. Normally, the osmolar gap, that is measured osmolarity and calculated as a difference of less than 10. However, if it's more, then it's likely to have some toxins. So consider non-calculated osmotically active substances like toxins, which could be methanol, alcohol, mannitol. So this is the 6 steps approach for acid-base balance. Remember the format, look whether the ABG is valid or not, correlate with the history, then look for ventilation and oxygenation, then look at the pH and PCO2, its direction to differentiate metabolic and respiratory, and look whether there is compensation or not. For compensation, for metabolic acidosis, remember the Winter's formula, and for metabolic acidosis, it could be normal in iron or increased in iron gap. If you have an increased in iron gap, which could be due to ketoacidosis, lactic acidosis. So to differentiate, we do ketoacidosis. In ketoacidosis, either it could be alcoholic or decay, depending upon the presence of beta hydroxybutyrate more in alcoholic. And in case there is increase in iron gap, there could be causes like toxins. So look for osmolar gap in them. However, in case there is normal in iron gap acidosis, negative in gut, so look for a gut cause, whereas it's positive, it is likely to be renal tubular acidosis. In metabolic alkalosis compensation, PCO2 expected is 0.7 into bicarb plus 21. So alkalosis occurs either due to an alkali gain or due to a H-ion loss, which can be through kidney or through gut. If the PCO2 for acute respiratory alkalosis compensation, for every 10 mm decrease in PCO2, there is 2 milliequivalent decrease in bicarbonate, and in acute standard base excess will be normal. And you can calculate from this very formula 24 minus, for example, if the PCO2 were reduced to 20, the change in PCO2 would be 20 into 40 minus 2, that is the fall in plasma bicarbonate will be 4. So the new plasma bicarbonate will be 20, 24 minus 4. In chronic respiratory alkalosis, the formula is multiplication by factor of 0.4. In acute, you should remember for acute respiratory acidosis, the increase in plasma bicarbonate equals about 1 milliequivalent for 10 millimeter increase in PCO2, and for chronic, it's 4. The pH also helps in guiding us. In an acute change, there is change of pH of 0.08, whereas for chronic, it's 0.03. So coming into a few examples, like this, a diabetic patient with Kussmaul breathing, pH is reduced, PCO2 is reduced, both in the same direction. So it's a metabolic acidosis. And since the pH is not normalized, it's uncompensated metabolic acidosis due to decay, which is also seen by this. A 7-year-old post-op patient presenting with chills, pH is reduced, PCO2 is reduced, expected CaO2 according to Winter formula will be 1.5 into bicarb plus 8, that is 23 plus minus 2. So it is less. So this is a uncompensated metabolic acidosis, which could be due to low perfusion. When we have metabolic alkalosis, then there could be chloride responsive or unresponsive, and we can also do a urinary chloride levels. So a 55-year-old man with hypertension and history of diuretic, he smokes, he's a smoker. In this, let's go step by step. The ABG is valid, looking for ventilation. It's adequate for the patient level. As the level of patient's level of CO2 production is normal, the CO2 is normal value. Regarding PO2, we can see the VQ, alveolo-arterial difference, which is approximately coming out to be 43 in this. And this is basically due to VQ mismatch. Regarding the acid base, the pH is elevated. PCO2 is also a little high. and but both in the same direction. So it's a metabolic alkalosis, most probably due to diuretic. To sum up, for respiratory acidosis, the bicarb goes up by 1 in acute and 4 in chronic. And for respiratory alkalosis, bicarb goes by 2 and by 4 in respiratory alkalosis. A few case scenarios. A 58-year-old male, a woman, for dyspnea. As you can see, oxygenation, PO2 is reduced because of hypercapnia or V-cube imbalance. Patient has high CO2, is hypoventilating. pH is less, PCO2 is high, opposite direction. It's a respiratory disorder, respiratory acidosis. To see whether there is metabolic component or not, if there was base excess, we could have looked for. The calculated bicarbonate is comparatively lower, so it's also acute respiratory acidosis along with metabolic acidosis. In this, pH is increased, PCO2 is less, both moving in the opposite direction, so it's a respiratory alkalosis, and base excess is negative, my normal range, so it's an uncompensated respiratory acidosis. Uncompensated respiratory alkalosis with severe hypoxemia due to asthma exaggeration. Another example, PO2 is lower, so than the expected for the patient who is hyperventilating. So the oxygen content we can calculate. In ventilation, PaCO2 is half normal, indicates that the patient is hyperventilating. The normal pH with a very low bicarbonate indicates the pH is going in the opposite direction. So it's a respiratory alkalosis, and there could be low bicarbonate because of the metabolic acidosis. Herein we can first look in the validity check, then look for oxygenation, ventilation. Herein you can see that oxygenation, SO2 98, PO2 137. The oxygen content here comes out to be 1.34 into PO2 into SO2 into hemoglobin as 18. The alveolar arterial difference is 135 and the patient is hypoventilating. So this is a case of metabolic acidosis. Another example, a 16-year-old female with onset of dyspnea. Here the pH is more than 37.35, so alkalosis. They are moving in the opposite direction, so it's a respiratory alkalosis. It's acute because bicarb is equal to approximately 0.2, and had it been chronic, then it had been 28. So it's more towards the acute. So it's acute respiratory alkalosis. Another example, pH is less, PCO2 is also less, so it's a metabolic acidosis. Calculating through the Winter's formula, and then we find the anion gap. We find the anion gap is high, so it's an increase in anion gap, metabolic acidosis. Here the pH is less, and PCO2 is also less. It's metabolic acidosis. Calculate the anion gap, it's elevated. It could be secondary to the lactic acidosis in the setting of vomiting. Anion gap is 48, which is very high. So delta anion gap we'll calculate. In this, 48 minus 12 is 16, and delta bicarbonate is 24 minus 8. So the ratio comes out to be 1.2. Since the delta gap is more than 1, it's concurrent metabolic alkalosis. So it's mixed elevated anion gap metabolic acidosis and metabolic alkalosis due to lactic acidosis. To summarize, we go for serial PGE's clinical profile and always correlate with the clinical judgment for a correct interpretation. We look for oxygenation, ventilation, arterial acid-base imbalance, whether it's simple or mixed disorder, and then we look up whether there is acidemia or alkalemia by 6-step, and ultimately come to a conclusion. Thank you.
Thank you, Dr. Kaur. It's a wonderful lecture, and you have made the things very simpler way. And there is a question in the chat box. Dr. Cypriya, the time is there? Can I just tell her?
Yeah, I have just seen the question, base excess, right? So I'll take that question. The base excess, what does it mean? So there are multiple bases in the body. The most important and the maximum one is bicarbonate. When we talk about base excess, that means the bicarbonate predominantly. So when we have a base excess, it's, if you tell its definition, it is basically amount of acid which you want to add to each liter of fully oxygenated blood to return the system pH to normal at a temperature of 37, PCO2 of 40. So whenever you have base excess, that indicates that there is a metabolic alkalosis. However, there is base deficit. That means your bicarbonate is less. So there is metabolic acidosis. So in that, if you have a definition you have to talk about, then in base deficit, you will talk about amount of base that is needed to make the serum to normal. Okay, so more negative the base excess is, it indicates that you have a metabolic acidosis. That is -2, lesser than -2 will take you to the metabolic acidosis. If more than +2 it is there, that means there is metabolic alkalosis. So immediately by seeing the ABG, you can tell that there is a metabolic disorder present.
Thank you, Dr. Kaur. It's a very wonderful session. Dr. Cypriya, should you go to the next session?
Yes, ma'am. Please, ma'am.
The next session will be by Dr. Amrita Gupta. She is the associate professor. She is affiliated to SN Medical College, Agra. Her areas of interest is pain. And she is going to give the session on the anaphylaxis. Please, Dr. Gupta.
Good evening, everyone. Today I am going to speak on the topic anaphylaxis. Coming to the definition, anaphylaxis is a severe, life-threatening, generalized or systemic hypersensitive reaction that is rapid in onset and may cause death. Anaphylaxis during anesthesia is a rare phenomenon. According to NAP6 report, it was found that the incidence of anaphylaxis was 1 in 10,000. The report also showed that the most important culprit of the anaphylaxis are antibiotics and the neuromuscular blocking agent. Even dyes, antiseptics, conoids, and iodinated contrast agents can cause anaphylaxis. Coming to pathophysiology, anaphylaxis is a type 1 hypersensitivity reaction. It can be Ig mediated and non-Ig mediated. The initial sensitization occurs whenever the susceptible individual is presented with an allergen, and in response to that allergen, the B and T lymphocytes of the body produces IgE antibodies. Now, what these Ig antibodies do? These Ig antibodies bind to FcER1 high affinity receptors present on the basophils and the mast cells. They also bind to FcER2 low affinity receptors which are present on leukocytes, basophils and eosinophils. Now, this time they only bind. Now on re-exposure to the same allergen, there is cross-linking of IgE antibodies, and which result in a cascade of reaction with the release of many mediators like histamine, tryptase, leukotrienes, and prostaglandins, which cause anaphylaxis. However, there are non-allergic mechanisms also which cause grade 1 or 2 type of reactions. Like there is direct non-specific activation of mast cells which cause release of histamine like atracurium, mivacurium, propofol, and succinylcholine. There is also calcium and phospholipase dependent mechanism like vancomycin causing Redman syndrome. There is also non-specific activation of G protein coupled mast receptors as in case of opioids. Coming to the clinical criteria of diagnosing anaphylaxis. There is acute onset of illness. There is involvement of skin, mucosal tissue, like there may be generalized hives, pruritus may be present, and there should be at least one of the following, like respiratory compromise or cardiovascular compromise or symptoms of end organ dysfunction, like hypotonia, collapse, syncope, and incontinence. Clinical presentation is according to Ring and Massmer scale. There are 4 grades. Grade 1 and 2 reactions are most likely to be non-allergic. As I told you earlier that anaphylaxis is either Ig mediated allergic and non-Ig mediated, that is non-allergic. That non-allergic in which there is non-specific activation of mast cell, vancomycin causing Redmond syndrome. There are mostly grade 1 and 2 reaction. Grade 3 and 4 reaction are mostly Ig mediated reaction which cause full-blown anaphylaxis. In grade 1, there is only skin and mucosal signs like generalized erythema, extensive urticaria, or both with or without angioedema. In grade 2, there is moderate multi-organ involvement like moderate hypertension, moderate bronchospasm, tachycardia is there, or GI involvement is there. But in grade 3, there is life-threatening multi-organ or mono-organ involvement like life-threatening hypotension, life-threatening bronchospasm, tachycardia. But there is a bradycardia. But bradycardia is a protective phenomena. Like in anaphylaxis, there is a release of mediator which causes the shift of fluid. 70% of the fluid is shifted into the interstitial space. So there is a severe hypovolemia. When hypovolemia is there, the receptors in the left ventricle, in the heart is activated, in the left ventricle is activated, which causes the Bizon-Zarisch reflex. It is a protective reflex and which take the signals via unmyelinated vagal fibers, which causes bradycardia. And how come it is protective? Because bradycardia allows the heart to fill during the diastole. So whenever you give atropine just by seeing bradycardia, the heart will not be able to fill during the diastole and cardiorespiratory arrest can occur. So never give atropine in bradycardia during anaphylaxis. Grade 4 is cardiac or respiratory arrest. Coming to the laboratory investigation, serum tryptase is a mast cell protease that is increased in case of anaphylaxis, and it can be measured in the plasma 30 minutes after the first sign of anaphylaxis. Its half-life is 2 hours. Half-life of histamine is also 15 to 20 minutes. So both the histamine and tryptase can be measured 30 minutes after the anaphylaxis. There are also in vitro test and in vivo test. In vitro tests are radioenergo absorbent test, that is RAST. It has very high specificity, but sensitivity is low. Skin prick and intradermal technique are in vivo test, and it also has a very high positive predictive value whenever the anaphylaxis is there. Now, various causes of anaphylaxis, like neuromuscular blocking agent is responsible for 60% of the anaphylaxis because it has a quaternary ammonium structure compound which is responsible for it. Succinylcholine is responsible for most of the cases of anaphylaxis because it has inherent mobility in its structure which bind to the Ig antibodies. Rocuronium also has a slightly less mobile structure, but it has also a tendency to bind to the Ig antibodies like succinylcholine and hence cause anaphylaxis. Atracurium and mivacurium, as I have told you earlier, cause direct non-specific activation of mast cells and cause its degranulation when injected fast. So it causes typical wheel and flare, yani grade type 1 and 2 reaction. Cisatracurium is though an isomer of atracurium, but it does not cause anaphylaxis and histamine release. Antibiotics. Penicillin is responsible for about 70% of the anaphylactic reaction. And there is also a cross-reactivity between the penicillin and the first generation cephalosporin because they share the same beta-lactam structure. So in case of penicillin allergy, one should not give first generation cephalosporin also. Vancomycin also when injected fast, it also causes histamine release and Redman syndrome. Latex is also responsible for causing 20% of the anaphylactic reaction. Healthcare workers many times wear gloves and which contain latex. And whenever they are in contact with the patient while putting the endotracheal tube or urinary catheter, it can cause anaphylaxis due to latex allergy. So avoidance is the only effective method, and you can use nitrile gloves in place of latex gloves. Local anesthetics. Local anesthetics also cause anaphylaxis, but it is very rare. There are two groups, ester and amide-linked. Ester groups such as tetracaine and benzocaine, they are metabolized to para-aminobenzoic acid, which can provoke Ig-mediated type of reaction. There are also preservatives in local anesthetics like methylparaben and metabisulfite, which can cause anaphylaxis. Although there is no cross-sensitization between ester and amide group of local anesthetic. Opioid. True anaphylaxis has been reported with every opioid because opioid has a tertiary amine type of structure which cause anaphylaxis. Pethidine is most commonly responsible for it. Cross-reactivity is there among the opioids except in the phenylpiperidine group, that is fentanyl and sufentanil group. Propofol is responsible for induction agent. Propofol is responsible for 1.2 to 2% of the anaphylactic reaction because propofol contains soy oil, egg albumin, and glycerol. And it was said that propofol should not be given to the patient who is having the egg allergy. But there is no written document or there is no such evidence to prove that there is an increased risk of anaphylaxis in this population. Anaphylaxis to benzodiazepine is also very rare. Diazepam is dissolved in propionine glycol, which is responsible for causing anaphylaxis. But midazolam is very safe benzodiazepine and it has not any metabolite. Volatile agent, there is not a single report of any anaphylactic reaction with the volatile agent. Even the fulminant hepatitis, which was associated with halothane, it has immune component and it is not at all related to anaphylaxis. Management. There are mostly 3 key steps to management, that is timely diagnosis, appropriate dosing of epinephrine, and appropriate intravascular fluid replacement. Also, patient should be given oxygen and neck should be raised so that venous return is improved. There are 4 grades, as I told you, according to Ring and Mesmer scale. In grade 1 reaction, no treatment is required. In grade 2 reaction, in which moderate hypotension and bronchospasm is there, we have to give bolus IV epinephrine 20 microgram. We have to increase the dose by 50 microgram when there is no response after 2 minutes of epinephrine dose. If you do not have any IVSS, we can give IM epinephrine 300 microgram. And we have to give IV crystalloid 500 ml at rapid bolus and repeat if there is inadequate response. In grade 3 reaction, in which there is life-threatening hypotension or bronchospasm, we have to give either 50 microgram bolus or 100 microgram bolus. 100 microgram is given when you have already started the vasopressor or bronchodilator, but there is no response. So you start with the 100 microgram. You have to see for 2 minutes, and if there is no response, you have to escalate the dose to 200 microgram. We have to give crystalloid also 1 liter as bolus and repeat if there is inadequate response. In grade 4 reaction, there is a cardiac or respiratory arrest. So we have to follow the ACLS guidelines, in which we have to give the epinephrine 1 milligram IV. Dilution is 1 in 10,000 every 3 to 5 minutes. And we have to start the cardiac compression even if the systolic BP is less than 50 mm of Hg and end tidal CO2 is less than 20 mm of Hg. Now coming to the refractory management, we have given the epinephrine, we have given the fluids. Even after that, there is inadequate response after 10 minutes. Now what we will do? We will escalate the epinephrine dose. Like we will double the bolus dose and we will give this doubling dose for 3 times. If no response occur, we have to start with the epinephrine infusion. That is 0.05 to 0.1 microgram per kg per minute. When you are preparing the infusion, you can give the patient IM epinephrine 500 microgram. We have to escalate the fluid up to 20 to 30 ml per kg. Still, there is no response. We can add an infusion of norepinephrine at the rate of 0.05 to 0.5 microgram per kg per minute, or phenylephrine, that is 10 to 35 microgram per minute. Sometimes there is adrenergic desensitization. Like sometimes there occur desensitization of adrenergic receptors, and that in that case vasopressin is very helpful, because there is the response of epinephrine is not coming because of desensitization. Then we can give vasopressin as bolus once at 2 unit, or we can start the infusion of vasopressin at the rate of 2 unit per hour. We can also add IV glucagon 1 to 2 milligram when patient are using beta blockers. We can consider the use of ECMO whenever it is available. Although epinephrine is a very good bronchodilator because it is a beta-2 agonist, but if persistent bronchospasm is there, we can give inhaled bronchodilators like salbutamol puff can be given. 4 puff can be given, and it has to be repeated after 10 to 15 minutes interval. Each puff contains 100 microgram of salbutamol. We can also consider IV salbutamol, 100 to 200 microgram is recommended, and a continuous infusion of 5 to 25 microgram per minute can also be given. Salbutamol is an ampule which contains 5 milligram in 5 ml. That is, the concentration is 1 milligram per ml. After adequate epinephrine and fluid resuscitation, only after epinephrine and fluid resuscitation, corticosteroids and antihistaminics may be given. This is a case report which I have sent, and we have also encountered a severe anaphylactic reaction to the atracurium in an 18-year-old girl, which came to our OT for emergency nephrotomy and due to intestinal perforation. And as soon as we give atracurium, within 30 seconds of that, there is a sudden drop in the BP, and the BP drops to 70 by 50 mm of Hg, and saturation also dropped from 98% to 70%. Then it further drops to 50%, and we were not able to ventilate the lungs. Then we managed that case by giving IM epinephrine 500 microgram, and we also nebulized the patient with salbutamol. And the case was managed well in the OT, and then we conducted the whole case, and the patient was discharged when on the 10th post-operative day. You can go through this article. So this is adrenaline, and see, its concentration is showing 1 in 1000. That is 1 milligram in 1 ml. That is 1 milligram in 1 ml. But we have to give the dose in microgram, so we have to dilute it. Now what we'll do, we will take 1 ml, that is 1 milligram, and dilute it in 10 ml. That is 0.1 milligram per ml. Now 1 milligram contains 1000 microgram. Then 0.1 milligram contains 100 micrograms. Okay, now you got the dose in micrograms. Also, 0.1 milligram per ml means 1 in 10,000. That is the dose that we have to give in grade 4 reactions. Whenever there is cardiac arrest, we have to give 1 milligram, but the dilution is 1 in 10,000. तो भाई कैसे बनाना है 1 in 10,000? आपने 1 ml लिया एपिनेफ्रिन, 1 ml में एपिनेफ्रिन कितना हुआ 1 मिलीग्राम. आपने उस 1 ml को 10 ml में बना लिया, तो 1 milligram in 10 ml means 1 divided by 10 means 0.1 milligram. अब 1 milligram में कितना है, ये 1 in 10,000 हो गया. ये 1 मिलीग्राम तो आपको ग्रेड 4 में देना है, पर जब माइक्रोग्राम में देना है तो जब आपने 1 को 10 बनाया, दैट इज 0.1 मिलीग्राम बना लिया, और 0.1 मिलीग्राम मीन्स मल्टीप्लाई बाय 1000, तो दैट इज 100 माइक्रोग्राम. ओके, this way we have to calculate the dose. It is very important. Now coming to the conclusion. Perioperative anaphylaxis, as we have seen, mostly it is IgE mediated, but it can be non-IgE mediated also. As in case of atracurium, mivacurium, they are light reactions like grade 1 and 2 reaction. But neuromuscular blocking agents and antibiotics can cause severe anaphylaxis, which is IgE mediated. Management is graded by clinical presentation. As I told you in Ring and Massmer scale, I have told you that scale is very important, and we have to manage it according to that only. The cornerstone of treatment are still adrenaline and IV fluids, and we have to give corticosteroids and antihistaminics only when these adrenaline and fluids has been given and the patient is stable. Tryptase concentration and skin testing are used to retrospectively establish the etiology, to refute or to diagnose the allergy. But their results must be correlated with the clinical history. A comprehensive assessment provides clarity about the culprit drug and safe alternatives, thus ensuring patient safety during future anesthetics. Thank you.
Ma'am, you need to unmute yourself.
I have unmuted.
Thank you, Dr. Gupta.
Thank you, ma'am. Thank you, ma'am, for
wonderful lecture. There is a question in the chat box, Dr. Mansha Kantha, that in the anesthesia practice, is antibiotic as the main cause of anaphylaxis shock or muscle relaxant?
No, muscle relaxant. Muscle relaxant. In various countries, it has been found that sometimes muscle relaxant supersedes, sometimes antibiotics. But most of them, I have read, it is muscle relaxants.
Okay.
Especially, but
yes.
these muscle relaxant cause mild reactions. Sometimes I have also encountered one reaction, ma'am, I have told you. It was a severe anaphylactic reaction with atracurium.
Actually, what happened in the antibiotics, when we give little test dose, then we wait for IV, yes, then we go that. That is the reason, yes, that's why we do not. But muscle relaxant, we have to give it immediately.
Yes,
so we do not know. That is the thing. Dr. Gupta, I will ask you one thing. Is there any pediatric allergic action plan have been done?
Ma'am, pediatric, though I have not seen. And I have not even read about pediatric allergy.
Yes, they are in a plan of the pediatric allergic action plan. What are the first aid they have to do? So that action plan is there also.
Okay.
I think okay. Anyway, okay. However, this is very nice. And Dr. Cipriya, the time management is very good, and it's a wonderful time I am having with you all people. Thank you very much.
Thanks, ma'am. Thanks, ma'am.
Thank you very much. It's really good for the postgraduates. Thank you.
Thanks, ma'am. Thanks. Okay, ma'am.
Thank you so much, ma'am. Thank you so much, ma'am. And thank you, speakers, for such a wonderful lectures. Thank you so much, ma'am, for your time. So let's now move on to our next pop-up lecture on Aldred score, which will be presented by Dr. Sudhanshu Shekhar Nayak. He's Assistant Professor in Department of Anesthesiology, ABVIMS and RML Hospital, New Delhi, and his areas of special interest are critical care and regional anesthesia. Welcome, Dr. Sudhanshu. Over to you.
Good afternoon, everyone. I am Dr. Sudhanshu Sekhar Nayak, Assistant Professor, Department of Anesthesiology, RML Hospital, New Delhi. Today, we are going to discuss about ALDET scoring system. The ALDET score evaluates patient's recovery and readiness for transfer from PACU to surgical ward or second stage recovery area. The time immediately following anesthesia is a critical period and it requires intensive observation. The post-surgical stations are now short-term ICU called post-anesthesia care units or PACU. The PACU is designed and staffed to monitor and care for patients who are recovering from the immediate physiologic effect of anesthesia and surgery. And here, we resuscitate patients who are unstable in PACU, and the PACU provides a tranquil environment for recovery and comfort of patients who are hemodynamically stable. There are different scoring systems used for discharge from PACU: the ALDET score, the simplified post-anesthesia recovery score, post-anesthesia discharge scoring system, the fast track score, discharge criteria tool used by Brown et al., the Danish Society of Anesthesiology and Intensive Care Medicine discharge score, but most commonly used is ALDET score. It was developed by Aldred and Korolik in 1970. The original score assigned a value of 0, 1, 2 to the following 5 criteria or variables like activity, respiration, circulation, consciousness, and color. The total score is 10, that is, score can be from 0 to 10. A minimum score of 9 out of 10 is considered adequate for discharge from PACU. With the advent of pulse oximetry, ALDET score was modified in 1995 to include oxygen saturation. This slide compare ALDET scoring and modified ALDET scoring system. ALDET score comprises 5 criteria: activity, respiration, circulation, consciousness, and color. In activity criteria, when patient able to move 4 extremity, 2 point given. When patient able to move 2 extremity, 1 point given. When patient unable to move extremity, 0 point given. In respiration criteria, when patient able to breathe deeply and cough freely, 2 point given. When patient is dyspneic or having limited breathing, 1 point given. When patient is apneic, 0 point given. When in circulation criteria, when BP is plus minus less than 20% of pre-anesthetic level, 2 point given. When BP plus is plus minus 20 to 49% of pre-anesthetic level, 1 point given. When BP is plus minus more than 50% of pre-anesthesia level, 0 point given. In consciousness criteria, when patient is fully awake, 2 point given. When patient is arousable on calling, 1 point given. When patient not responding, 0 point given. In color criteria, patient having pink color or normal color, 2 point given. When patient is pale, 1 point given. When patient is cyanotic, 0 point given. In modified criteria, the color criteria is replaced by oxygen saturation criteria. When patient able to maintain oxygen saturation more than 92% on room air, 2 point given. When patient need oxygen to maintain O2 saturation more than 90%, 1 point given. When oxygen saturation is less than 92%, even with supplemental oxygen, 0 point given. The advantages of ALDET scoring is simple. It is easy to calculate. It is clinically based and universally accepted. Some limitations are like it does not address common issues in PACU, like temperature, pain, nausea, vomiting, bleeding at incision site, and urine output. Here we'll discuss a case scenario. A 25-year-old female, ASA1 patient with pre of vitals, heart rate 78 per minute, BP 122 and 76 mm mercury, SpO2 100% room air, and she underwent left cholecystectomy under GA, which was uneventful. After smooth activation, she was shifted to PACU, and in PACU, she is conscious, breathing spontaneously, maintaining oxygen saturation of 99% room air, with BP of 128 and 72 mm mercury, and moving all her 4 limbs. So what will be her current modified ALDET score in PACU? Since patient is moving all her 4 limbs, 2 point given. Since patient breathing spontaneously, 2 point given. And since and the BP here is 2% of baseline value, so 2 point given. And patient's oxygen saturation room air is 99%, so 2 point given. and patient is conscious, 2 point given. So total Aldrich score is 10. So here we can shift the patient from PACU to surgical ward. A second case scenario, a 25-year-old female patient of known hypothyroidism controlled with tablet thyroxine 100 microgram OD with pre of blood investigation within normal limits, and she was posted for elective upper limb orthopedic surgery under GA. The pre-op vitals are heart rate 66 per minute, BP 122 and 72 mm mercury, and SpO2 100% in room air. In PACU, she was drowsy but irascible, breathing spontaneously with BP 90 and 54 mm mercury, and maintaining oxygen saturation of 88 in room air, but 97% with oxygen, and moving all her forelimb. So what will be her current modified Aldrich score in PACU? Since moving all her forelimb, 2 point given. But since patient is drowsy but irascible, 1 point given. Since patient breathing spontaneously, 2 point given. And since BP is 28% of baseline, 1 point given here. And since patient is maintaining oxygen saturation 97% with oxygen, but less than 90% in room air, 1 point given. So total Aldrich score here